Hello guys, welcome to Diabetes Chat. We are live and tonight is our World Diabetes Day virtual conference. I hope that you are super excited. We can't wait. We've got such a fantastic lineup of guest speakers and entertainment over the next 6 hours here. And I hope that you're super excited. We're going to hear from so many amazing people from around the world sharing diabetes awareness. And it's just going to be great hearing all the different perspectives. Shall we have a look at what's coming up and how you guys can get involved tonight? So welcome to the conference, World Diabetes Day. You can tune in on our Twitter account at diabetes_chat, and you can see in the pinned post there, we have our live video that you can check out, and you can post along using hashtag DiabetesChat, and we'll bring some of your comments forward to tonight's virtual conference. And also on our YouTube account as well, you can join in the conversation in the live chat box. And I can see loads of people already there. It's great to see you. And we'll get some of your comments up throughout the course of the evening. And we're super, super excited. So if you want to join in tonight, we have lots of things going on, including a prize giveaway. And all you have to do in the chat box on YouTube, type in hashtag DiabetesChat, and you can go into a draw to win, hopefully, one of these amazing prizes that's been donated: a Captain Lance's book, a mini pancreas toy, and 4 VIP tickets to the Overtones Good Times tour. Thank you to the guys for the lovely donations to this prize giveaway. And all you have to do is hashtag DiabetesChat in the YouTube chat box, and you could potentially win one of them prizes tonight. And finally, that's our schedule for tonight. We have 6 hours of amazing things happening here on Diabetes Chat on our virtual conference tonight. Different perspectives. We'll be talking to healthcare professionals, advocates. We've got type 2 chat. We've got a tech chat, a celebrity chat, a global panel chat talking to advocates around the world, a parents chat, live entertainment, and we'll also have our Diabetes Chat kids. I can see Shane in the background, and we'll be seeing him soon in about 15 minutes time. So, wow, what a lineup we've got. I can see so many amazing comments coming through, and we'll get them on our screen shortly. But first, we want to introduce our first speaker for tonight, James Ridgeway. He lives with type 1 diabetes. He's a DSM, and he is an Eden educator. And he has spent some time today recording a video for us guys to highlight and make awareness of the different types of diabetes. And that's what we're doing tonight, showcasing and highlighting and making awareness of all the different types of diabetes. So let's catch up with James and let's learn a little bit more about the different types of diabetes.
Hello, everyone, and welcome to this presentation called Under the Umbrella, which is basically diabetes in 10 minutes. And it's a privilege to be part of this Diabetes Chat World Diabetes Day event. So those that don't know myself, my name's James Ridgeway. I'm a person who lives with type 1 diabetes, and I'm also a diabetes educator for a team called Eden, which is based at the Leicester Diabetes Centre, and also a diabetes specialist nurse for the University Hospitals of Leicester NHS Trust. And what I'm going to do is basically touch upon the different types of diabetes. But first, I wanted to bring up this slide, which I think it's important to remember why we are all here. And November is a special month in the world of diabetes, as we know. Firstly, it's Diabetes Awareness Month, and November the 14th is known as World Diabetes Day. And World Diabetes Day was created in 1991 by the International Diabetes Federation and World Health Organization. And it's there to celebrate the birthday of Sir Frederick Banting, a Canadian surgeon who discovered insulin along with Charles Best, a research assistant, in 1922. But it's important to not forget the important role that John McLeod a professor and endocrinologist at the University of Toronto in Canada, who allowed Banting to use his research facility and offered best to support him in doing so. They first experimented on dogs, then cows, then James Collip, the fourth person, came along, a biochemist, and he made the insulin samples that they produced more safer for humans. They purified it. And then on the 11th of January 1922, so that's 37,197 days ago to be precise, Leonard Thompson, age 14, a young boy, was the first person with diabetes to receive insulin. And what a difference that moment has made to the lives of many millions around the world. So just a kickstart for you there. So diabetes, we're going to kick off now to understand the different types, but diabetes in general refers to a group of diseases that affects how the body uses blood sugar or blood glucose. I define it, the word diabetes, as an umbrella term that can positively connect a community, but yet there are at times it can cause misconceptions and negative presumptions. As you can see on the screen, there are many different types of diabetes, and this doesn't actually show all of them. My aim, though, is to look under the umbrella, under that general term, and inform you on what these particular 8 different types are, and how they are uniquely managed, and why one size really does not fit all. So first is type 1 diabetes, and this, as for many known, is an autoimmune condition. And this is where the body has attacked the insulin-producing cells, which we know are called beta cells. And as a result, natural produced insulin from the pancreas, which we call endogenous insulin, is no longer produced. And therefore, people living with type 1 diabetes need insulin to live, to survive. Insulin is crucial to allow the glucose to go into our cells to provide and be used as energy. It gives us the fuel we need. But sadly, there is no cure for type 1 diabetes yet, but the future does look very promising with advancing technologies such as hybrid closed-loop therapy and a treatment in particular called teplizumab, which is an immunotherapy treatment, also known as Tzield, which can help to delay the development of type 1 diabetes for some people on average by 3 years. And in relevance to the development of type 1 diabetes, most will, well, if not majority, will present with symptoms which we known to be like the 4 T's, which are toilet, urinating more often, especially during the nighttime, first, feeling more thirsty, but it can't be eased, can't be quenched, tired, and thinner. So that's the first one, is type 1 diabetes. Then type 2 diabetes. So this occurs in the majority of people living with that umbrella term diabetes. And this is where the pancreas is still producing insulin, but it's either not very effective or not quite enough. The causes, now they're multifactorial. Yes, people who are overweight and living with obesity, that does have an increased risk, but it's important to think of other risk factors as well. So physical inactivity, genetics, family history of type 2 diabetes, and then some more you can see on the middle row there. So we've got polycystic ovarian syndrome, gestational diabetes, certain ethnicities, and you'll find out another cause as well later, but there are many other causes for type 2 diabetes. We are also seeing an increased number of young people being diagnosed with type 2 diabetes. Partha did a really brilliant blog last week, I think it was, and he brought out a statistic which showed that 4% are now under 40 years of age of the total population of type 2 diabetes. And in comparison to type 1 diabetes, we're seeing more people diagnosed with type 2 between the age of 18 to 40 years. Treatment options are varied and they include diet, physical activity, oral therapies, particularly those with a cardiovascular benefit, non-insulin injectable therapies, and insulin. Again, non-size fits all, really. It's all dependent on what the person is needing at that particular point in time. There is no cure for type 2 diabetes, but you may have heard of the word remission. And this is where the person is able to achieve a HbA1c less than 6.5% under diagnostic threshold, or 42 millimoles per mole, and that's for more than 3 months without the assistance of any glucose-lowering medication. And the most effective strategies known so far are through very low-calorie diets and bariatric surgery as well. So another one I wanted to bring up was type 3C diabetes, a really important one to be aware of, I think, for many people. And this develops when another condition or health circumstance causes damage to the pancreas itself. It might be directly related to the pancreas. So this could be pancreatic cancer, pancreatitis, or pancreatic surgery. It can often be misdiagnosed for other types of diabetes. I tend to see people who've got type 3C that have actually been given a diagnosis of type 2 diabetes. For this type of diabetes, though, insulin treatment is usually the main strategy for this particular type. Gestational diabetes now. So this type of diabetes is one that develops during pregnancy, particularly as the pregnancy advances, usually diagnosed following a test called an oral glucose tolerance test. And usually they're normally provided between week 24 and 28, but some women are offered, who have certain risk factors, a test earlier on in that pregnancy. This type of diabetes usually goes away after birth, and therefore, and all diabetes medication that was used during that time for women who develop gestational diabetes, it tends to be stopped after pregnancy. But the individual is known to be at a higher risk of developing type 2 diabetes, so annual diabetes screening is recommended for these particular individuals. So the next one is, I think, called monogenic diabetes, something which many might not be aware of. It's very rare and often misdiagnosed, and it's caused by a mutation, a change to a single gene, and genes provide instructions to make protein within the cell, and insulin is actually a type of protein. So monogenic diabetes reduces the ability to produce and use insulin. Generally, if a parent has this mutation of a single gene that affects diabetes or causes diabetes, their child has a 50% chance of actually inheriting it. So it's got a strong genetic family history to it, and genetic testing is the best and the only way, really, that is used to diagnose, along with history from the actual individual. Treatment can include lifestyle or glucose lowering medications, and sometimes insulin. So we're going to have a look at some of the two particularly common types of monogenic diabetes, which obviously it's a rare type of diabetes, but common in its rare state. So the first is neonatal diabetes, also known as NDM. It mainly develops in the first 6 to 12 months of life, often mistaken for type 1 diabetes, but type 1 tends to be diagnosed after about 6 months of age. Some will either have a permanent state of NDM. Some, though, may have more of an intermittent one, a transient approach. So it comes and it goes, and it may go on for a while, and then it can reappear. And it tends to be that the individuals affected by this, the newborns that are affected by this, tend to be smaller at birth. But these individuals can still thrive and survive well post birth itself. The next one is MODY. So this stands for mature onset of diabetes of the young, as you can see on your screen. It's usually occurring in adolescence or early adulthood, so usually under the age of 25, and it can often be mistaken for type 1 and type 2 diabetes. Again, genetic testing is required for these individuals to actually give a diagnosis. The main feature with this as well is a typical family history of diabetes that's occurred over a number of generations, particularly, like, for example, grandparent, parents, and child. So when I see a patient who's been diagnosed with type 2 diabetes, I will always ask, what is your family tree like in relation to diabetes? And there's been times where it's led to genetic testing because of a query around whether it could actually be monogenic MODY for certain individuals. The next one then is LADA. Some of you may have heard of this. So this stands for latent autoimmune diabetes of adults, and it shares the features of type 1 and 2. Some people have called it type 1.5 or even slow onset of type 1 diabetes. And that's because, as I said, it's an autoimmune condition, but the destruction of the beta cells, those insulin producing cells, are at a much slower rate compared to type 1 diabetes. So insulin isn't always needed at the start of this type of diabetes, usually after about 6 months or so, sometimes a little bit sooner, which means that initially sometimes just oral glucose lowering medication is required, which was why it can be sometimes mistaken for type 2 diabetes. The key difference is that these individuals, like people with type 1 diabetes, will have positive antibodies. Then the next one is steroid-induced diabetes. So steroids are prescribed for different health reasons. Some of you may have had steroid medication prescribed before. You may have had it for an infection or chemotherapy or pain, and in different forms it can be given as well. And it's usually given for a short period of time. And taking steroids can cause high glucose levels and cause what we call a steroid-induced hyperglycemia. It's usually well treated with sulfonylurea tablet called gliclazide, or some people may need to go onto a certain type of insulin to help manage their glucose levels. When the steroid has stopped or the dose is reduced, then the glucose levels will calm and reduce as well. But for some people, in most cases, people can develop a steroid-induced diabetes. And the last one I wanted to touch upon was cystic fibrosis-related diabetes. This is known, can be termed as CFRD. And cystic fibrosis, as it says there, is a progressive genetic disease that can affect the lungs, pancreas, and other organs. And CFRD, cystic fibrosis-related diabetes, is the most common type of diabetes for people with CF. Around 20% of people with cystic fibrosis have CFRD. It shares the features of both type 1 and type 2. Some people can have an insulin resistance, whereas some people can be deficient of insulin. And particularly this can occur at times where there's stress on the body. So illness, taking steroids, for example, during pregnancy, etc. Insulin treatment is generally recommended for this type of diabetes. So we're at the end of this now. So in conclusion, one size certainly does not fit all. Diabetes is an acceptable term to use as long as the user and the recipient with that word understands that there are many different types, and each type has, I think, an umbrella of its own, as underneath the umbrella itself are many people living with that specific type, each with a different story to tell. And that brings us to the end. So thank you very much for listening. And I'll hand back now to Tom to take you through the rest of this wonderful evening. Thank you very much.
Wow, James, thank you so much for sharing so much awareness for all the different types of diabetes. I thought that was really, really insightful. And there's so many amazing comments in the chat box already. Remember, guys, you can get involved, hashtag DiabetesChat on Twitter and also on our YouTube page as well. And we've put a question out. Feel free to introduce yourselves. What is your name, connection to diabetes, and where you're tuned in from? And already we're getting some lovely comments coming through. And also remember, if you use the hashtag diabeteschat in our YouTube page on our chat box, you could potentially win some amazing prizes, which we'll share more details throughout the course of the evening. Okay, so let's crack on with our speakers tonight. And first of all, we have the Diabetes Chat Kids. And I'm really, really, really excited to welcome Lochlan and Shaun and Max and Tahlia to the Diabetes Chat here. It is a first for Diabetes Chat that we have you guys here live. And I know we spoke last couple of months, and hopefully we will set something up for the new year where we have a mini series of Diabetes Chat Kids talking to you guys. But honestly, thank you so much for coming along tonight and sparing some time with us, because I'm sure you'd rather be playing on your Xbox or whatever rather than speaking to us. But honestly, thank you so much for coming on. So what we'll do is, if you unmute your microphones, because that might be easier, and then you can all talk. So welcome, guys. Everyone okay?
Yep.
Yeah.
Good. So what we're going to do, we've got about 15 minutes. I've got some questions. We'll go around in a circle. We'll have a bit of a topic discussion. So maybe we'll start with Lochlan and Shaun and Tahlia, then Max, and then we can sort of ask the questions and bounce off each other. Tonight, this episode is about just raising awareness for diabetes, talking to you guys, and just getting to know you guys a little bit more. So can you tell me, what is your name, what is your connection to diabetes, and how long have you been living with that particular type of diabetes? Lochlan.
Cool. Hi, I'm Lochlan. I've lived with diabetes for 10 years. I got diagnosed when I was 4. I'm now 14. My connection to diabetes is that I have it, and I've set up my own charity called Lochlan's Legacy.
Brilliant.
My charity is all about raising awareness and releasing stigma around type 1 diabetes.
Brilliant. And where can people go check out the charity, Lochlan? Where can they find out more information about it?
It's on Instagram, TikTok. Just search up Lochlan's Legacy and it should pop
Brilliant.
up.
I don't think I'm cool for TikTok. I just don't know how to work it. I've tried, but I'm just not down with the kids. Shaun, what about you, mate? What's your connection to diabetes?
I've been living with type 1 diabetes for 9 years now. I was diagnosed whenever I was 8, and I've been connected with a few groups down in Derry in Northern Ireland, including the T1 Club, and I would do some work with yourselves, JDRF.
Brilliant. And you got type 1, Shaun?
Yeah, I do.
Type 1, brilliant. Tahlia, hello. What about yourself? What's your connection to diabetes? How long have you been
I've
with
had
diabetes?
it for 6 years, and
You've had it 6 years. Wow.
And my connection to diabetes has been a part of a few things, like Diabetes UK and JDRF.
Brilliant. Hello, Max.
Hi, I'm Max. I've been living with diabetes since I was 2 years old, and I was diagnosed when I was 18 months old.
Brilliant. Well, guys, I think between us, we got about 40 odd years literally living with diabetes between us, or more. And I just think it's amazing that we're all here tonight raising awareness. So great job. What technology do you use then? What technology do you use to help you with your diabetes, to check your levels, or to administer your insulin? Start with you, Lochlan.
Well, I've got the Dexcom G6 and the Omnipod 5.
There we go.
I think it's some of the best technology I've used for a while. It's put my HbA1c down to 51, and I've only been on, and that's my first time in range in the whole 10 years I have in type 1.
Wow.
So it has really helped me, and that I've only been on it since August. So it's not as if I've been on it a while. It's only August, and it's already changed my life to make my diabetes a lot easier to control.
Brilliant. Like quality of life, isn't it? Them sort of things that could just help that little bit more. It's brilliant. What about you, Shane?
I would be using the Libre 2, the AccuCheck Smart or Expert Reader, and then I'd be using the Novo Nordisk Smart Pens to administer insulin.
Brilliant, brilliant. And what do you like about the smart pens? What are smart pens, Shane?
Smart Pens, they're insulin pens that would let you inject yourself and log it onto some sort of I guess log, and you would use it with like Libre 2 or a Dex, and you would scan it on, and it would show whenever you administered your insulin. It shows you on the pen how long ago you administered your insulin, and it's easy. It makes it easier to sort of see if your insulin correction factors are off.
Brilliant. And I've got mine here, and like Shane's explaining, is you can literally press down the memory mode, and I'm not sure if you can see it, but it tells you how many units you've taken and when you last took that. And I don't know about you guys, but have you ever been in a position where you might have forget, or your parents might have forgot to go, did we give that insulin? And having technology like this or things like pumps, it's all there, isn't it? The data's there, and it hopefully helps you guys. It helps us, you know? So yeah, thank you, Shane. Tahlia, what are you using? What technology are you using?
I have Dexcom G6 and I use Omnipod 5.
Oh, nice. And how are you finding the Omnipod 5?
Really good.
Yeah. And what do you like about it the most?
That when I start to go up, it brings me down itself.
Brilliant stuff. So that the technology and the algorithms are helping you guys just have that quality of life. It's really, really helping. What about you, Max? What are you using, buddy?
So now I'm on the Medtronic 780G pump. This helps me because it alarms when I'm high and then alarms when I'm low. But usually when I'm high, it gives insulin by its own. Like I don't even have to put the insulin in myself.
Brilliant. And I think that's great because, like, for me, for instance, guys, is overnight my sort of levels will rise a bit, and the next day I might have sort of dawn phenomena. And having technology like these pumps you guys are talking about, the hybrid closed loop, it's so good because it can help sort of keep your insulin at a sort of steady level overnight and throughout the day. So well done. So what is your go-to hypo treatment? So if you're having a hypo, what would you tend to have for your hypo treatments? Let's start with Max this time, then Tahlia, Shane, then Lochlan. Max, what's your hypo treatment?
So I have orange pure juice. Whenever I'm low, it just brings me up straight away. Like anything else, like snack, it doesn't really bring me up that high, but I enjoy it better than pure orange juice. But I still like the pure orange juice, so that's good.
Yeah, absolutely. It's really helpful to get your levels up quite quickly, isn't it? What about you, Tahlia?
I have lift shots.
Oh, nice. In the little bottles. Brilliant. And I guess the good thing about them is it's there ready for you, so you can just get it off your shelf or in your school bag or wherever you are at home with mum, and you can just use that sort of 30 grams or whatever it is to just take, and you don't have to think about how much you need to take, and then I guess you can 15 minutes later decide if you need more. Whereas for me, at times, if you got like a big bottle of Coke, you sometimes just want to drink more, don't you? So I think having things like that, it's a good tip to have. Brilliant. What about you, Shane?
My usual go-to hypo treatment would be dextro tablets.
Yeah.
And they're just these small sort of chalk tablets.
Yeah. How many would you have if you're on a hypo, or does it just really depend on where your levels are sitting, or is there a standard you kind of go for?
The recommendation would be 4, but usually depends on how severe your low is, or if you've given too much insulin, you might need a bit more. But it's really handy if you're training, or say you do football or weightlifting or anything like that. There, it would be really handy just to
have them to hand, isn't it? It's brilliant. It's great. And like you say, is you've got them tips of knowing to take 4, or you can judge the situation and take more if you need. And these sort of technologies like you guys are talking about is you can see your trends on your phones and things, and you can kind of see where you're going. And then if you need to maybe just take 1 to just keep you sort of afloat, I guess that's great. So well done, Shane. What about you, Lochlan? What's your go-to hypo treatment?
Well, my main one now is dextrose or a bottle of cola. Like if I'm at school and I'm seeing myself dropping, I'll normally, if it's going near lunch, that's what I'll drink during lunch. So I'll have like a bottle of cola during lunch if I'm low. But my main one's dextrose.
Brilliant, brilliant. Thank you, guys. So what one word would you use to describe diabetes? What's the first word that comes to your mind when someone would say, how would you describe diabetes? For me, it might be, it is quite relentless. It's there sort of 24/7. It's a you know what I mean? It's there always. What about you guys? Any sort of words that come to mind that you would describe diabetes?
I would say
Anyone can go. Go on, Lochlan.
life changing.
Life changing. In what aspect?
Well, it's something that not everyone needs to think about, but you need to. So that you've got a different life of live. You've got a different way of living to everyone else. So it's a different in general.
Yeah, absolutely. What about you, Shaun?
I would probably use the word difficult because there's no straight path with having diabetes. It changes day to day, depending on your patterns, depending on how much sleep you have, what you've eaten, the type of food you're eating. It all depends on your day-to-day life, and it's very difficult to have any variety, really.
Absolutely. I totally get it, Shaun, because like we're making 180 decisions a day. There are over 42 factors that can literally decide where our levels are going, up, down, left, right, you name it. And like you say, it could be a factor of sleep. It could be about anything really. And it is really hard. It is difficult. Tahlia, how would you describe diabetes in one word?
Annoying.
Annoying. What do you mean by that? Tell me a bit more.
Like, it's like you always have to have it, and if you want to eat and you're high, you can't.
Oh, that is really annoying when you're really hungry and you might be sitting at a high number and you think, do I want to eat more? That could actually just keep it going high. And it's that thinking, isn't it, all the time of conscious of what you're eating and when you're eating. And like you say, if you are high in that moment, it is difficult and annoying. Max?
I'd say a mixture, because when you're high, you get to do what you want, but then when the bloods come back down, you don't feel yourself. You're a bit tired, and not feeling very well.
Yeah, absolutely. And I love how you guys are talking about the sort of hypers and hypos. Brilliant stuff. To finish then, guys, what superpower would you say your diabetes gives you? What superpower do you think it gives you? What about you, Shaun? So it might be things like resilience, determination, and you can say them words if you want.
I would say more determination, because determination comes with the fact that you want to keep on top of your bloods, but you put that on top of everything else you have to deal with on a day-to-day basis. So it's not your only worry would be your diabetes. It would be other factors that people wouldn't even think about. You know what I mean?
Absolutely, mate. Absolutely. What about you, Lochlan? What's your superpower?
Probably bravery. I don't think I wouldn't say type 1 stops me, so I'm just push on and just get through challenge with challenge every day, and you need to be brave to take on challenges, because sometimes days can become different and you just need to know that you can get through it. So
Absolutely. And I think you guys have been really, really brave tonight in coming on and speaking. I can see so many messages flooding through. And the people that are listening in, please let us know what you think your superpower is. What is your superpower with diabetes? Tahlia, what about you?
I'd say it makes people stronger, because normally when people go to normal doctor's appointments and they have to get needles, not lots of people like needles and they say it hurts, but if you've had pen injection, you do finger pricks, and you've had it for a long time, you just get used to it.
Absolutely. Yeah, definitely. Thank you so much. And Max?
I'd say it'd make you smarter, because when your bloods are in a bad position, you need to know what to do in that position.
Brilliant. Honestly, so thankful for you guys for coming on tonight and literally being type 1 warriors and sharing a little bit about you and your diabetes, telling us about your superpowers. I think you're all amazing people who are doing so many fantastic things, raising awareness for diabetes, and keep up the great work, guys. Thank you so much for coming on tonight. You are my heroes. You are superheroes to me. And I really appreciate you coming on. And we should definitely do more of these next year, right? We should make a mini series of chats with you guys. Definitely. All right. Thank you so much, guys.
Thank you.
Right.
Thanks.
Right.
Thanks, guys. Wow. I thought that was just sensational. I hope that you guys really, really enjoyed that. Our first ever Diabetes Chat Kids. We're seeing so many messages flooding through. We'll have to get them bounced up onto here. And please let us know, what is your superpower with diabetes? You're listening to Diabetes Chat Live. If you're on YouTube, you can comment in the chat box, #DiabetesChat, and you could be in for the chance of winning some amazing prizes. And if you're on Twitter, hello over there on Twitter. So I believe we have our next session. Hello, Kez. Hello.
Hi.
How are you?
Good. All good.
Brilliant. So you are going to host our next session, which I am really, really excited to listen into. I'm going to have a little break in the background, and I'm really excited to hear. I believe we have the guys here. Is that right, Mary? Casey and Santiago, hopefully. But the next session, what is the next session about, Kez?
So it's our poetry and art special. So we're going to be talking to the guys about how they use their art to advocate and share awareness of diabetes.
Brilliant. That is going to be really cool. And it's, we're going to do some live poetry, hopefully, and Santiago is going to share some of his diabetes art. So hopefully we are ready to go. Over to you, Mary.
Hi, good to see you. Thanks for coming to talk to us today. So if it's okay with you, we'll just start off with some introductions so that you can tell everyone a little bit about yourself and your connection to diabetes. So we've got the diabetic survivor here. So if you could introduce yourself and tell us where you're from and what your occupation is to start with, that would be really useful.
Right. Thank you, Kes. Thank you for having me. So my name is Santiago. I was born in Uruguay, but I live in Scotland. And my relation with diabetes, I would say, is all over the place. I work in design on diabetes for a few years now. I have worked in the past with the third sector, so Diabetes UK, for example. I also do like consultant work with diabetes-related companies, and I actually do work nowadays with a digital health company which does things around diabetes. And as you mentioned before, in my spare time, I play with a diabetic survivor, and I try to have a little bit of fun around that and being involved with the diabetes community in that aspect. That will bring definitely DDoc, which I know was in the program a few days ago. And I would say in a nutshell that's my relation with diabetes. Yes.
Okay. So can you tell us a bit? So you mentioned a bit about your artwork and what you're playing around with there. What would you like to share with people about that?
Yep, sure. So I will put my slides here. Right, it's working. Yes, it's working. So something that I will do, I will show some images, and I will try to walk you through them and try to explain a little bit why I did them. This doesn't mean that it's exactly what people will see, but I guess that was my my idea behind. I would say the diabetic survivor since the beginning was more like an accident. So just to bring a little bit of context, I just started doodling on top of a napkin, and my girlfriend at the moment, she say, well, it would be great to share that with people. So that's how I started the Instagram channel, and from there was quite an interesting place to start, because actually it was the people, the community, who started like giving me some ideas to do. So I'm just placing this artwork here because it was the first one, and to me this has quite a special meaning, because it's of course this idea of when we prick our fingers, usually there's a number, but sometimes we feel like judged about those numbers, or we're thinking all the time about being in range, and many of these thoughts that we have in mind of people that we live with diabetes. So this was like I guess like a funny and approachable way of trying to communicate that, and also to laugh a little bit about it. So this idea of being playful, and it's always very light-hearted as well, I would say. Another artwork I have chosen is this one. This one was, as we already know, well, in my case, I do live with diabetes type 1. And to me, it was quite impressive to realize that actually we lack many hormones. It's not only insulin, no? And you know how these hormones also, they affect our mood. So I was trying to show this idea of this battle, no, of our moods, or our swings of moods, when our blood sugar levels are out of range, in a funny way, of course. This one, I would say, is quite self-explaining, but let's say that it's always challenging to go to the bathroom if you have a pump. I know there's some models that are waterproof, not mine, I'm afraid. Next slide. This is one actually that I was showing recently in EHD in Hamburg, and in a panel around stigma. And to me, it was so interesting to see the reaction of the different people with this drawing. I don't know if you're aware, but I have a very vivid memory when I went to the States when I was a child, that there was this pile of socks actually, and this label saying like diabetic socks, which at that time I was not even aware of, diabetic socks, and all the things around it. Of course, is about the circulation and all that stuff, but it's not only. I think this graphics, of course, you can read it that way, like in a literal way, but then we can think about stigma, and these preconceptions on how we look like from the outside, and if we're normal or not. There's an element of the sock as a domestic item, I guess. Everyone is aware what is a sock. Everyone hopefully has a sock as well. And this dialogue between the socks, is a bit of like an open-ended in a way. It brings more questions than answers, but that's exactly the idea about this, about preconceptions. Sorry, I don't. So actually, this is the last slide, which is a bit more like I would say, like a poetic approach to insulin. So as hopefully you can see, it's like a vial, an insulin vial. And I do collaborate with Insulin for All, which from the ones out there that they're not aware of is a campaign of T1 International about granting access or helping people to access insulin and diabetes supplies. And I was thinking about how something so small, or such liquid, could bring so much life, and really how we depend on this, and how literally, if we don't have insulin, maybe we cannot enjoy going out or our lives, and so on. So that's the idea behind about somebody coming from the basement and seeing the sky and the clouds, and this idea of freedom or fresh air. I guess those were the things I wanted to comment, and that's all for me. Thank you very much for giving me the opportunity to show my work.
Oh, that's great. I really like the sock one actually. I think that's my favorite.
Maybe you can tell me what you see actually, because I have like very different answers to that question. How you read the image?
Oh, it's difficult, isn't it? I think it's a bit tricky to see, but I guess like on the outside, everyone kind of looks the same. You wouldn't necessarily know that someone has diabetes, would you, by just looking at them?
Yeah, there's definitely an element of the famous like hidden condition there, and yeah, it's talking to that as well. Yeah, absolutely.
Yeah. So you just you mentioned about the DDoC and DDoC voices briefly. Did you want to just share a little bit about what that is for people who might not know?
Yeah, absolutely. So DDoC is a German community of people with diabetes. Actually, it's an organization that gives the opportunity to people with diabetes or people related with diabetes to go to professional conferences. So these professional conferences in the past, they were always intended for healthcare professionals, researchers, or industry players. And these give us the fantastic opportunity to be there and see a little bit what is going on, that actually although things will not exist without us, right? Because it's not only the research side, it's like the industry side. There's many discussions around, for example, language. That's something recent that came in the last few years. Me personally, I do love technology, so it's always good to see the new research or the new clinical trials around that, and also the possibility of speak there and give your opinion. And sometimes might be, I don't know, could be like a product designer, I don't know, designing any of the sensors we're using now, or somebody maybe creating like a new classification of the condition for a clinic in any place in the world. And if that actually goes, if that, let's say, moves forward, that will have an impact in all of us. But sometimes not necessarily feels that maybe they don't have all the input that we think they should have from us, from the people that are using technologies or systems or healthcare, systems, whatever you want to think about. And so, I mean, to sum up, I will say that I encourage anybody to apply. It's something that anybody can do, and it's a great way of meeting other people with diabetes or related with diabetes, and also a way of getting into diabetes advocacy, which I think is something super important in our community. And well, DiabetesChat is a very good example of that. So yeah, I'm sure if you ask to another DDoC fellow, will have a different opinion, but I'm sure that everybody will think that it's a fantastic experience.
Great, thank you for sharing. So if people wanted to find out a bit more about DDoC and about yourself and what you're doing, how would they find out?
Guess social media. So I mean, just if you place DDoC in any of the usual social media channels, that will pop up. And in my case, the Diabetic Survivor is just how well known, mainly in Instagram. So yeah, that's it.
Okay. Tom, have we got any questions coming through at all? I haven't got the window open, so I can't see, I'm afraid.
We've got some lovely comments coming through. Holly says, the Diabetic Survivor currently on DiabetesChat, showing his artwork inspired by type 1. This work is particularly the sock analogy, because we don't look like diabetic on the outside. And just lovely comments on coming through. Jimmy says, let's have a look. I have a mug with this diabetes sock logo sent to me by Donny. Fantastic, Donny. Martin says they still sell diabetic socks. Did anyone ever get them? I think I might have got a pair when I was first diagnosed. Apparently, diabetic socks.
Well, and how was the experience?
Not good. Yeah, it's probably as on par to diabetic chocolate, maybe. If anyone would have had that back in the day. But thank you so much, Santiago, for coming on tonight and sharing your amazing art. And it's just great, isn't it, Kez, to showcase a different style of advocacy, raising awareness for diabetes through expressive arts, and it's been really, really, really cool to see that and talk to Santiago, the diabetic survivor, hasn't it?
Yeah, it's always good to see what other people are doing, you know, because we come together and we have a chat, but there's definitely something about seeing those other forms, isn't there, out there?
Absolutely. So, guys, I hope that you're enjoying the conference so far. Thank you so much, Kez, for coming on and hosting this section. It's been really, really cool. I'm going to, before we hand over in about 10 minutes to our next section, let's have a look at what's coming up for the rest of the conference and how you guys can get involved. Let's have a look. This one. Here we go. So obviously we are live for our conference. We have we're 1 hour in. We've got another 5 to go. Last year we did 24 hours, but definitely not this year. If you can tune in, you can tune in via Twitter at diabetes_chat. And also you'll see a pinned post there, which has the video, and you can hashtag diabeteschat and get involved in the comments there. And also here on Twitter, you can, on YouTube, sorry, you can join in the live chat if you are there, and you can also subscribe to our channel as well. Prize giveaway, right? We've mentioned this already, and if you want to have a chance to win some amazing prizes, here is your opportunity. Simply, all you have to do in the YouTube chat is type in hashtag diabeteschat in any of your comments. It might just be hashtag diabeteschat. It might be a comment that you're making. Whatever you do throughout the evening, just hashtag diabeteschat, and we will do a giveaway to these amazing prizes later on. I can see 7 entries so far, so we want more to come. So just hashtag diabeteschat on the YouTube chat box, and you could be in for the chance to win Captain Atlantis book by the Captain Atlantis guys. Max was on a few minutes ago. The mini pancreas toy by the lovely Mary. Oh, let's go back. And she's going to be doing that over the next couple of weeks. And Jay James from the Overtones has kindly donated 4 VIP tickets to the current Overtones tour, Good Times. Myself, Claire, and Richard went yesterday, and it was fabulous. And included in the VIP tickets is you will get to see them before the show to say hi and take a photo and enjoy the concert. Absolutely amazing. And if you win that prize, we'll be in touch with you, and you can try and select a date that is good for you, and we can liaise and connect you with the team at My Diabetes Story. So looking ahead for the rest of the conference, we have in a few minutes our type 2 chat, where we'll be talking to Claire, who lives with type 2 diabetes, Mel, who is a healthcare professional and works in diabetes, and hopefully Desmond will be joining us as well to share some of their perspectives of running educational programs to help people living with diabetes. Then at 7:30, we have a tech chat with the Type 1 Diabetes group. Shaun, our good friend Shaun, and the Diabetes group will be hosting a tech chat with the amazing Tim Street and Dr. Emma Wilmot. We have some questions for them, and we also hope that you guys can send some questions as well. And then 8 o'clock, we have a celebrity chat with Jonny Labey, which would be absolutely amazing, hearing his story of diabetes when he was diagnosed and how he manages diabetes being an actor. And you may know Jonny from his time in EastEnders. So that's really exciting. And then 8:30, we have a healthcare professional chat. The DSN Forum ladies and Partha will be joining, and we have Amanda and Beth and Tamsman and Vicky, and like I said, Partha. And we've got some questions that we will be asking the guys and talking about technology as well. And I'm sure some questions will come out from the recent news of hybrid closed loop, and we welcome some questions from you guys as well. And then we have a parent chat from 9:30. We'll be joined by 5 amazing parents. Michelle, our Mary will be hosting. Edelle will be there as well, and Rob and Maddie from DigiBeat will be there, and we'll be talking about the Type 1 club that Shane mentioned before as well. And then we will be having a global chat connecting advocates, amazing people living with diabetes around the world. From 10 p.m. UK time, we have Jazz from India, Renza from Australia, Tino from Zimbabwe, Joanna from the Philippines, and Jean from Ireland. And we'll be talking to them, and Jean will be hosting that section, which will be really cool. And then we have some live entertainment, which is really cool. And we've got Tony, who'll be getting his bass guitar out, and he will be performing some fun live songs for you guys, and guest tunes as well. So that'd be cool. And then an open forum chat to finish the night, where you guys can come chat away with us. Mary, I'm going to bring you up to the screen. I just want to say hi to the amazing Mary, who is working behind the scenes. Hello to you, Mary. How are you? Before we start our next section in a few minutes' time, how are you?
I feel like I've got like kind of dangly things out of my head. Like
no, first and foremost, because I've seen this already because we had a pre-chat. But look at your amazing setup with all your balloons and lights and World Diabetes Day. It's incredible, right?
I know, and I'm wearing my blue top too, so all good.
Amazing. How are you finding tonight's conference already? We've had the Diabetes Chat Kids. We've just had Santiago sharing his diabetes art. Just really, really empowering, isn't it?
Oh, do you know, that one on the toilet was just such a giggle. I use an Omnipod now, but like I did used to have. I have type 1 and have had for 25 years, but I also parented a child with type 1 as well, everyone. And I've had a tube pump and now use a pod, and I forgot about the toilet thing.
Absolutely.
I've missed that one.
I think that would be me. I'm quite clumsy, so yeah, that would be me all day long.
I know, you just forget.
I know. In fact, to be honest, I used to door frame my sensors all the time. Does anyone in the chat let us know if you door frame your sensors? But I used to door frame, but I'm quite good now. Since I've gone into the G6, for some reason, I've been all right. It was when I was on Libra.
You get a sense of awareness about yourself, like, and you forget about it when like seasons change. I think like you're all right until it gets warm, and then you're wearing short sleeves, then you door frame them because you just forget to be aware of them.
Yeah, 100%. So obviously we got an amazing schedule coming up the rest of the evening. You're hosting a parent chat later on. Looking forward to that.
That's gonna be good. That's gonna be nice. Yeah,
absolutely. And talking about the T1 club, we're talking about DigiBeat, and talking about you guys as parents, like looking after the amazing warriors. And that kind of follows the earlier chat that we had just then, about 20 minutes ago, with the Diabetes Chat Kids.
Exactly.
Brilliant stuff. So welcome along, guys, to Diabetes Chat. This is our World Diabetes Day virtual conference 2023. Hope everyone is good. I am Tom. There's my name there. I didn't actually introduce myself, I don't think, when I started. I started Diabetes Chat, founded Diabetes Chat in February 2022, just to talk to people, to connect with people, and I felt after 15 years living with diabetes, I was ready to talk and embrace my diabetes and felt more confident with technology. And I was able to, I wanted to talk, and I set up a Twitter space, and it just really blew my mind, the people that came and chatted, and we had people from all over the world like you guys are tonight, and it was just incredible to hear people's stories and connect and not feel alone and share them lived experiences. And we've had amazing people from all over the world join us with all our weekly chats, with our special events, and tonight it's amazing that we're doing this special event, and I hope that you guys are enjoying it. And I will be checking out some of the comments in a few minutes' time when I jump off the camera. But I'm going to hopefully bring up Gary. Let's bring up Gary to the screen. Hello, Gary.
Hello, Tom. Hello, guys.
How are you, Gary?
other than my computer's decided that it's not going to work, so I've had to jump on my phone. Everything else is fine. This is why meetings are vital to show up to when you're asked to attend, but you're busy and you're like, yeah, I can't do that. So, yeah. But other than that,
Never
everything's
mind.
fine.
You're here in voice. That is the main thing.
Yes. Yes.
But all is good. We have the beautiful Claire and amazing Amelia, and they'll introduce themselves in a minute. But let's have a look at what's happening now. So what we're going to do now, Gary, what's our next session?
So we are now going to be looking at the type 2 perspective of diabetes. So we do understand at DiabetesChat that inclusivity, diabetes is for everyone, this space is for everyone. So we want to ensure that we include everyone in the space. So we are now going to get some perspectives of people living with type 2, people who work with people with type 2, and can I get an understanding on how we go about treatment of type 2 diabetes, the different types of treatment that can be done, and just getting to understand the challenges that people living with type 2 are facing as well. So we are very excited to welcome our guest speakers and get to hear their side and get to hear how they manage the condition or how they help people living with the condition. So yeah, without further ado, I will let the ladies introduce themselves, and then we will get into asking some questions. So whoever wants to go first, certainly feel free, whether it be Claire or whoever.
I'm Claire. I've
Amelia.
been living with
I'll let Claire go
diabetes since I've been living with diabetes type 2 since I was 22. I was diagnosed in 1995.
Hi, I'm Amelia Cook. I'm the clinical lead for diabetes for the Black Country. I've been a DSN for over 20 years, patient advocate, and here to support the patients and the fantastic Diabetes Chat.
So that's great, and thanks for introducing yourselves. So you've already kind of answered the first question, which was what is your name and your connection to diabetes and how long you've lived with the condition. So I'm going to start with yourself, Claire, and we'll bounce back between each other. And Amelia, if you've got anything that you feel you can add into this as well and help and support anybody of that, or like giving some advice, certainly feel free to let us know and just jump in. If I've not asked you a question at that point, just jump in and let me know. But Claire, can you just give us a brief kind of outline of type 2 diabetes? So I think a lot of diabetes, a lot of people understand it, but there's also a lot of misconceptions. So can you just describe what type 2 diabetes is for the people here so that we can all get an understanding of it and understand what it's like to live with diabetes? So yeah.
Okay, type 2 diabetes is that your body either doesn't produce enough insulin or doesn't use the insulin that it produces well enough. It can be treated by diet, can be treated by tablets, can be treated by insulin. It all depends on each individual.
Yeah. And how do you find, Claire, so how do you find living with type 2? Do you feel like you still run the same way I would say I run a normal life? So as we know, I live with type 1. Do you feel like it puts any restrictions on? I know, I understand with type 2 there is, from the understanding I have of it, there is some slight restrictions compared to type 1, depending on how you're treating things. So if you're specifically diet related, there's limiting in things that you're asked, like you can still have everything that you would normally eat, but it's like you can't do what I would do, where if I look at a whole this is going to sound bad, so don't judge me, nobody judge. If I look at a 350 gram bar of chocolate, I can look and see how many carbohydrates are in it and decide if I want to eat that whole bar, to take carbohydrates for that. How is it trying to master with things if you're not on like insulin and that? Do you find it a struggle? Because I understand you're on insulin, but previously I know that insulin just recently happened for you. It's not always been the case. So how do you go about navigating life with type 2?
When I was first diagnosed, I was just told to watch what sugar I ate. So it got to the stage where I didn't want to eat anything, basically.
And I think that's, I think that's a common occurrence, and I hope, Amelia, you'll jump in for this and can I see if it's something that you've heard a lot from people living with diabetes? Because I know, see, when I was first diagnosed, I was told I couldn't eat sweets or anything like that. And I think that's a lot of misconception, and there has been a lot of change recently, but it's still alarming that we have this problem where people don't realise that we can still live a normal life. And I'm wondering, and this can be yourself, Claire, or it can be you, Amelia, or anybody that wants to jump in, do you think there's anything we can do to try and change the opinion of this and what we can or can't eat? Because I know that press has a lot of say on this, and a lot of stigma comes from press as well. So is there anything that we can be doing to advocate ourselves round about this?
I think
it's very difficult. Oh, I'm sorry. Yes, thank you, Claire. I think it's very difficult for patients, to be honest, because some patients are diagnosed with type 2 diabetes and they're already struggling with their weight. So the first thing that the healthcare professional will say is, oh, what are you eating? What types of food are you eating? And I hope that over the years I've been a diabetes nurse that I've actually changed with the times. So in current times now, we don't tell people not to eat certain things. But what we will do is we'll have that conversation around, if you've had a high carb meal, time in range, because I do insulin as well, we'll look at that and discuss doses. So I think Claire's sort of on insulin as well, as she said. So that's changed her sort of goalposts and what she can do. And I know she uses Libra, don't you, Claire?
Yeah.
But a lot of type 2 diabetics, especially newly diagnosed, newly diagnosed, often feel like they can't eat much. And I'll say, well, I'm not allowed bananas, or I'm not allowed grapes, or I'm not allowed some chocolate. And we discuss goals. So we discuss sort of, are you feeling that, your weight's an issue? So some of my patients do have that struggle as well. And we know that struggling with weight is not that simple. It's not one process. It can be lifelong struggles for some people. And we do get people with type 2 diabetes who present slim. So am I going to tell them to lose weight? No, I'm not. I'm going to talk to those patients about the reasons why their diabetes presents and how we can support them to achieve what they need to achieve.
Yeah, and there was a question just put up, and it's something I'm sure everybody living with diabetes, whether it's type 1, type 2, LADA, moody, or anything else in between. And this is specifically more towards you, Amelia, because I know that you're a diabetic specialist nurse, and I would really love to hear your perspective on this. Do you feel that people living with type 2 are given enough support from DSNs and things, in terms of, do you feel that they get the same access to a healthcare team that somebody living with type 1 would get? Because I know that for me, I've got a specific DSN that I can contact. I've got specific people that are my point of contact if there's a problem. Do you feel like sometimes is there room for improvement with maybe type 2 and the management of type 2 and helping support people with type 2, be giving them these direct links rather than just something? And I'm not saying that everybody does it, and just to clarify this, it's not bad mouthing or anything, I don't want anybody to feel that, but do you sometimes feel we just maybe give people with type 2 this big bombard of information and then kind of leave them and let them go, and then nobody really checks in with them, and they're sitting there thinking, I don't know what I'm doing. I've just been given all this vital information and I don't know who to turn to ask for help. Do you feel like there is enough support given to type 2?
I think this might be an opportunity for Julia to come in from Desmond. We've got a plethora of education for patients, but as you say, the education on its own is not what you need. You also need support and ongoing support. So we've got a few NHSC programs at the moment. One of them's total diet replacement, which is like soups and shakes. Now, again, there's a lot of stigma around that, but actually it's giving type 2 diabetes patients an option for not going on to medication if they've been diagnosed in the last 6 years. And I've had some really good positive feedback from patients saying, I thought you were going to offer me a tablet, but you've actually offered me a psychologist and a dietitian for 9 months and a program that's going to support me. So I'm trying to change that stigma around some of the programs that we offer. But also, I think National Health England, NHSE, are recognising this now. And we've got a new type 2 in the young that I've been tweeting about, where we've got a full template and general practice will need to complete that. So things, Gary, I could talk to you all night about things that are not looked at the moment. Things like preconception for young women with type 2 or mental health in men. So there's lots of things that we need to get better at. And we also need to see type 2 diabetes for what it is. It still causes risks to patients and it's still something that we take extremely seriously. It's 90% of my workload in primary care. So I've had to get pretty good at it now. And that rapport with patients is the most important thing. That rapport, those patients knowing they can ring me anytime and I won't judge and I'll try my best to support them. It's difficult. We need to get better at it.
And you know, I will say so I am not from England, I am from Scotland, so I'm NHS Scotland, and I would say it's the same. There is some improvement happening, but when you speak to a lot of type 2s, they know that the NHS know there's still room for improvement, and that's what we love is people like yourself, Amelia, who are coming in and trying to shake it up and say, no, look, we need to support people. Because you can, I just seen a comment up there, somebody saying that's type 2, I'm assuming, is you get a once yearly checkup by your GP and that's it. And you're like, well, what you meant in a year, you're getting 15 minutes with a GP potentially to tell them everything that's happened or tell them everything that's happened in that 1 year span. It's very hard because it's living with diabetes. And I forever say this, and I'm hoping that anybody that's on, like Claire that's on the panel or Tom or anybody will come in and say, it doesn't matter what type you've got, diabetes is diabetes at the end of the day. It's hard enough, never mind not having support, and all these things are very important. And I feel like type 2 people potentially people living with type 2 feel left out because a lot of conversation in the diabetes online community is a lot of people talking about type 1 and not many people voicing about type 2. And I hope that is going to constantly keep changing with bringing this awareness up that type 2 diabetes is just as challenging, if not harder. I would probably put it down harder living with type 2 because there's more restrictions put on you. There's more challenges and I'm not saying that there's greater risks, but when you look at statistics, there is higher risks living with type 2 for people developing complications. And these are all things that are challenging. And when you're doing it, and this is where we need to be able to try and find the peer support for the community to be able to understand that diabetes is diabetes no matter what. We want to support everybody, and that's what I love about DiabetesChat, Tom, Claire, Mary, and everybody that's on the community is we all have that understanding that it's an inclusive environment and everybody should be there, because just because we're living with type 1 doesn't mean that somebody living with type 2 isn't entitled to ask for help, because everybody should be able to ask for it, and we all have the answers. We all can help, and that's what I love about Diabetes Chat. We all get that opportunity to support people living with it and get to greet people like Claire, like yourself, Amelia, like yourself, Julie, who I am going to bring in a minute, because I know that you do Desmond, which I think is I think we call it Bertie here or something, which is, I'm sure it's something like that. So I'm going to get you in a minute, Julia, just to give us an insight into what you do. But Amelia, I just want to say, I love that you are there helping patients, being part of the grassroots cause, shaking up things and saying we need to make this change to be able to help people, but letting your patients and all the people that you're helping know you're there to support them and never judge. And that's what we love to hear, because it is about your specialist, your diabetic specialist nurse, your doctors. They are your peer support as well. So peer support is also coming from a DSN, because that sometimes you phone your DSN and they're the first person that you can get the answer from or get support that you need. So I love that you're doing all this and shaking up the grassroots and basically telling people this is what we need to do to help people living with type 2. And you're showing that it's just as complex and challenging. And Claire, I just want to ask you, before I bring Julia in, Claire, how do you feel hearing somebody saying that they're trying to change the way type 2 is viewed and changing the way that it's treated? Because it is type 2, Claire, I take my hat off to you, and I've said this to you before, I'm sure many a times, that I know how hard it must be, because there is a lot of things that need to go in, and you've also got with type 2, so being on insulin doesn't mean your body doesn't produce insulin. It just doesn't utilise insulin as effectively as it normally would. But as you know, with diabetes, Claire, day by day changes, and sometimes your body might decide one day, I'm going to make insulin work super efficient today, and you take JAGs and you're like, this is not going as the way I planned. And then sometimes it does what we do, where you feel you're injecting water and you're like, why is nothing bringing this number down? How does it feel to have somebody saying that, making these changes and trying to get it so that you don't just get the annual appointments with a doctor who you're trying to ram the whole year of problems in a 15-minute appointment? How does that make you feel?
Hopeful for the future for other people that are diagnosed with type 2.
Yes, and you know, that's what I was hoping for, the word hopeful, because that is what we are. We're hopeful that people like Amelia are making these changes and other people are starting to look, and she's leading by example by saying, this is how we should be treating patients with type 2, not treating them as, oh, this is this and this and this. And I did hear, Amelia, you had said that not every type 2 is to do with dieting and things like that. Some people that get type 2, it's not, and this is a one misconception I want to change. Type 2 is not because somebody ate too much sweets, they've done too much of this, they've done too much of that. Type 2 is because your body has had a reaction. It's basically the starting point of putting this for me is type 2 is your body has had a reaction, and it is attacking the beta cells that produce insulin for you, and it's basically weakening them down. And it doesn't matter, you can be an athlete and be type 2. Type 2 is not caused by diet or lifestyle choices. It is environmental factors and how your body's reacting to the environmental factors. And there's a lot of other things, but I just love the fact that you highlighted type 2 is not a lifestyle choice. It never has been and it never will be. It's something that's happening in your body. It's your body attacking its own natural cells to basically slow down the production insulin. So it doesn't always necessarily stop it, but it's slowing down that production insulin. And I love that at the start of this that you did highlight that it's not actually about what you've ate. There's multiple factors that are all happening in this. And would you agree with that, Amelia?
Partly. I'm just a bit sort of thinking about the fact we haven't got Desmond in yet, and it's a fantastic programme. Bertie is for type 1 for carb counting. Yeah. Yeah. So just quickly to say that type 2 diabetes is caused through multifactorial reasons. It's caused through either beta cell destruction in some patients, as you say, where they've got insulin deficiency, but it also can be insulin resistance. So in a lot of my patients, they're producing a lot of insulin, but the body cells are resistant to that insulin. And there's many reasons for this. It can be central fat store. It can be people who do struggle with their weight as well. It can be genetic. It's 6 or 7 times more common in different ethnic groups like South Asian, Afro-Caribbean, and they can get diabetes at a much slimmer body mass than white people. So there's lots and lots of multifactorial reasons. But you're right, the slimmer type 2s have got insulin beta cell dysfunction, destruction, but resistance is quite a common presenting symptom in terms of these patients have very high sugars and respond very well to things like metformin. Now, we've got a dog on the chat. Sorry. So after Julie's spoken, there's a few questions in the chat about medications, so perhaps we can cover that as well afterwards, Gary. Sorry.
Yeah, definitely, Amelia. So, Julia, eventually getting round to you just to find out a little bit about Desmond and that. So, I think everybody wants to know, can you share what Desmond and My Desmond is and how this all started and any support or resources that are available for people living with type 2 diabetes or for anybody living with diabetes as well?
Yeah, hi. Sorry for the joining the call late. And the reason I've not got my camera on is unfortunately I'm still out and about. I'm currently at a football in my car near a football pitch due to some personal circumstances and having to pick my son up. So I do apologise for not having my camera on, but you wouldn't be able to see me anyway in the dark. Yeah, so Desmond, as it turns out, is 20 years old this year. So Desmond's a type 2 diabetes self-management program that first underwent a research trial all those years ago, 20 years ago. And since then has gone through many different transformations, but the main emphasis and the full goal for Desmond has always been about supporting people with type 2 diabetes to self-manage their condition when they're at home on their own or with their family and not with the always in contact with healthcare professionals, about giving them the tools and the confidence to actually go forward and start to manage their type 2 diabetes independently. And the My Desmond side of it came from the normal Desmond sessions being very much group-based, face-to-face sessions, people coming together and sharing their experiences of how they've been managing their type 2 diabetes. And the My Desmond side of it came from a development around sort of 8 years or so ago, thinking about how to put some of that information into an online program so that people could access that information and some of those tools and as and when they needed to, as and when they wanted to. So whether that was them accessing that information after they'd been to a Desmond face-to-face course, or whether that was accessing it instead of coming to a Desmond face-to-face course. And that's kind of quick recap of what Desmond is in terms of those face-to-face sessions, and then that My Desmond with that online sort of self-management program. And both of those programs are generally referred into via healthcare professionals within areas that have got Desmond commissioned. So they, like I say, they might just commission My Desmond, or they might commission both programs. So really about people making those contacts with their healthcare professionals first, and then having that referral into the Desmond program to help them with that ongoing self-management.
And that's fantastic, and it's great that it's something that's been trialed and tested. It's something that is proven to work. and I've seen a few comments pop up on the screen, and I'm sure it's Mary in the background that's doing all our magic wizard work, about people saying that they think they've actually done Desmond. So it's fantastic that there's people here that have done this course and seen the benefits of it. So can you just let us know, how can people living with type 2 diabetes access the National Education Programme? Do they have to speak to someone? Is it self-referral? Can you point us in the direction of how we can do this?
Yeah, so there's many different services that commission the Desmond programme around the country, can do it slightly differently. So some will have self-referral in, where you might be able to go through a website, put your details down, and then you'd be contacted by the Desmond sort of referral team. Some Desmond sessions run within primary care, within some GP practices, for example, and you might be referred in that way. The best way to find out what is going on in your local area in terms of Desmond is by going onto the Desmond website, which is www.desmond.nhs.uk. And that takes you to like an interactive map where you can sort of type in where you live, or you can use the map to find out what the local site is in your area, and then through that follow the link to their particular details, and that would tell you how to get yourself referred to a Desmond programme. But if in doubt, speaking to your GP or your diabetes nurse or a diabetes specialist nurse at your local hospital is really the key. They should know what is the local service that's commissioned in your area.
And thank you very much for sharing that, because I'm sure there's a lot of people here, and I've seen in the comments a few people saying they done it some time ago, which is probably the same as me. Ours isn't called Desmond, I think, and I'm from Ayrshire and Arn Health Board, so we're called Betty, which is better eating something, I forget what it's called, and that's how long ago I done it. And it's something, some people saying they need refreshers, and I feel like it might be something
it's a performance course for eating, isn't it? Yeah.
So I have seen a few comments, and Amelia, I did see that there was a few people asking about medication. So can you just share how we go about treating type 2? And there was one, but I am going to butcher the name of this because it was Kez that was asking somebody. Peglicesian or something. Can you, I don't know if I'm saying that right. Can you share what that is? Because somebody has put up that it makes you pass fluid, is the best way to describe it, and it brings out excess sugar. How do we go about treating things like type 2 diabetes with that? Is that ultimately what it does?
Yeah, so I'm going to be very quick because I think we've got about 3 minutes left, haven't we? Yeah. To get through this. So basically, the diagnosis of diabetes is done by a HbA1c, and it's 48 or above. So some patients don't know they've got diabetes, so they need 2 blood tests 2 weeks apart. The NICE guidance is diet and lifestyle first, which is where you get all the misconceptions around food sometimes. But that's when I'll be referring to things like Desmond or your local education. So anybody, everybody's from all over, you see. So I work in Black Country. So we refer to Aviva. We've got structured education through those people, and they do online and face-to-face. So metformin is your first line. It suppresses your liver kicking out sugar when it doesn't need to, and it sensitizes your body to its own insulin, and it also has a bit of a glucagon-like peptide effect. So it stimulates insulin production when you're eating. Metformin's been around a long time, over 100 years, I think now, and it's the main staple of diabetes. However, in recent times, we've realised that the group called SGLT2s, or your empagliflozin, canagliflozin, dapagliflozin, this group actually protect your kidneys and your heart. So any patient that's at risk, a Q risk of above 10%, you would be offering them these empagliflozin, dapagliflozin drugs. Now, what they do is they inhibit reabsorption of glucose via the kidneys. They're called SGLT2s. It's the GLUT2 inhibitor. So they put about 300 calories of sugar in your urine, they lower your sodium, and they protect your kidneys. So the guys that have said they're on those, that's a really good call. Then it progresses to third line. And after third line, which is either glycoside, you could use glitazones. Usually, though, the first line would be metformin, then an SGLT2 now because of the amount of evidence around these drugs. After 3 lots of tablets, you're then considering insulin if the patient's HbA1c is going up. And the HbA1c for insulin would be above target, which is 58. I know target's not a good word, but these words need to change. Certainly, if somebody's got a HbA1c of above 70, we would consider insulin. So there's a lot to fit in around type 2, but I'm happy to answer any comments afterwards through. I can't get online with this chat because I'm not very good, but I'm happy to do some via Twitter, or if Tom can help me out because I'm getting old now.
Thank you so much, Amelia, and Desmond. Thank you, Gary, for hosting this amazing segment in tonight's chat. I think it's really important for us to raise awareness for all types of diabetes, and that's what we're doing tonight. And like Gary, you said in the first opening few minutes, you said that we're an inclusive community for all types of diabetes, all connections, parents, carers, you name it, healthcare professionals. And I've learned a lot since starting Diabetes Chat, and it's my mission to continue to raise further awareness for all types of diabetes. And next year, I know Mel, we're working behind the scenes to do more chats on different types of diabetes, and particularly type 2 in your area. But thank you so much, Claire, for your lived experience. Thoughts, Amelia, for your thoughts as a DSN, and Julia sharing from a Desmond educational part. So let's bring up Shaun. And how are you, Shaun? How are you?
I'm good, thank you.
Good. So Shaun is here tonight, guys, from the Diabetes Type 1 group, and it's great that we are working together to raise diabetes awareness today on our Diabetes Chat platform. Thank you so much for everything that you're doing to support the diabetes community. And tonight, you've got 2 amazing guest speakers. I will let you introduce them, and then we'll bring them up to the panel.
Okay, so evening, everybody, and thanks, Tom, for giving us a space here to talk about diabetes tech. Emma, up first. Do you want to introduce yourself, Emma?
Yeah, sure. So my name's Emma Wilmot, and I'm an associate professor at the University of Nottingham and a consultant diabetologist in Derby, where Shaun has very successfully established the Derby T1 Diabetes Peer Support Group. So hats off to you, Shaun. That's been running many years now, and you've done a great job.
Thank you. And next up, we have Tim Street. Tim?
Hi there, everybody. It's Tim here. I am the runner of the Diabetic website, and I have been contributing to the open source DIY artificial pancreas community for the last 6 or 7 years, as well as using that kind of technology. I sit on the Diabetes Technology Network UK, advising the NHS with regard to diabetes technology as well. And apologies, I'm going to just put the camera off for a moment. I'm feeding the dogs as I've just got home from work.
Great being live. So, Emma, if we start with you first, obviously the hot topic of the moment over the last week or so, and for quite a long time building up to that, is the NICE technology appraisal on hybrid closed loops. You've had quite a lot to do with the data gathering on that, and you've obviously seen some in clinic because a few of us have been using it for quite some time. First of all, how excited are you about it, and what are the trends that you see, the positives that you see from those that use it and those in the trial?
Oh, I mean, this is an absolute watershed moment in type 1 diabetes care. You know, I started as a consultant a decade ago, and actually, even if you'd told me that everyone would have access to CGM, I wouldn't have believed that. But now that we've got the door open for hybrid closed loop technology, it's mind-blowing. It's an absolutely amazing development. And, hats off to Partha, who led the NHS England pilot, and our team at ABCD were involved in analysing and publishing the data. And essentially, it shows a staggering improvement in HbA1c, great improvements in time and range, reductions in low blood sugars. But actually, for me, the bit that really made an impact was speaking to people in clinic that came back on hybrid closed loop technology, just saying that this was so life-changing, being able to go to bed at night with the reassurance that your glucose is going to be in range when you wake up in the morning, getting a good night's sleep, being able to do more activity without feeling like you're constantly worrying about hypoglycemia because the system's got your back. The impact is, you can't quite put into words the difference it makes to people living with diabetes. And it's fantastic to see that this will be rolled out. I don't know if we've already covered the recommendations about who will have access, or if you want me to touch upon that now, Shaun.
I haven't heard it covered, so let's go for it, Emma.
Yeah, so essentially, NICE just within the last week have really announced the recommendations, which are suggesting that for people with type 1 diabetes, that they should have access to hybrid closed loop therapy if their HbA1c is above 7.5% in old money, or for those that like new money, 58 millimoles per mole. Those that have got disabling hypoglycemia, those that are pregnant or who are planning pregnancy, and all children and young people in paediatric services. So a large proportion of people living with type 1 diabetes.
Yeah, it's amazing, isn't it? It's going to make a huge difference to many. There's going to be quite a few different options as well, Emma, aren't there, for people to choose, which is good.
Yeah, so I think we're still awaiting final confirmation, because one of the caveats with those recommendations are that they need to be cost-effective systems. So I personally haven't seen a list yet of what those cost-effective systems are, but hopefully that will include all available systems, and that people with diabetes will have choice. But I think we're still waiting on confirmation on that, as far as I understand.
Okay, great stuff. So the big pluses that you see then, HbA1c is coming down significantly.
Yeah, huge reductions in HbA1c of like 18 millimoles per mole. Really, really big, but achieving what people would describe as the best HbA1c they've ever had, but with next to no hypoglycemia, very low rates of hypoglycemia. So for example, for anybody that's listening that's on CGM of some form, the real world data shows that people typically have about 5 or 6% time below range, time in hypoglycemia. When you look at the data from the closed loop systems, this is typically around about 2%, so much lower hypo experience than what you get on multiple daily injections. And let's be honest, hypos are not a nice part of living with diabetes, and anything that can help reduce the amount of hypos you experience has got to be a good thing.
Definitely. And time in range as well.
Yeah, time in range is increased as well. And again, the other thing, just to so people are aware, so some people say to me, oh, I want one of those closed loop things because it will take away my diabetes for me. And what I would say is, at the moment, it certainly doesn't do that. So if you want to get the best out of a closed loop system, you do still need to count the carbs, put that data into the system, and give the bolus at meal times. And again, it needs to be before you eat rather than afterwards to get the best results. So it doesn't take away all the burdens of living with diabetes, but it definitely makes things much easier than it is just with injection therapy. And again, the other thing I would say is, although we're saying this is all great, it is, again, a personal decision. Not everybody living with diabetes wants to have a pump attached to them. And I think, we need to respect that. It's not for everybody, but for those that are really keen to get their HbA1c down, get their time in range up, and are willing to wear extra kit to help them achieve that, then it's going to be an option going forward.
I think it's going to be amazing. I don't know if Tim's with us. He seems to have frozen a little bit at the moment. Are you there, Tim?
I am, yes.
So you've been using closed loop systems for quite some time.
Yep.
Emma's
Since 2016.
I think you'll echo that.
Sorry, so that again, I caught you went all squidgy on me.
Emma's been talking about the huge advantages that she's seen, and I know full well that you've seen those advantages too over the last few years.
Absolutely, yeah. I mean, I started back in 2016 using various open source systems, and
absolutely, I have seen the benefits of it. I mean, I think to have 8 years of consistent time in range in the 80 to 85% mark with far less effort is quite phenomenal, really. And I mean, it's one of those technologies where you get better out of it the more you put into it, but even without that, the data shows that it just makes life hugely easier.
Yeah, brilliant. So you've, through your Diabetic website, Tim, I know you've tried lots of new technology and various pumps and all that sort of thing. What do you think are going to be the key decisions that people are going to have to make before they go on the closed loop system?
So can I change that around a little bit and say the information I think people should be presented with to help them make a decision? One of the key challenges is that all of the algorithms are not the same and they do things in different ways. So for example, it's tremendously helpful if you're about to go onto a closed loop to understand, for example, what your lifestyle is like and then the impact of how that might affect your looping as you're doing it. Because if you're active, there are certain types of closed loop that are perhaps less sensible for you to be using than if you're, say, you have a fairly routine lifestyle that makes life that works in a certain way, and that's going to be probably play a key part in it. I think another thing that's quite important is that you need to be able to understand the human pump interface. By that I mean how it plugs into you and delivers insulin, because one thing that we rarely talk about in relation to technology is the bit that fails the most frequently, and that's the cannulas and also the CGMs. So for me personally, it would be incredibly helpful to be able to try these things, these components of it before we were able to get hold of it. I don't think we're going to get there in the near term, but they are important things to consider because they make a big difference to your experience living with one of these systems.
Yeah, absolutely. Emma, anything to add on to that?
Yeah, I think going in with realistic expectations about what is expected, and I think for me the biggest mindset is about how you keep yourself safe on these systems. At the end of the day, they're insulin pumps only with rapid acting insulin, so the background insulin that people take with injection therapy is no longer there. And for me, the biggest worry is that if you're used to running really high sugar levels and you go across to one of these systems, seeing a glucose of 18 might not worry you, but actually it does really worry me, because seeing a glucose like that on a closed loop system shouldn't be happening very often. And it can potentially mean that your system or your pump's not delivering insulin. But the difficulty is when you've had decades of seeing glucose levels that high and thinking, oh no, I've got my carbs wrong again, or I've not given enough insulin and that's why it's happened. I find a lot of people say it's very difficult to shift the mindset to, instead of, oh, it's all gone wrong again, and I personally have done something wrong, is thinking actually the pump might have been doing something wrong, and making sure that people take safe troubleshooting, check for ketones, change a set, give an injection with a pen, etc., to stay safe.
Do you think that's any different to going onto a pump, Emma?
No, it's not. It's not at all. And I think traditionally people have been nervous about using pumps in people that perhaps wouldn't be as keen to check ketones if things are high, or that we're missing a lot of insulin. I think that's been a challenge to the uptake of pumps. We know from the National Diabetes Audit data that those on a pump that you're less likely to be on a pump if you get very high HbA1c. But I think hybrid closed loop therapy is the opportunity to hopefully make life with technology a bit easier. But the key thing is making sure that people are safe in doing so.
So it's still going to be quite an emphasis on training people as to what to look out for. It's not just a case of, here you go, get on with it.
Yeah, no, exactly. I think we've got huge challenges in the delivery of this because, and in fact, it's funny, the journey that we've been on, if you remember back when Labey first came out and we got recommendations for rider access and everyone's worried about how will we do this and how we'll provide necessary education. Actually getting somebody started on a Libre is absolutely easy peasy straightforward compared to starting somebody on a closed loop system. So yeah, we've really got our challenge out ensuring that we've got enough support for people moving across to the system so that they feel confident and can safely manage that transition.
One of the questions that does come up from time to time in sort of the social media groups is the effect of somebody with a high HbA1c going onto an AID system and then having a rapid lowering of HbA1c levels and the risks associated with retinopathy and linked to that. What's your experience been in clinical practice in relation to it?
Yeah, so it's funny you should mention that. I've actually been reaching out to some national experts on this over recent weeks, because I think it'd be quite useful to have a consensus on what the approach should be. We've known for many decades now that very, very rapid reductions in HbA1c have a low chance, but a potential chance of worsening retinopathy if you've got quite significant retinopathy already. But the ophthalmologist feedback that actually, as long as people are getting monitored, and if there is any progression in retinopathy, it's usually treatable and that can be prevented. And there's absolutely no doubt that sort of 5 years down the line, having a better HbA1c is better for your overall outcomes in terms of retinopathy. I think the key thing is making sure that people are getting monitored more frequently if they do have significant retinopathy and under ophthalmology, for example. The other things to be aware of are the potential for insulin neuritis, which happens rarely, but you can get sort of burning and stinging sensations in the feet as if the glucose levels improve very rapidly, and also insulin edema, where again, if somebody's been running an average glucose of say 25 and then there's a sudden improvement in it, then that can cause sort of swelling just because there's a lot of water retention because the glucose levels have corrected so quickly. So it's just being aware of these things, and I think if possible, it's trying to make sure we support people to improve their HbA1c a bit more on injection therapy before the transition, because even on closed loop, the highest glucose you can set is with CAM APS, which is 11.1. So if you're used to running an average glucose above 20, then even going to that highest 11.1 is quite a drop, isn't it? So, and these are discussions to have in clinic, and it's difficult because on one side, somebody with an average glucose above 20 has got a huge amount to benefit from getting that HbA1c down, but equally on the other side, first do no harm, and we want to support and make sure that that's a safe transition. So these are conversations we're having along the way.
So you touched on it a little bit ago, Emma, about managing expectations. So I guess the next point is that this is going to be a hugely challenging time for healthcare professionals. This is suddenly going to come out there, and the population is going to be expecting to go on a hybrid closed loop system.
Yeah, and I think that is going to be a huge challenge. I mean, to put this in perspective, in 2008, we had the NICE recommendations for insulin pump therapy. Guess what percentage of adults were on pump therapy in the 2022 audit?
12%.
12%. So we have got huge challenges. And actually what's interesting is the uptake of pumps varied from ICB to ICB. Some have got 6% uptake, some have got 18% uptake. So there's also a variation across the patch. And there's also some services that don't feel equipped to deliver that. So we've got huge challenges in terms of delivery, and also huge challenges in terms of equitable provision. For example, we know that those from the most deprived populations, only 9% will be on a pump compared to 14% of the least deprived. We know that 4% of people that are from a Black background are on a pump compared to 12% of white. So the last thing we want this to do is to drive further inequalities. And I think we're going to have to make sure that whatever we do doesn't widen inequalities rather than drive them down.
So in terms of that, is there anything that us diabetics out in the wild can do to prepare, Emma, or to help you guys out?
So I guess the first thing is, if you've got your diabetes appointment coming up, the first thing is to start having a serious think about, first of all, do you think you meet the criteria for hybrid closed loop? So if your HbA1c is above 58, if you're planning pregnancy or you're pregnant, if you've had disabling hypos, or you're a child or young person in paediatric services, then and you meet the criteria, that's the first question. And if the answer is yes, and you think, actually, this is something I think I want to do, or I need more information, it's about finding resources that you can really dig down. What are the systems? What might suit me? And I think lived experience is so powerful. You know, in Derby, we're lucky to have the Derby Type 1 group, and I often say to people, go on there, ask for people's thoughts on the various systems and get a real feel for it. If you think about the amount of research you put into choosing where you're going to live or choosing a car, take that and multiply it, because this is going to be attached to you 24/7 for the next 4 years. So yeah, I'd do your research, look at the company websites. If your local area offers a sort of showcase event where you've got the opportunity to go along and get your hands-on experience with the kit and see the size of it, etc., then that's really useful. And I know Alistair Lum, the chair of the Diabetes Technology Network, myself, Pratik Chowdhury and others have all been working to put together a load of resources to support decision-making around hybrid closed loop, and that will hopefully be going live on the DTN website in the coming weeks, so look out for that as well. So equip yourself with the information, and before your appointment, go in with a list of questions, having done your research, have an idea about what system might suit, so that you can have a really informed discussion at that appointment. Because in my experience at the moment, a lot of people coming into clinic don't even know that there is a NICE technology appraisal, often don't know what a closed loop system is. And I'm spending a lot of the appointment going through the basics of closed loop, never mind going into the detail of what the systems are, etc. So yeah, if you're listening tonight and you think you might meet the criteria, go do some research and come in armed with your list of questions, and we'll do our best to support you.
And I think that's where those of us in the community have a big part to play in helping to educate people about the NICE appraisal being there. So where you are involved in peer-to-peer support groups, where you are a member of, I don't know, a group on Facebook or forums, etc., open up the conversation, discuss the fact that this is coming, that this is around, and this is going to be available to a subset of people, and help people to understand that they should go and investigate if it's something that's interesting to them, because if they don't, I'm not necessarily going to miss out, but it makes it all the more challenging for the limited number of healthcare professionals we have to go through the same process.
And roughly when, Emma, do you think you'll be able to start having conversations in clinic about this? I appreciate it's so hot off the press, you might not know the answer to that yet, but what would be a sensible guess?
What do you mean in terms of offering
in terms of you starting to have conversations with people about hybrid closed loops?
Yeah, well, I mean, we're already doing that, and we've got a huge waiting list of people already, but that waiting list is likely to get longer and longer and longer. I mean, the reality is NICE have estimated that with medium adoption, that's with 37% of eligible people taking up the opportunity for hybrid closed loop, we're looking at 57,000 people. Huge numbers. I mean, to put this in perspective, in Derby, which is one of the large pump services in England, we do about 50 pump starts a year, and we've got over 600 people on pumps.
Wow.
So we have really got our work cut out. There's no additional staffing, as far as I'm aware, coming to deliver this. So we're going to have to really think differently about how we deliver diabetes services to try and free up time to ensure we can get people started on the system and give adequate support to ensure that they feel confident in the use of the system. So yeah, it's a challenge for us as healthcare professionals, because we want to deliver it at the click of our fingers, but that's not going to be possible because we've still got all the other services to continue to run. And it's going to be frustrating for people with diabetes because they're going to be desperate to get hands on this life-changing technology. But the reality is there's going to be a wait. But we are in a brilliant situation, the fact that we've got the technology appraisal that's recommending access. And I think together we just need to think about how we can work to make this happen.
Brilliant. Lots of challenges, but from what we've heard, challenges that are definitely worth working through.
Yeah.
So just broadening it out a little bit, Tim, to what you do. I mean, I've been on your Diabetic website, and there's all sorts of weird and wonderful stuff going on there. Where do you think technology is going to go next? We've got this coming out now, but I'm aware that you trial a lot of different new things that are coming out on the block. Where do you think we're heading with that?
Well, it's interesting because I've just come back from 2 days at the Diabetes Mind data exchange in San Diego, where I was talking about some of the stuff we've been doing in the open source community to remove the need to do any mealtime management. and some of the research projects going on in that area. And this is kind of the next generation of what will happen around artificial pancreas type technology, automated insulin delivery, where using the glucose data, it will signal that a meal has been consumed and that you don't need to do anything. It just deals with it in the background. To some extent, some of the existing tools have features within them to help with that right now. They can't distinguish between a meal and not a meal fully, but they are able to help with poor carb counts and other things like that. And for example, CAN-APS recognizes, based on the pattern recognition it uses, meal times and then how people deal with meal times, and helps to modify that. The 780G, for example, has some features within it that allow it to, again, identify bad carb counts when people are dosing for meals and try and fix those. But interestingly, they look a lot similar to the open source tools than you might think they would. So I think that's probably the next phase in the technology world as to doing that. The other area that was always up for discussion as well is that of multi-hormone type approaches. The jury's a bit out, given the struggles that Islet have had with their dual hormone system. They've done a lot of trials, but they've got nothing into production yet, for a couple of reasons. The main one being it's actually really quite hard. There have also been some trials with dual hormone not using glucagon and using something called pramlintide as well, which is replacing a hormone that we lack as type 1s, which is produced by the beta cells. That would be amylin, and it helps to slow digestion. And the other area that there's a huge amount going on in the US that I wasn't aware quite how much of it is actually prescribing GLP-1s to people with type 1. And that seems to be much bigger over there. So adjunct therapies that are being used quite regularly in type 1 treatment off-label than I think I was aware of. I think the jury's out on the benefit of doing that long-term and the effects of doing that long-term, but it's certainly something that is now going on.
So in 10 years' time, Tim, where are we going to be?
Well, Vertex's VX264 trials will have been successful. They'll be available at a price that's right, and we'll be getting implanted stem cells in a capsule stuck inside our peritoneum. We won't need artificial pancreases, but a technology sitting on the outside. Let's be positive. It's not a cure. It's not a cure, but it's probably the next best thing.
Brilliant. And back to you, Emma. The day when everybody can have a closed loop system, everybody that wants one can have a closed loop system. How far away do you think that will be?
I think that will almost certainly come because, you know, as the years goes by, the technology gets cheaper, more affordable, smaller, more acceptable to people. And I think we will reach that point. I'm not going to put a year on it, though, because who knows? I think in 10 years from now, I'm still going to be delivering this technology appraisal. In fact, I know I am. So because the numbers we have to get through are so huge, but it is going to be the delight of my career being able to support, like being employed to essentially take people on injections and take them to closed loop, and witnessing that absolute transformation in how they feel about their diabetes is amazing. And again, coming back to what we've seen from the pilot, 69% before they went on to closed loop had diabetes distress, and by that they meant they felt overwhelmed by living with diabetes. They felt like they're failing with their diabetes. After moving to the closed loop system, that dropped to 22%. That just gives you some insight into the real difference it makes. And I love my job because my job is basically taking that away from people and making them feel better about their diabetes. So bring it on, cannot wait.
Brilliant. We're nearly out of time. Tom, I don't know if you're there with any other questions.
Such a fantastic chat, guys. Thank you so much. We've had so many lovely comments coming through on Twitter and on YouTube. Let's bring this one up and see if any of the guys can answer it. Has there been any research for type 1s trying to lose weight? Would the hypo version of hypoclusia help with this? What's your thoughts?
Our pilot data showed a very mild increase, like 1 to 2 kilograms in weight. But I agree that there is, because you're not having to stuff your face. Like, for example, for me, a big thing, people come back to clinic and say, I love going for walks now because before I used to have to eat carbohydrates the whole way along, and now I can put on activity mode and the system just keeps me safe, minimal hypo, without need to consume quite as many carbs. So it's a balance, because we know that if you've had a very high HbA1c and you improve it, that you're losing less calories in your urine and you can gain weight. But equally, if the system's allowing you to eat and not have to treat your hypos all the time, then there's a benefit to that. So it's weighing it up and ultimately just trying to exercise as much as you can, eat as healthily as we can, and that stands whether you've got diabetes or not. A challenge for everybody.
I think as an N=1 experiment I've done, can you lose weight with a hybrid closed loop experiments, which I published on Diabetic probably, I think it's 2020. And the answer is yes, you can. It definitely does help with the exercise side of that, and therefore, if you need to lose weight, don't worry about trying. You can be successful doing it.
Yeah, because I like from my own past experience when I'm trying to lose weight and then going to the gym and then having like severe hypos, and it kind of seems like quite pointless. Like I'm trying to lose weight, but then having to treat myself with hypos. So having a technology like this, the algorithms and stuff, hopefully will help. It's not like you say, it's not the cure and everything, but it's that next step to like trying to say like suspend the insulin and put into activity mode and things like that. So thank you so much. Shaun, thank you for hosting this section. It was absolutely fantastic. And thank you, Emma, Wilmot and Tim for coming along and being absolutely brilliant. And yeah, it's been really good. And hopefully people will go away learning a lot. There's lots of people tweeting things and highlighting some of the key topics from your discussions. So thank you so much, guys. It's been great.
Brilliant.
Cheers, guys. See you later. All right. Wow. We are 2 hours into this fantastic World Diabetes Day 2023 virtual conference here on Diabetes Chat or on YouTube, hoping that you guys are having a great time learning lots. Let's have a look at the schedule of tonight. So like I said, we are having our virtual conference for World Diabetes Day. Tuning in, you can tune in on Twitter in the pinned post. You can see the video there, and you can tweet along at diabetes_chat and hashtag diabetes chat. Also here on YouTube as well. We mentioned this a few times already. If you want to be in for a chance to win a prize, we have 3 up to grabs tonight. Thank you to Captain Atlantis for donating the book, and that will be sent out to you. The lovely Mary, who is in the background working on the tech stuff, thank you, Mary, is going to kindly make a mini pancreas toy. And Jay from the Overtones has kindly donated 4 VIP tickets to go to the Overtones Good Times tour. And I can tell you now, it was fantastic because I went yesterday and we were dancing all night long, and you got to see the amazing band, and went for a little VIP guest meet and greet, and you got a picture and a little chat. So all good. And if you win that particular prize, we'll connect you up with the My Diabetes Stories team, and they will look at available dates for you guys to come and have a look. Okay, Mary, can I bring you onto screen for a minute while I just check out our next guest speaker, make sure Jonny's here, and would you just do a quick run through of what is to come for the rest of the evening?
Can you hear me okay? It's yeah, so we've
All
got
good.
a whole all right, we've got a whole lineup for the rest of the evening. It's only 8 o'clock, and we've got great chat going on in YouTube. And don't forget, you can mention on Twitter and hashtag DiabetesChat to get your comments seen. Coming up next, we've got the celebrity chat with Jonny Labey, and then after Jonny, we have a big long chat with the DSN forum and with Professor Partha. It's an insight into healthcare professionals. So those in the chat, it's your opportunity to ask questions that aren't just about your diabetes. It's about their work and what they're interested in. And oh gosh, there I am. And so it's a rare opportunity to ask, and a nice one, because they learn all about us. They know all about us, and we know quite a small amount about what they do. So it's your opportunity. Pop them in the comments, and we'll bring them up. After that chat, we've got, let me see, we have, of course, let me see, it's the parent chat with that I'm hosting, and we have the amazing Digibeat with Maddie and Rob and Michelle, and we've got Edelle from the T1 Club, and we're going to talk about diagnosis times from a parent's perspective, because those of us that have diabetes, how our parents experience that that time is different to what we experience. And so we're going to talk about that a little bit, and about what we do for children, our children that have it's type 1 that our children have. So what we do for them at different stages of their type 1. So we've got different ages. After this chat, then at 10 p.m. we have the global chat, and we've got Jean on with Renza and Tino and Jazz and Joe, and it's going to be a really, I'm going to say it's going to be really insightful. I'm trying to think of a better word. Like, it's going to be interesting. You know, we only really know about our own diabetes worlds, like our own ones, and then our diabetes within the countries we live in. But like type 1 in Africa is so different, and type 2 in those countries that are so different, in other countries is so different. So it'll be interesting, is just to start what it'll be. Then we have at 10:30 we have got live diabetes entertainment. We've got, did I see Tony in the chat? I think I did. So type 1 Tony is playing us some tunes, and that will be fun. So looking forward to that one. And after that session, then we've got our normal open forum, and that will be on from 11 till midnight, where we'll just take comments and chat, and just it's open, and we talk about what we've been talking about. So that's the run for this evening. What do you think so far, Tom?
I think it's been really cool, hasn't it? Like, literally hearing all the different perspectives from all the different people. I really loved I'm going to be just probably go through them all and say I loved all of them, but I really, really loved the Diabetes Chat Kids, because I remember growing up, I was 17, living with diabetes, and I know Shane is close to that age. I think 17, isn't he? And for me at that age, I was very isolated. I didn't want to talk about my diabetes, didn't want to embrace it. And these guys are just so empowering with their confidence and their bravery. And I just love all the advocacy work that they're doing. And I wish, I keep saying many times on Diabetes Chat, I wish I could rewind the time and go back to there, but I'm it's better to be late to the party than not be at the party, and I'm at the party now. And but I think the guys are absolutely great, and I really loved chatting to them. And we had some lovely coming through from other children that were listening in, and really,
I know that one on Twitter, that was lovely.
Yeah. Absolutely. So it's just great, and it's something that we can look to do more on. And then we had the type 2 chat, where we were raising awareness for other types of diabetes, and it was great hearing different perspectives, the lived experience of Claire and the healthcare professional experience, work with children in diabetes care, and then Desmond talking about the educational programs as well.
Yeah, it was a great chat.
Yeah, and we had some great comments coming through community saying that they've been part of these sort of things. So that was great. But it's been really, really interesting. I've just been trying to connect with Jonny. I'm not sure if He's
having
lost
difficulties
connection.
coming
Yeah,
on?
I'm not too sure. So you've got the lovely myself and the fantastic. Let's just, I'm doing the right way.
I feel like I've got blue plaits in
It
my
does,
hair.
yeah,
Like with
yeah.
I know.
So why don't we, while we're waiting, hopefully for Jonny to jump on. If not, you've got myself and Mary for the next 20 minutes. Mary, I'm going to. Why don't we? Have you got your balloon?
I've got my balloon.
Okay. So I'm going to ask you some quick fire questions, and we're going to get our balloons. And when Diabetes Chat go on the road shows to our in-person events, we also talk about the blue balloon in terms of you might have your high moments when the balloon's up in the air, maybe, and when it hits the ground, it's the sort of the low moments in diabetes, whether that's talking about hypos or just the general low moments in itself. And then we talk about on Diabetes Chat in person that when it does hit the ground, it can just bounce back up. It's okay. It might be, and that's in terms of everyday life. You might have not a good day, and then tomorrow's always a new good.
It's not even about the blood sugars.
No, exactly. And as Rose Stewart, that came on Diabetes Chat a few weeks ago, she said, look, you just need to break it down step by step and look at the goal and what you want to achieve, and just trying to go for that goal rather than trying to get up there. It's trying to break it down slowly and hopefully achieve that. So you've got your blue balloon, and you can do a little bit of a challenge here, Mary. I'm going to ask you some quick fire questions, and you can keep the balloon going up. Are you ready, Mary? Should we play the Diabetes Chat theme as well? I love how the back balloons they're all wobbling as well. That's cool. Alison said before we haven't played this yet, the tune. So here we go.
Oh yeah.
Okay, Mary. Oh, I don't know if you heard me there. I think the sound.
I didn't hear you properly. No, hope you didn't.
I think we might have to cut the sound. I don't know why it's gone weird. Anyway, so what is your name, Mary, and what is your connection to the Diabetes Chat team?
Okay, so I am Mary Murphy. I am living in Magherafelt in Northern Ireland. I am a co-host on Diabetes Chat. Is that the question you asked me? It's really hard.
Absolutely, it's hard to try and concentrate while you hit the balloon up in the air.
I know.
When were you diagnosed? Yeah. When were you diagnosed?
Oh man, I was diagnosed in 1997. It was in my first term while studying in Queen's. So yeah, that's me.
And do you finger prick or use technology to check your levels and administer your insulin? What do you use, Mary?
Oh my gosh! See, this week I'm using everything except for I've never used sticks. Well, I have used. No, I didn't know. My sensors are my Libra is just not playing ball at the minute, so I'm scanning. And I have finger pricks because I'm on my second one. I'm actually on my third Libra in 3 days, and
wow.
So I'm going between finger pricks, and I normally DIY loop, and seriously, I'm like putting the finger in the air, going, "What's my blood sugar?"
Why have you been on 3 Libras in the last few days? Are they just sense faults, or this is raising awareness now, isn't it? Showing the realism of diabetes at times.
So I'm also a parent of a teen with type 1. So this started last Monday night, when Johnny's Dexcom transmitter died, and that was kind of all right. Got through that, but then to try and get him back looping, and we were looping with definitely. I don't know what looping would be like with type 2, but I know that looping for our family, it's so worth it when we can get it going. But see, when it's not working, it's just honestly, it's such a stress. You don't realize how chronically stressed diabetes has, whatever type, because lots of the stuff is not about blood sugars. It's about trying to get appointments. It's trying to get the stuff you need. It's trying to get your prescriptions. It's
all them 180 decisions, right?
Yeah, missing your phone. Oh, there's Johnny.
There is Johnny.
Just look at us trying to fill time. Oh man.
You have to come closer, Johnny. We can't hear you much.
Can you not? Oh, it's just this Zoom thing, isn't it? Where am I? Can you hear me?
Have you got a speaker volume?
Give me 1 sec. Maybe headphones.
You can
get your headphones.
You can see that we're live here, guys. Like normally when we do the podcast, we edit all this out, but you can see that we're literally live, raising awareness for diabetes here. Yeah, Jonny will hopefully connect with us in a minute. Thank you, Mary, for helping me fill some time.
You're welcome. You're welcome. Me and my balloon.
You and your balloon.
I'll let you guys get chatting.
Thank you so much, Mary. Hey, Jonny.
Hey, man. Is the audio working?
Yeah, I can hear you. It's a bit quiet, but I think I can hear you. Can Mary? Can you hear Jonny? Okay. I think so. So, Jonny, welcome to Diabetes Chat. How are you, my friend?
Yeah, I'm well, mate. I'm okay. Yeah, I'm good. I'm just sitting around. Actually, I was just sort of working about what to do for Diabetes Day tomorrow. Actually, just
brilliant.
Over it, and then I realised the time. So my slowness and my sincere apologies.
No, not at all. So we got some questions for you, my friend.
Yeah.
So we're going to do some quick questions first, just to get to know you a little bit. So, what is your name and what is your occupation?
My name is Jonny Labey. I'm a doer of all things. I'm a over-busy, creative, busy-minded type 1 diabetic.
Yes.
The creative nature. But in a shorter answer, I'm an actor.
When were you diagnosed with diabetes?
I was diagnosed when I was 15, so just on the cusp of getting into GCSEs and
yes,
just into the sort of time of going off and preparing for college and doing all the things that for most of my life I'd wanted to do, and then got handed a kind of.
And how was that time then, Jonny? Like, obviously you're growing up as a teenager and going through like different sort of hormones and all them sort of things, and then you're preparing for exams and then maybe go to college, university, or you're looking at your career and looking ahead, and then you're diagnosed with diabetes. What symptoms did you have, and what was them times like for you and your parents, I guess?
What was the time like? Do you know what? It was half my life ago. And I'm very fortunate to say that it seems almost like a bit of a distant memory. But I remember at the time the symptoms were all the standard ones. You know, I was just like unbelievably thirsty. I couldn't for the life of me work out why. But you know those big like 2-litre bottles of Evian that you get, you know, like the big sort of like the 2-litre jobs. I would have to carry one of those around with me at school because I just felt like I could never not just be drinking it, you know.
Absolutely. And then would you
honestly be able to finish if I was given the time in between classes? Mentally, I could actually finish the entire 2-litre bottle without even questioning being full.
And I think a lot of people would do that, wouldn't they? They'd have that and then they go to the toilet and then just drink again. Just that vicious cycle of drinking, toilet.
Yeah, and it was, I think then subsequently was going to the loo every, I ended up actually getting chucked out of a French lesson because my French teacher thought that I was doing something that I shouldn't be outside the lesson because I was constantly needing to go outside, and because I drank so much water, I actually ended up just leaving the lesson anyway because I was going to leave a puddle in the classroom and I couldn't quite face the aftermath of that. So I just had to just run out the classroom. She banished me from French for a lesson until she then realised that I was rushed to hospital, and I think she felt quite bad.
You felt a bit guilty at that point, right?
I would feel suspicious too. You know, I would sit down in my chair and I was so embarrassed, and I was thinking, I'm gonna have to go again. I can't do this.
Absolutely.
Yeah, just a feeling of tiredness as well, and my mum wrote a big article about it, actually, like the experience of being a mum and dealing with you know, a broken child in her eyes, or a breaking child, and not knowing what to do as a mother. So
I can
got
imagine.
that whole experience documented, which is
Yeah.
really emotional, actually.
Yeah. We just had a comment through. They said, Tom, could you speak softer? And Jonny, speak a bit louder. You tell we're live.
It's my phone. I'm so sorry. I didn't. It's normally okay. Is it okay like this? If I hold it?
I think so.
Probably not.
I don't know. Who knows? Who knows? I'll try and be a bit quieter. What's your go-to hypo treatments then?
Go-to hypo treatments. Well, I'm now on a pump. So luckily to say, I've got the I'm doing a load of work with them at the moment. I'm doing a load of work with Medtronic, and sort of yeah, I'm on the 780G pump. Oh, hang on a sec. This might solve the issues. It might make it worse. I don't know.
We'll see. We'll see in due course.
Is that better? Can you hear like that? Or has it gone through the speakers? I'm technologically challenged, so I don't know.
I think it's about the same. It doesn't matter. It doesn't matter.
No, it's still in my phone anyway.
So what you're talking about that then, and then do you find you have less hypos then with the technology that you're using than you did before when you're on injections?
Yeah, so it's really changed a lot for me, actually. I rarely get hypos, and I've been in recently to do all the HbA1c checks and things like that, and it's taking some time to rewrite, you know, because my lifestyle's very like inconsistent, man. It's like, you know, juggling with the blue challenge, for example. You know, it is, or it definitely was when I was injecting. It was a huge balance and trying to get that right, and trying to I guess trying to be as hands-on with one thing, because like in performing you really have to just chase, you know, it's a really tough industry.
So what
you
is
have to give your all to it.
So what
I wasn't doing as well with managing.
Yeah.
You know?
So how long have you been on the Medtronic using that?
2 years now. 2 years.
Like, and I've seen on your Instagram page and things like that, you're really a huge advocate for raising awareness for diabetes, and I love the sort of videos that you're posting, raising awareness, and I just think it's great.
Thanks, man. It's someone actually in my class today, because I teach acting as well.
Brilliant.
And she came up to me at the start of the class, and I think she was really expecting a kind of confused response from her teacher. She came up to me and she said, you know, I'm diabetic. She was about to lead on to tell me why she was, you know, maybe not feeling, you know, whatever. And I just went, yeah, me too. And she was like, really? I was not expecting that as a response. And I said, oh no, right. What are you on the pump? And she was like, yeah, well, I was just going to let you know that I've been switched over to the pump. And I was like, oh, are you on the closed loop system? You got the Omnipod? What have you got? She was like, yeah. And I could just, I always find that interaction, I find that interaction the key thing about doing what it is that I want to do, with Know Your Type and all of those platforms, is that it's the kind of hearing it from another diabetic kind of makes it advice that you listen to so much more.
Definitely.
You should obviously listen to
and if you see, I'm sure you see people like walking past and you see people wearing the sensor and you're like, wow, there's someone in the wild, they've got diabetes.
Now, because everyone's got these health things, you know. I'm going up to what they call the Zoe pads or whatever they are.
Yes.
I think we've like coined a fashion statement, which I never thought I'd be able to say.
So can I ask then, how do you find managing your diabetes then, being in the role that you're doing in your career as an actor. How do you find, or how have you found managing diabetes? Do you do it yourself? Do you have a team that are there supporting, checking your levels, or how do you find? Have you ever sort of had any hypos on set, or what's it like being in that position?
There's no team, man. There's no team. There's never a team. You manage what you can, and that's what makes it important to have networks and communities of other diabetics. It's something that I'm going to be developing next year massively, and hopefully the tail end of this year. We're just in the process of setting up a charity, but it's all based around type 1 events, because I used to do a lot of interviews. It got a lot to manage doing it by myself, as well as managing diabetes, as well as doing all the other bits. But I went to a diabetic football match, actually, organised by the brilliant Chris Bright, who you might have spoken to.
Yeah.
He's a great guy. And it was the first time that I'd actually been a part of a team of people that we rocked up to something, and the key focus of the evening was to win the football. So it was all like tactics, we were talking about five-a-side, talking like passing techniques, and like, a 3-2-3 or a 2-1-3, or I don't know.
You sound a pro, Jonny.
Yeah, really. Oh God. Back on the bench was my position. And I it was the first time that the key thing wasn't talking about diabetes, because you go to these evenings where you can talk to other diabetics and you awkwardly just talk about insulin and how you're managing and whatever else. But this was the first time that I was just chilling with a bunch of lads playing football. And then it was only when we got round to eating lunch that I realised my whole team was obviously diabetic, but I'd actually just forgotten that. I just thought that I was just a normal lad rocking up to an event where I'd been oddly invited to come play for a football team.
Did you score?
I didn't score. No, I didn't score. In fact, I think we lost pretty badly. But it was in that spurred me to want to try and do more of those sorts of things. Yeah, so like we're going to be organizing like I don't know, swimming galas, or a lot of like kind of either competitive or community based stuff, whether it's like songwriting or whether it's doing music events, or because you start to realize the more you sort of network out and branch out that there is quite a big community of people in the UK, regardless, that have type 1 diabetes. And
absolutely.
I guess sadly, in another sense, it's getting more and more.
With each passing day,
everyone takes the condition kind of, independently.
Absolutely.
The big help to me was being a part of a group and not making diabetes the focus.
Yeah, absolutely. So
opening
go on.
up with passion, joining people together with passion, but
Definitely.
The focus is really kind of just letting them know that there's this other person that likes what you do, but also
absolutely.
Liking, sharing an interest, and the interest and the common ground not being, a medical condition.
And we talk a lot about that diabetes shouldn't stop you from doing the things you want, isn't it? And that's, I think, the sort of point you're also trying to say is that people can go do other things like football or whatever, and hopefully for a few moments or a few 45 minutes maybe try and forget about it and enjoy and try and be as normal as they can, isn't it? What advice would you?
It was the most glucose stocked up football team that I've ever witnessed.
I bet.
Yeah, man, they had like those glucose tabs sponsored by. We've got bananas, Lucozade.
Happy days.
It was the best game I did, but still,
didn't do too well. It's all about joining in, Jonny. So to finish then, what advice would you give to someone who's watching, whether it's anyone living with diabetes or a child or someone who's obviously looking up to you, Jonny? You're obviously in the public figure and you're an actor and you're doing really well for yourself and a professional. What advice would you give to someone in terms of their diabetes? Any top tips or any thoughts from you? What would you say?
What would I say? In fact, that's exactly what I was just milling over now, because I'm trying to conjure up something to kind of say as a message for diabetes, for Diabetes World Diabetes Day. And a part of me wanted to be very optimistic and very kind of, it's going to be fine and everything's going to be amazing and don't worry, life won't hold you back, and you know it's all going to be you know the positive stuff that we always hear, we always have, but sometimes, and I don't know if it's a kind of sadistic point of view, but sometimes it's nice to hear, because I've always tried to keep such a positive message and such a this, and I'm by no means perfect, you know.
No one is.
And I think that's the shared, and that's the key thing. I think after we've, you know, said adieu, is I might actually just kind of properly open up about how difficult it is actually, but not in a negative way. I think anything at life that's worth working through makes you feel like you've accomplished.
Definitely. And I think
I don't think it's the view of being negative about anything, but it just kind of it's worth the fight. It's worth
absolutely.
It's important not to feel perfect, I think.
Absolutely. Yeah. And you might have heard the tagline, time in happiness, isn't it? So honestly, thank you, Jonny, for stopping by. We look forward to hearing what's next for you. Like you said, some great ideas. And we'll be
and sorry I was late and had all of those sound issues, and
all good.
Thank you for
we've had some messages.
Sainsbury's now and get a blue balloon.
Go. But honestly, thank you so much, Jonny, for stopping by, mate, and we'll catch up again.
Well done for what you do.
Cheers, matey. There we go, guys. Jonny, Labey there. Apologies for the sound technical problems. I think from Jonny's end, we couldn't quite hear him to perfection. But the transcript will be available after the chat, I believe, for the YouTube. So you will be able to hear that. I do apologize, and I appreciate your patience. Hello, Mary. Need your microphone.
Yeah, just popped on as well. Like, so that was lovely, and I'm really sorry about the sound. Just wanted to say that we were trying different things in the background, and it was just one of those things. And Mark mentioned about just one of those kind of glitchy things with what we're using. But.
And I think it just shows, doesn't it? One, we're live, and also it's like with diabetes, like sometimes things work, sometimes things don't work, like technology, and it's just one of them things. But like I said, we do apologize. It will be on the website and the transcripts and all that, so you can go check it back. And it will be a great chat for you guys to go have a look. Just before we bring up the guys, let's just press that slide. So in a few minutes, we are joined by the amazing Amanda, Beth, Tamsin, and Vicky from the DSN forum, and the amazing Partha. We will be having a healthcare professional chat. And if you guys want to join in, please put your comments in the chat box on YouTube or on Twitter, and we'll try and get some of them questions to the panelists. There's been lots going on. I'm sure there are some interesting questions that you've got, but I think to start, we definitely want to do some introductions. Hi, guys.
Hi.
How is everyone? Everyone okay?
Good, thank you.
Good. So welcome to, obviously, Diabetes Chat. We're here today for our World Diabetes Day virtual conference. It's amazing to have you guys. We've had so many fantastic speakers raising lots of awareness of diabetes, talking about different types of diabetes, including type 2 diabetes. We had kids on, and now we've got you guys here. So can you maybe, I see Partha, and I see Vicky, then Amanda and Beth on our screen. Can you maybe start with Partha? Let's go round in a circle. Introduce yourselves to the community that are listening. Who are you? What is your connection to diabetes? What are your current roles?
So, thanks very much for the invite. Amazing effort as ever, Tom. Much more smaller version compared to your 24-hour marathon, right?
When you have two kids, Partha, I'm like, no, my wife won't let me.
Done amazing. So, my name is Partha. I'm a consultant in diabetes. I look after type 1 diabetes. That's my day-to-day job. And obviously, I've got the role as the type 1 lead for the country. It's been, 7 years and a bit since I've been doing it. And a few other things on the way. So that's probably enough about myself.
So I'll get next, shall I? Yeah, so I am Vicky. I am a diabetes specialist nurse. I've been at DSN for 18 years and I have two roles, two day jobs. So day job number one is working for the Eden education team at Leicester Diabetes Centre. And day job number two is DSN in primary care. And then I'm also part of the DSN forum, which is the night job. And yeah, I've been connected within diabetes for a good 18 years. Couldn't imagine doing anything else.
Brilliant. Amanda.
I thought you were going Beth first. I have 3 hats on. I am a diabetes specialist nurse, been a DSN for, about 7 or 8 years. I'm also a parent of my son has type 1 diabetes, and I also live with type 1 diabetes. So I have all the hats.
All the hats. Yes, indeed. And Beth.
Yeah, hi. My name's Beth Vicki. I am a lead diabetes specialist nurse in Wiltshire in the community. I've been in diabetes care now, I think maybe 12 years. I was a practice nurse for a little bit and then went into DSN role. So yeah, that's me. And also like the Amanda and Vicky, also part of the DSN forum team. Just a little heads up, Tamsin can't make it tonight. She's really sorry. She's not feeling very well.
Good.
So
that's fine.
She says hello.
Hello, Tamsin. Best wishes to you. Hoping that everyone's hearing the sound. That's okay. If you have any questions for the guys, remember you can tweet it along or put it in the comments. And also, Beth, it's not on my notes, but I'm going to bring it in. You also have a connection to diabetes as well, because when you were pregnant, would you like to share that? Because tonight's about raising diabetes and all.
Now that so, yeah, my first pregnancy I had gestational diabetes. Didn't with my second, but yeah, my first one I had gestational diabetes. So I'm aware of the whole scribbling blood glucose levels in your diary, and that's coming from a nurse as well. But yeah, I've been there.
Brilliant. So what fascinates you about working in diabetes? Following on the conversation you just said, you're sharing the amount of years that you've been living with diabetes, and I can see you're all fantastic, passionate healthcare professionals. But what really fascinates you about diabetes, and why do you want to help people? What's your thoughts on that? Anyone can go for it and bounce off each other's ideas.
Who wants to go first?
Shall I go first? Mine's totally selfish. No jokes. I have a son with type 1 diabetes, so obviously I'm very biased in wanting to improve things in diabetes. My brother and sister also have type 1 diabetes, so I think that's kind of what got me into it. But I think diabetes, when you do it as a healthcare professional, it's very kind of Marmite subject. Some people really love it, and some people really don't like it very much at all. So we're just those weird people that absolutely love working in diabetes, and there are so many of us that have the passion. I know Partha always talks about passion in your work, and definitely there are so many diabetes healthcare professionals that just have that passion.
Amazing, isn't it?
I think when you're like picking, like diabetes as a specialism kind of fell into my lap because the practice nurse who did it left, and it was like, oh, you're the only one left, you're going to have to do it. And when you're starting out in diabetes, it's like a massive mountain to climb, as I'm sure most of you, but it's like there's so many different types, there's so many different medications, there's so many insulins, there's so many complications to get your head around. So it's huge speciality to learn. So I think, yeah, like it's a bit, that's why maybe it's like Marmite, because you just think, are you ready for that much learning in your career at that time?
And do you find you guys work with all types of people with diabetes? So like we talked about already about type 1, type 2, Modi ladder, like do you find like you've got a mixed bag of patients coming through the door?
Yeah, and I think that's kind of like, it's good to point that out because, you know, everyone's very, at the moment, obviously excited about hybrid closed loops, but that's not the only thing that we do. That's probably 5-10% of our role. So we have to still know about everything that type 2, everything that's going on with that, all the new drugs that are coming out, all the TAs that are coming on associated with those drugs, then we have to know about. So yeah, we've got a lot to kind of keep our heads running with, and every person we see in a clinic will not all have type 1 diabetes. So we have to switch heads constantly.
Yeah, absolutely. Let's bring in Vicky then. Obviously, Vicky, DSM, but also you like say working for Eden and obviously helping educate and train people. I guess that's a big passion for you, is it? Like, and leading back to that question, what fascinates you about diabetes? Is it helping other people out to train them and educate people and raise that awareness, right?
Yeah, totally. And I think good care is underpinned education and training. And in order to have good education and training, you've got to have people who work within diabetes. You've got to, if you're teaching people about it, you've got to work within it. You have to share that clinical insight.
Share that practice.
I guess my initial interest came, it's probably quite different. I was a staff nurse working on a liver transplant unit, and a lot of the people that I looked after had either had a liver transplant or they'd had pancreatic surgery. And I developed my interest because I was looking after these people that then went on to develop diabetes after major surgery. And I just thought, I just want to do more about it. So in the short time that I'm with them on the ward, I can support and help them as much as I can, because they've gone through a life-changing operation. Then they've developed diabetes, and a lot of them had to go on to insulin therapy. So it was a massive thing for them to deal with. And I just wanted to be able to, I guess, help them as best that I could.
Yeah, absolutely. Brilliant. And Partha, what fascinates you about diabetes the most?
It's my job. I mean, I've always said that, and I always say this. I trained to do this, right? And I trained, taxpayers paid my money. I trained as best as I could, and I try and do the best job I can. And I've got a national role, and my role is to get the best thing possible for people with type 1 diabetes, and that's the way I see it. So whatever I do with a lot of passion. It's sort of me in any definition of work or life or thing that I do. So I put the same energy into it, and that's very much it. So it is a job which I enjoy doing.
And obviously you're already active on social media, and I think that's really great, because I know Partha, you've mentioned previously from when I've heard you talk, you say we as patients see our healthcare professionals as at 2% of the time. So having sort of amazing people like yourselves being so active on social media to help people raise awareness by posting things out or doing these sort of events, it's just really, really good. And it's just really nice that you connect with people, especially after like the pandemic and things like that. And maybe we can lead on to briefly, what is the DSN Forum and the Diabetes One-on-One, and where did that all come from? Collectively, you've all worked together in that project. What was your roles in it, and why did you do it? And what was the impact of them initiatives? I know they're still strongly going well for the community supporting.
Should we go DSM Forum first? Okay, so DSM Forum was an idea that I had after going to a conference and not really having anyone to speak to, not having the peer support. We talk about peer support in diabetes, but as healthcare professionals, we didn't really have a peer support group for diabetes specialist nurses. There's many sort of Facebook groups and things for practice nurses, but there wasn't anything for specialists in diabetes. So I set up this Facebook group, and Partha kindly tweeted it, and then we got hundreds of people join. And yeah, so then I got Beth on board, and Vicky and Tamsin. Eventually everybody was involved in it, and it's just grown and grown and grown. And we do it. It's always been a peer support group. That was the main reason for it, because there are some DSNs that work on their own, or in like one or two members in a team, and you've got people doing things up and down the country and it's multiple people doing the same thing. So actually having a place where we can share resources, share things, so we're not duplicating work, we're not wasting lots of time doing things that somebody else has already done. Why reinvent the wheel when we can just share it between ourselves? So that was kind of the idea behind it. And Diabetes 101 was kind of Partha's idea that me and Beth helped with. So Partha, do you want to talk about Diabetes 101?
It's always, the principle is very simple, isn't it? I mean, people always say that, do I always work with people I'm friends with? Not necessarily. I work with people who share my passion. That's as straightforward as that. You don't have to be my friend to do that. If you become a friend along the journey, brilliant. But and to me, passion is half of the battle. I see so many people very intelligent, very clever, very thoughtful, but just doesn't share the passion. And I can tell you they can't change things. So, and I can also tell you there's about gazillions of people more clever than me in the diabetes world, right? But the reason we do make progress is because of the underlying passion. And as you said, the connection we have with the community. And Diabetes 101 was very much that, right? So, we said pandemic, let's get people together. There was people from a mental health background. There was a pharmacist colleague. There was somebody to talk about eyes, retina, the nurses. It was amazing, right? And all we did was reach out to people and say, hey, listen, we're here. It's tough. And everybody did their part. It was a great group effort. And no, it's part of my life during those years, which I was very proud of. And it was fabulous to see how people came together to do it.
And you just saw some comments flash up on the screen, and you can see the impact of these things, these amazing initiatives and communities, and that are helping people during these times and still helping people. And we had a question that came through actually last few days. Are the pediatrics DSN forum members PDSNs? Does that make sense?
Yes, there are definitely PDSNs in the forum.
Brilliant. Super.
Yeah, we have adults, pediatrics, dietitians, midwives. There's all kinds of specialists in diabetes. So yeah, that's why it's nice. Kind of, we all chat and help each other. Pharmacists as well, don't we?
Yeah.
You tend to find PDSNs a lot quieter on social media. We're always looking for some noisy PDSNs on social media, aren't we? we never hunt them down. If you are a noisy PDSN on Twitter, do give us a shout.
Come on, let's talk. Yeah. So what resources have you guys been part of then in terms of the DSN forum and the Diabetes 101? Is there any particular resources that you'd like to highlight? Is anything like
I think
you can signpost to the community?
Yeah, Vicki,
this is your one.
Brilliant. This is your baby.
There's a couple of websites. We've moved all the Diabetes 101 content over to the DSM forum website. So that includes all of the tweetorials we did. So that was kind of short educational elements through Twitter. So we've got all the slides that are available on the DSM forum website on the 101 page. We've got lots of our own DSN forum resources. We're well known for our comparison charts. So we've got CGM1 and insulin and hybrid closed loop. And they are designed for both healthcare professionals, but also people living with diabetes as well. And we've got a whole host of resources on the DSM forum website. Again,
like this one. Like this one, Maddie. Here's one.
Here's one we prepared earlier.
So yeah, we always try and keep our websites up to date. We're forever updating things. We always joke and say it's like version 3,027,000. But so yeah, we try and keep things as up to date as possible.
Yeah. And also, come on, Beth, Amanda, tell us a little bit about the DSN forum that you guys have just hosted last month, right? I'm losing track.
The conference?
Yeah.
Okay, so that was all four of us. That feels like so long ago, doesn't it? It was like 4 weeks ago. But yeah, we did a big conference. This is our first sort of national conference. We had done a tour before where we'd gone from place to place. Well, I went in my little car from place to place to place. And we did like little groups. So we did like a forum tour with like 30 healthcare professionals at each event. But this one was our first big conference. We had something like 250 people sign up in the first 2 weeks of it going on Eventbrite, and we pretty much didn't have a seat in the house. The whole place was full, and they were all specialist diabetes nurses, and a few dietitians and midwives. Yeah, so really good day. We had Partha speaking. We had all the stars, didn't we? We had Helen Murphy about pregnancy. We had a great talk on psychology, psychiatry, and type 1 eating disorders.
Yeah.
What else did we have, Beth? I can't remember now. It's been so long. My talk.
Phil Newland-Jones about a new drug that is out for breast cancer.
Oh, yeah.
Causing hyperglycemia in people that don't have diabetes. So that was really interesting because it's something that at the moment we don't have guidance for. So we spotted these kind of people being given this drug and then referrals coming through. And we were like, oh, we didn't know what to do because there was no guidance and stuff. So we had to kind of had a nice talk about that, which is really interesting. Yeah, so it's really good. A busy day.
Question down there for you.
Oh,
can't social worker. So it's for specialists in diabetes. So if you solely work in diabetes, obviously that's the closed group because, like I said, it's a peer support group for those people that solely work in diabetes. But all of the open things that we do are for everybody. So we have an open Facebook page, we have a Twitter account, we have YouTube, we have podcasts, we have everything else. But the closed group is just a peer support group for specialist nurses.
Brilliant. Thank you so much, guys, for the sort of introduction to tonight. I hope people are listening have got a little insight into who you are, the amazing things that you're doing, talking a bit about Diabetes 101 and DSN. Let's talk a bit about tech and let's bring Mary into our conversation. And this is an opportunity, guys. If you have any questions to Partha, Beth, Vicky, and Amanda, please, you can write it in the comment box. And we will try and get the questions to the guys. But we do have some tech questions because obviously it is quite heavy at the minute. But we also want to make sure that if there's any other questions as well, guys, that please take this opportunity the next 40 minutes to bring your questions forward to the guys. Does that sound all right?
We have a webinar on Wednesday that anyone can attend. So we don't want to give everything away tonight.
We know. We're going to talk maybe about something a little bit different.
We need to know a little bit more about like what is hyperglycemia and not necessarily know every part of the jigsaw, but just to educate people and raise awareness. But Mary, I'll hand to you for this section and I will jump back shortly.
Yeah, so we're really, really acutely aware about the webinar. And Tom, if you find that link to share for like the Eventbrite, just first, because we've got quite a mix of people that are watching and that will watch, and there's a lot of diabetes technology out there that's being used, and we've talked about the different types. James talked about the different types, and Emma and Tim and Shaun all talked about HCL and a little bit of that work. For those that have type 2 in the chat, what tech's out there and that's potentially available for them first? Is there anything, or will there be anything coming in?
Shall I take that? So rather than put the nurses in a difficult position, let me take that. So let's start across the board. So first of all, type 1 diabetes, I'll quickly tackle that because I think there'll be a question which everybody will be wanting to ask. So I'm going to get that out of the way first. So don't worry, ladies. We're not going to take away anything from the conference that's going to happen. One of the big questions that's happened about the closed loop and everything, there's lots and lots of discussions and chatter about it. So the first thing that I'd like to say to everybody, if you haven't heard it from me, it's not true. All right? So that's the first thing I would say. Nobody, bar me and 2 other people, actually know what the plan is, how we're going to do it. So just relax. At the moment, just relax. Everything else is chatter, gossip, conjecture. So don't worry about it. Just relax. The second thing I think that comes through is, what about the ones who have been left out? And we have a plan. We have, just like we have had with Libra and CGM, there is a plan. So keep the faith, keep the trust. That will happen too. And then comes type 2. What is available for type 2? So if you look at the evidence base that has been created by NICE, which is called the NG28, on there, there's very clear guidelines as to who would be eligible for it. Now, there is a fundamental difference as to how NG17 and 18, which is the type 1 side, kids and adults, have been implemented, and how the type 2 has been implemented, but very patchily. And you could call it a bit of a sort of a social experiment, because everybody knows my input in the type 1 side, where I've gone absolutely all guns blazing at it and challenge systems. I always say that that is slightly an unsustainable model, because you need other clinical leaders to step up. You need to do that. I can create the ammo for people. They have to take it into the local system and have that discussion, because I won't be doing this job forever. That's the sort of fundamental thing. So are people with type 2 diabetes eligible for technology? Certain groups certainly are, as backed by NICE, showing it's a cost-effective use, different types of insulin, risk of hypos, etc. So I would encourage those with type 2 on this call to have a look at that NG28, the section on continuous glucose monitors or blood glucose monitoring, and have that conversation with the local clinician as to why they can't access it, okay? Because you're not asking for something which is not in guidelines. That's the way I would approach it. If you've got type 3C, you're eligible for CGM, of course, because of the linkage with type 1 in the sense of the way it behaves. But I think that's the reassurance I want to give to everybody, is that if you have followed the journey, then you must keep the faith, right? And I said this in 2018, that CGM would become standard care for type 1 diabetes. And I can tell you right now, and I've said this a few months ago, so will closed loop, right? So just bear with us, because clinicians also need time to deliver. We're talking to, Vicky, Amanda, Beth, and in spite of their overwhelming happiness, there is also a degree of worry about the pressures they'll be under and what the expectations are, how quickly they'll deliver it.
These are our questions coming up, actually.
Of course it will be, because the NHS, there's only so much people can deliver staff, and thereby comes, and I'll finish with this, is when we talk about priorities, that doesn't mean that we are forgetting the others. What we're saying is we will get to you, but we'll get to you slightly after others. Now, that's a difficult call, always, but everybody can't get it simultaneously. That's the nature of the beast. So, as I said, in a few years, it will become standard care, and you have to keep the faith in the process to get there.
Yeah, thank you for that. And you've kind of placed that lovely, because we want to talk about I have a question down, like to say what is actually hybrid closed loop for those that have type 1 in the chat and that will listen, like just in a
nutshell,
yeah.
All right, I'll tell you the way I describe it to my patients or anybody who comes and sees me. There are 3 parts of type 1 diabetes. 1, you prick your finger, you see a number, you do some mental maths, what the heck to do with the number, give myself glucose, give myself insulin, what am I supposed to do with it? And then you give yourself the insulin through a pen. Modern technology is moving to automating all of them, right? Your finger prick is gone, so number picks up. Your pump is there to deliver it, and a lot of the algorithm in the background are doing the mental maths for you. Not all of it, you still have to input stuff. So the way I explain to people is that those 3 processes, which used to be done all by you, a huge majority of that will now be done by technology. That's the easiest way I can explain it. Science, it sounds a bit like Star Trek, and pretty much not very far off from that. So it's automating the usual things you do day in, day out, and lessening your burden on the mental mathematics. How's that?
Great, perfect. And all the positive and rightly positive press about hybrid closed loop this week was superb. But those in the community, there's a comment that Flipper actually made, and she said, it's all brilliant and it'll start widening access, but it has been reported in the press as these systems are full artificial pancreases and will solve all our issues. And lots of people talked about it across Twitter, and you all will. I remember when I was asking to be put on a pump list, and the professor in the Royal in Belfast said, "This is not the answer to your dreams," and it's kind of similar. Like, and what's your opinions, all of you, about hybrid closed loop, and I'm with NICE guidance too, because maybe I'm asking this question about why you went for NICE guidance, Partha. Like, and it wasn't just guidance, it's a technical appraisal, and it's not even just technical appraisal, it's a multiple technical appraisal. So why, even though it's not perfect, like what is so good about it?
It's the best thing that science can provide at the moment beyond a cure. That's the way I put it, right? It's as straightforward as that. You could argue that DIY can do better, but it's the best thing that science can provide. Everything else we talk about, the complete loop or the actual artificial pancreas, is still not here. So these are, I have noted, and I've noted with interest the comments made, and they're right. But don't forget that what you're doing is by raising the noise. The media has a role. All news is good news. You've got to remember that when you're talking about it, you're raising awareness. When you're raising awareness, it draws eyeballs of politicians and people who will fund, and all that is important. And the media will always report things or pick things which are catchy, right? So you'll see words like science fiction. Artificial pancreas sounds far more dynamic on the ear of the media rather than a hybrid closed loop system. And that's the reason they report it. It's the very annoying narrative that they go, for example, with type 2, which is all we need to do is eat low carbs, right?
Yeah.
It's a problem, but it's an attractive statement because it makes your solution simple. And that's what people are trying to do with the media. So that, I think that's the way you need to look at it. You obviously will say that's not true. Of course we know it's not true. But does it make your life better from where you are? So I think I would say, rather than the media, think about, would it make your life better? And I'll finish with this so the others can sort of give their views. This is the way I see it. If my child had type 1 diabetes, this is what I would like them to be on. So I want everybody else to be on it. When the next thing arrives, if I'm in post, I'll try everything to make sure they have it. That's the way it should work. So this is pretty much the cutting edge of where we are.
Yeah. What about you guys then, Beth? What is your opinion about hybrid closed loop? And if you had the ability to encourage somebody to be on it, like what, even though it's not perfect?
Yeah, I mean, they're amazing. I've seen them do amazing things for people that I've looked after. Definitely off the camp that they don't fix everything. All the people that I have using hybrid closed loops as, patients that I look after still don't, ring me all the time asking, this has gone wrong, what do I do? It's not a kind of thing that we just set someone off with on day one.
This is the interesting bit, actually. Yeah, what are you finding different, like in care with hybrid closed loop for people you look after?
It very much depends on the kind of people. I mean, and this is why I say social media is a bubble. The people using social media, the people accessing this kind of thing, are the ones that are very tech savvy anyway. They tend to be in the know because they're accessing these kind of events and getting in touch with the information. The patients, 80% of the ones that are coming to our clinic are not those kinds of people. They're the ones that need a lot of support. And so we don't put someone on a hybrid closed loop on day one and never see them again. And it's not a case of they don't still need our help. And I think that's the thing that's causing DSN teams a lot of stress at the moment, is it's a lot of the DSNs, you guys, if we start you on a hybrid closed loop and it goes wrong on day 3, you're going to ring the DSN and think the DSN knows what to do. And most of the DSNs don't know what to do at the moment because we haven't had training, and there's a lot of people that need to be upskilled because pumps has always been kept as a kind of specialist kind of thing inside the speciality of diabetes. So there's a lot of things that need to happen, and we can talk about that more on Wednesday, but there's a lot of stuff that needs to happen before the whole floodgates can open for everybody to have hybrid closed loop systems. But yeah, they're amazing. I can't, the quality of life that it gives people back is amazing, and all of the stuff, it's nice to be able to offer things to people that does take away some of the burden of diabetes.
Okay, I think what you're saying about like if something isn't going to plan on day 3, that your DSN doesn't necessarily know how to fix it, but like then there's the patience in working through the solution, like to make it work, because I understand that perspective. See, the challenges like that, are they there with putting somebody on an insulin pump? Because I know with like the TA151, like that hasn't delivered everybody that meets the criteria for it. Is what are the challenges for even putting people on this from your perspective, like so people can understand to be patient. You guys are only people.
I'll quickly give them a couple of points, and then Amanda and Vicky might want to give their views as DSNs. I tell you what, Amanda, why don't you guys go first?
Yeah, I mean, the staffing is an issue, but obviously we don't want to give too much away. We're talking about this on Wednesday, and I noticed there are lots of people in the chat talking about type 2 diabetes as well. So I think we need to probably answer some of those questions as well. But yeah, I think staffing is an issue, training is an issue, funding is an issue, that we don't have a bottomless pit, and you know, some of our diabetes are funded in different ways. Some people get a pot of money, and once the pot is gone, that's it, and so they can only put so many people on per year. Other people have different ways of getting their funding, and they seem to be able to put everyone on it. So it's until we have this structure set and guidance set, which is what, you know, Partha's doing with the NICE guidance. It's very postcode dependent, unfortunately.
Yeah.
Vicky, did you want to join anything before I put in my comments?
Not necessarily with pumps. I mean, I see the majority of people I look after are people with type 2 diabetes. So certainly in my area, we're not using insulin pump therapy in people with type 2 diabetes. But with regard to CGM, again, some of it is down to, a lot of people with type 2 diabetes will be looked after in primary care, and CGM is relatively new for some primary care teams. So it's that knowledge and confidence for them to be able to initiate it and support them. But also we are sometimes governed by, so we have the NICE guidance, but then we have our local formulary guidance as well. So sometimes as healthcare professionals, we're constrained. We would want to give it to everybody who fits that criteria, but sometimes we aren't able to. And that's above our level as specialist nurses. So that can be a little bit frustrating, but you know, so as Amanda says, it's a combination of, you know, endless resources, training and education, and actually the means to be able to do that in which area you're working in.
I'll probably answer that beyond pumps, if I'm honest. So let's take an example of type 2 diabetes, right? There's a drug, has been for some time, which basically protects you from having kidney problems, right? About 70% of type 2 diabetes patients would be eligible for it. About 20% are on it. So here comes your question. Forget about technology. You know, not many patients with type 2 are even aware of that drug. And if I told somebody, hey, listen, there's a drug which actually prevents you from developing kidney problems, do you want to have it? The answer from most people with type 2 is probably going to be, yeah. Why hasn't anybody told me that, right? So there is that. And I don't think we should underestimate the issues that we have with clinicians themselves or the structures that we build, not deliberately. And I'll give you a very good example of that, that we've seen with pumps. So to get a pump, a lot of people put in place that you have to do an education course. Okay, Great. I get it. Makes sense. Of course, you want to be educated and X, Y, and Z. The problem then becomes if you turn around and say, but you can only do the education on my terms, in my place, on my days, and lots of people are leading busy lives and going, well, I can't do that on those days. And the answer from the clinician can't be, well, then that's tough, right? So you can't set up a barrier and then make the barrier so rigid that you open up deprivation gaps. So there is a problem with that. And I think that's something to sort of think about and I think this is why we are being much more careful with the closed loop this time. Want to structure it, want to put the process in place so people can get it more evenly. And I think, you know, there's a question there from about, am I talking about empagliflozin? It actually talks about any gliflozin, right? So lots of SGLT2 inhibitors, there's GLP-1 analogs. We've had big studies come out yesterday showing these ones also reduce your heart attacks and so it depends, right, as to what we're trying to do as a population and where we are as clinicians. That's quite important going forward. So the problem isn't just with technology. The problem is very much across the board.
Yeah. Do you know, we haven't asked yet about that. That's been really helpful. Sorry, and helpful to a lot of people in the chat. We also had a question about what care looks like for different types of diabetes in your clinics, like because we only know our own, and we only know from our perspective. But is it different? Does care look? It does sound stupid, right? Does care look different for different types? But maybe there's similarities. Do you know what I'm trying to ask? What's the same and what's different, maybe, for different types? That's a massive question.
Shall I go? The same, obviously, we're looking at glucose in all types. We're going to be looking at glucose. We're going to be looking at blood pressure. We're going to be looking at cholesterol in all types of foot checks, eye checks, every of those, all those fundamental checks that we do, kidney, all those fundamental checks are going to be the same no matter what type of diabetes you have. There is different types of structured education depending on what type. So people with type 2 diabetes will do a different type of structured education because it's not about carb counting. It's more sort of diet, lifestyle, carb awareness, that kind of thing. Different types are entitled to different things. So like the CGM, for instance, and the hybrid closed loop with your type 1s, obviously that's part of that care. With type 2s, we don't have that. And they have different medications, obviously. So some of, and a lot of our conversations with people with type 2 are not are about their oral medications, and sometimes there's an issue with weight management. So we have lots of conversations about that, because sometimes people with type 2 diabetes, especially if it's quite new, then they might be able to put it into remission. So sometimes we might be referring people to those types of programs, especially if they're young. There's a program at the moment, Type 2 Day. Is it 2 Day? Type 2 Day, Partha, where people under the age of, I'm going to say 40, who have type 2 diabetes can be referred to that program, and that's all about trying to get them into remission if they have type 2 diabetes. So yeah, lots of different things, and I would also say probably sometimes the complications. People with type 2 diabetes sometimes can live with type 2 diabetes for a long time before they get a diagnosis. So sometimes when they come to clinic, they already have complications of diabetes. So we might see things like foot ulcers or kidney issues or something pretty early on in diagnosis, because they've had it for a while without knowing.
I suppose so, like the difference in age, although that is becoming slightly less common, because we do see type 2s diagnosed sometimes at 18 years old now, whereas, you know, and everyone assumes that people with type 1 are diagnosed as a child, but you have like different extremes of age that you then have to care for people during. So you might be looking after, you know, for the younger people, taking them through childbearing age, pregnancy, that kind of thing. And then you've got going to university for maybe the younger people. So, you know, during that age range, you've got end of life palliative care for some patients with both types. So there's lots of things that we have to jump between in our clinical heads that you might, you know, a typical day on triage for me is jumping from, caring for someone that's end of life to then picking up someone who's just found out they're pregnant with type 1, etc. So there's lots of things, because you have to change everything around when someone gets pregnant. Not all medications are licensed for that kind of thing. So yeah, there's lots of things to jump between. Usually type 2 care you might find as well, I mean, Vicky can say more about it, but it's usually type 2 care is more seen within primary care. Type 1 diabetes, usually you'll find it's more with specialist care, secondary care places, but not always. Depends kind of how you manage diabetes and things. But yeah.
But is that numbers wise, or just like, so you mentioned earlier, Beth, right, like maybe 5-10% of your caseload is type 1, and then it's just there's so many.
Much more of my caseload is type 1 diabetes than because I'm in a specialist service, but I don't know what, I guess just type 2 diabetes is just naturally seen more in primary care. So it can be managed very well in primary care for a number of times, and depending on when it gets complex, or if, you know, that person with type 2 diabetes has other complications, they might then be transferred to a specialist to be looked after. But generally, people with type 2 diabetes are seen in primary care.
And
Vicky, who would normally be seen in secondary care then who have like type 2 diabetes?
So in our area, we have what we call an enhanced model of care. So a lot of our GP practices within Leicestershire sort of start insulin initiating in people with
Like
type
a
2
middle
diabetes.
tier?
Sorry?
Is it like a middle tier? Like between
Sort of. It's sort of. I suppose it's sort of based on, so where Partha works, they have the Super 6 model. We have the Super 7 model. I don't quite know where the 7th one came from, but so it's a criteria of
You just want it to be different.
yeah.
Just got one up.
Yeah, a
Special.
criteria of people who would be referred on to specialist services, and then the majority would be managed in primary care. But our GP practices and practice nurses, we deliver the training in Eden, so they come on our training. They are upskilled on how to initiate insulin, start other injectable therapies. So we have that enhanced model of care, but that's not the same everywhere. That's just how our services are designed and delivered. Whereas, you know, where Beth might work or Amanda might work, it may not necessarily be the same. It's the care is still being received, but it depends on who delivers that service. So, you know, somewhere else, it might be that everybody who needs to start on insulin, for example, who has type 2 diabetes would need to be referred to specialist services. That doesn't happen where I work, but obviously, you know, it might happen elsewhere.
Yeah, okay. And what does your day look like, Partha, in clinic then? Do you just see people with type 1, or what does that look like?
No. So I do quite a lot of type 2, actually. I don't talk about it much on social media because it's consumed mostly by type 1. So we have this, we have had a model of care for about 10, 15 years now. And basically, in the hospital, we see only 6 types of diabetes-related things. So there's a lot of type 2 we would see with renal dialysis, foot problems, obviously pregnancy, all of that. We would see there would be a mixture of type 2 and type 1. Then you have the specific type 1 clinics like the technology. And we've got consultants who specialize in each one of those, if that makes sense. So we would all do that. And the way our works, all our type 2s are seen in the community, and our community nurse specialists, we meet with them ever so often to discuss some of these cases that are quite tricky, give some opinions and stuff. So it's a mixed model. It works quite well. And no, there's a fair amount of type 2s we see. We see LADA, we see some mixed pictures where the nurses feel they need to come up and see us. It's fine. So yeah, a big mixture of everything, so to speak. So it's one of those things. Days are variable, Mary, depending on, I've got so many hats. It depends on which hat I'm wearing what day. So yes.
Interesting. There's questions from the community.
Thank you. Yeah, loads of questions coming out. I think it's really interesting conversation. One question coming through is, how do you guys find the impact of data, like seeing obviously CGMs and things like that? Obviously, it helps us guys so we can see like the trends and see where our sugars are. But as healthcare professionals, how does the data help you? Because you've told us already that you've been working in diabetes a fair while between you collectively. But how does it help you guys? Like, how does it help you? But also, how does that then help us? Do you get what I mean?
I'll quickly give that, and I think that probably nurse colleagues would have much more to add than me. I think for me, it's a conversation starter. I think it really is. I think it's mostly for reassurance. I'll have people who would come with a time in range of 10%, and you say, it's all right. We're going to work towards getting you to 15 next time around. Let's see where we're going. It also is a fascinating thing, and I think it's important that I always say this to clinicians, and it's also about the message we have given as clinicians over the years to people with diabetes. You go and ask people, what do you think your blood sugar should be? And what do you mean? And they said, what do you think your blood sugar should be? What do you think we have told you?
4 to 7.
Invariably people go 4 to 7, and you go like, okay, how often? And they were like, what do you mean?
Forever.
And I think then my standard line at that point would be, nobody can do that. And they go like, what do you mean? And I said, forget about people with diabetes. I can't do that. I think it's such an important thing. You can see the relief when you're turning around and saying, you need to be between 4 to 10. And do you know what? 50 is okay. 60 is amazing. 70, oh my God, you're smoking it. And 80, you shouldn't come and see me. I think it's a very important conversation starters, because you're suddenly starting to say to people, so I said, you know, I just told you at 70 you'd be amazing. And they said, yeah. And I go like, but that means 30% you could be outside and you still would be amazing. it's a very different game of conversation you have with people where you're trying to say to them, look, we know you're trying. What I don't like, and I've said this openly to clinical colleagues, is, and I've said this, when you have all this data nowadays, you've been given permission to look into people's lives. That's what you got now. The last thing you do is judge them. You don't go like, what happened last week? Well, last week, maybe, I don't know, maybe you had a really bad time at home, right? So that
Maybe
is
the sensor is wonky.
Exactly. Who knows what happened? So
Yeah.
I think that's the way, for me, data has been such a conversation changer, especially in the adolescent group who really struggle with so much in life, like mental health issues, the social media battles. It is a real game changer conversation. So I like that. I really do like that. And it makes my life much more easier, if I'm honest.
Yeah, I was going to say that. I can't. If someone brings me a blood glucose diary now, I don't have. I don't know what to do with it because I need all the pictures and the colours. But yeah, it's been a total game changer. It's really helps how we manage kind of diabetes and just look much more visual, being able to look at things and manage trends, that kind of thing. Yeah.
Somebody said in the chat earlier about being able to do remote clinics. Having all that data means we don't have to bring people in when they're at work. You can just chat to people on the phone. I haven't done a face-to-face pump start for years because we just don't need to because people do it all online. So yeah, really, really good that we can
I think
do
it's so much safer though. It helps you to make safer decisions, both you and the person that you're seeing, because you know you've got the information there, whereas with your blood glucose monitoring diary, you know, you could have written the number in the wrong box, it might have been at the wrong time of day, it might have, you know, all that kind of stuff
Might have been made up.
You might have done it in the car 5 minutes before your appointment.
Well, who knows? But yeah, so I think I think it can be quite overwhelming at first. There's a lot of data if you're not used to looking at it. But you pick out the bits that, you know, the key bits, that you can learn the other bits later on if you need to. But I do find it difficult to go back to blood glucose monitoring diaries now because I'm used to looking at, you know, CGM traces. So yeah.
But I guess the option is still available for people to use that, isn't it? If that's how they want to do their diabetes care. And I know you guys advocate for that. It's your diabetes, isn't it? You need to do what's right for you, and it's, you guys support that. We had another question through. Let's bring it up. What psychological, emotional well-being support looks like for individuals with diabetes? And I think this is a very big question.
Across types as well.
Yeah, across all types. Yeah, 100%.
A lot of it is about clinicians learning how to speak.
Oh yeah.
I mean, that's my honest opinion, right? We always are very quick to say all we need is more psychologists. Okay, so first of all, we don't have enough psychologists. Second of all, psychologists are not magicians, right? Psychologists are skilled professionals who can try their best, but there's not enough of them. And if you talk to lots and lot of people, and lots of it is about how the interactions with clinicians have been and what has scarred them for their life, by conversations, by judgments, etc. And I've always said this, if you've got 10 minutes with a person in a whole year, the least you can be is nice. The least, right? And there's a lot of clinical colleagues who say sometimes you need tough love. That's nonsense, right? Complete nonsense. It doesn't work, right? So if all clinicians just were nice to people, I can tell you the emotional burden will be far less, especially with all the peer support that's coming through, where the community does tend to look after each other a lot. If clinicians, I'm not saying all of us do it, but a lot of us do it, right? And we know that, we hear that. So if we could get that better, I think so. To the question, what does psychological, emotional well-being support look like for individuals with diabetes? It starts from the letter that goes out. It starts from the time they walk into clinic, seeing the admin, how they are welcomed into clinic, all of it, right? Your email, your contact, they're all important. That's how you change people's psychological, emotional. Not by saying
matters,
not by just saying that, oh, I tell you what, if only I had a psychologist, I would have cracked it. Nonsense. Part of your job is yours. So That's my view as to what it should look like.
Yeah.
Brilliant.
My
Thank you,
favourite
Beth.
that I hear is, especially for those with type 2, just go away and lose weight and come back in 6 months. And it's not that easy. So
No,
just
no.
asking someone to just go away and do that, pop back in 6 months, it's a total load of rubbish. As something that I'm always singing on my hill that I will die on when I do teaching, is because you hear that over and over and over and over again. Oh, low carb, go and do this, go and do that. And it's just, Partha always says it as well. You know, the best diet you can have is one, you know, no one can afford it. It's got to be sustainable, all those kinds of things. So, yeah.
Brilliant. We have 2 final questions coming through before we finish for the night. Do the healthcare professionals ever see a time where diabetes peers with knowledge in looping or hybrid closed loop could help in training to maybe reduce the workload or even speed up the process? I know we talked about had an honest and conversation about training and stuff like that. How can the community help in any of this process? It might be obviously the roadmap may become clearer, Partha and the guys, soon enough. But is any thoughts on that?
There's diabetes educators in the US. Those
Next year. Why not next year? Let's do it. People need to train up. So what do you need? Let's be honest. What do you need? You need people to be assured of the skills of the people, right? You want to make sure they're giving something that is safe. I think if you want to do it, you need to train people up, make sure they're assessed, they're done properly, and then they should be paid for their time. You do it then, and then you have it. That's how you educators work. So lived experience is fantastic. I would be definitely up for that. That's one of the fundamental reasons we are setting up all the peer support groups. If I'm honest, there is a plan behind, because I'd like people to step up and say, well, what is the training you need? Why don't what is it that the nurses need to do or the consultant need to make sure they're assured by this person setting it up? And where does the liability lie? Well, those are going to be important questions, right?
Yeah.
So, but I personally believe, hey, listen, we just don't have staff, right? So at the moment, we are turning around to industry and going, like, can you help us? Okay.
Yeah.
So, yeah, I mean, I think safety, liability, if we can cover those 2 things, why not?
Yeah, I mean, that's the thing. The reps are not all healthcare professionals. They're not nurses. Some of them would have been ex-nurses, but a lot of them are not. They've learned that skill. So definitely.
And people, as we say, living with diabetes are equally the experts in this, isn't it? And I think we continue to work.
It's teaching bad habits, though, isn't it?
Yeah,
I have to stop myself. No, this is how do as I say, not as I do.
Which is why a lot of we get asked clinical questions all the time on Twitter. We can't answer clinical because we don't know the background.
You don't know. No.
And like, you guys won't know as peers that person's kidney function, what that means to their heart failure.
Exactly.
These kinds of things. So we don't, we've trained a lot of time in our job. We're hugely experienced, not to put, but there's a lot of other stuff in the background, which is why we can't just say to someone on Twitter, go and do this with your insulin, because
absolutely. And same with us as a community supporting all types of diabetes on our platform. When people talk about it and share their lived experiences, we may share our experiences and things, but we always bring it back to, we're not healthcare professionals. You need to speak to your team to have them open discussions and see from there, isn't it? But finally, last question from me, I think, Mary, before we finish tonight. Is there any, I think it's been a fantastic chat. We've covered lots and lots and lots. And there will be obviously the DSN forum chat on Wednesday. I'm losing track. I've hardly slept for about a week. I decided to put this conference together, about 2 weeks ago, Mary? So I'm looking forward to getting some sleep.
Fabulously well.
So final question from me is, what's your final message to the communities, the diabetes community, raising awareness for all types of diabetes? What's your final thoughts or message to the people listening or listen back?
Who wants to go first?
I'll go first. I guess, one size, I think Partha said this, I'm stealing your line, one size does not fit all. I know we spend a lot of time, don't we, on social media, and there is a really strong online diabetes community, but not everybody is the same, and it's not just the type of diabetes, but everything else that goes on in your life. You're not the same as the next person, so one size does not fit all, and just remember that everybody's different.
I'd say don't forget to give yourself a break every now and then. Diabetes is difficult to manage, and sometimes we just are too harsh on ourselves, looking for perfection. But like Partha said, 70% is amazing.
Smashing it. Yeah.
And if we can get anywhere close to that, or even if you were at 10% and you made it to 20%, that's an improvement. That's amazing. So don't be so hard on yourself. It's an art, I think. And it takes time to learn how to manage.
No, it does. It does. Go on, Beth.
My little message, I suppose, because we're a DSN and in the DSN forum, just be kind at the moment to DSNs and your teams. Please don't bombard them with, I want a hybrid closed loop tomorrow or this week or next week. It will come, like Partha says, but we are a long way from offering it to everybody. DSNs are trying their hardest, but they are quite stressed and overworked already. So, but yeah, we'll get there. But just a little bit of a, please be nice to your teams because we're trying.
You are. And Partha?
I think I would say be nice to also each other. I think we're in very tough times, everything around us. Also, don't forget about where we are at and compared to the rest of the world. We do quite well comparatively, and a lot of us do work in other countries, and we see where we are. That's not a reason to say that we shouldn't have everything that money can afford. But just be aware of where we are at, and I think looking after each other is very important in these times, and I include everybody. And I've always had this view. I've never believed in silos of patients and professionals. We're all one big diabetes family. We're all trying to do the best that we can, and we'll get it wrong sometimes. And
we're only human.
Yeah, we'll get it wrong. We'll get it wrong, and we'll also get it right. So that's my message.
But we keep working together, isn't it?
Yeah.
Brilliant.
Yeah, I think we're really lucky that diabetes community, we do work really well together, I think, as an MDT. And that's part of also why I love it. The diabetes team is lovely to work in and on social media as well. But compared to other specialities, they don't have
I'm sure there's not a heart failure nurse chat on a Monday night for 20 hours.
I was that's a whole other conversation, about what are other fields of health like? Do you guys have a community? And then you just basically said that you kind of do, like we have our little patient community, and I've said the word patient and shouldn't have, and but it is really special. Diabetes is really special. It's not it's positive and negative.
And we had kids on to conclude. We had kids on at the start of the chat, Diabetes Chat Kids, something that we're going to do next year, and they were talking about their superpowers and how what they've got out of having diabetes, and they were talking about determination and perseverance, and it's given confidence, and it's great that in this hard condition to live with and manage on a daily basis, and like Vicky say, every
and
day
care
is so
for
different.
like you do.
Yeah, it's hard, and we all have busy lives, like we've all said, in jobs and family and stresses and everything. It is really hard and relentless, and it was really empowering hearing the kids talking and being brave and talking. So thank you so much, Partha, Beth, Amanda, Vicky, for coming on. It's been an absolute pleasure.
You're welcome.
And look forward to your conference on Wednesday. Please go check it out. Amanda, give one more plug on it. Go on.
Yeah, please come and join us. We have a whole hour talking about your favourite subject and Partha's favourite subject, hybrid closed loop therapy and the new NICE TA, the Eventbrite. We've actually had 330 people sign up to it so far. Yeah, brilliant. Amazing, isn't it? So go and sign up. It's not going to be live, but we are going to potentially record it if the tech works.
It's live if people join the link.
It's live if people join the link. Yeah,
yes.
if you join the Eventbrite, sorry, it's not going to be live streamed. Usually we go brunching like you are today to YouTube straight away, but we don't want to mess up the tech.
No, thank you so much. I think I hope that tonight has been really helpful. We've had loads of comments coming through. Thank you for your time, guys, and hopefully it gives you a flavour, guys, of Wednesday's chat with the DSN Forum, Partha. But honestly, it's been great. Catch you soon, guys. Thank you.
See you later.
Thanks for having us.
Bye.
See you later.
Cheerio. Bye.
Thank you. Wow. So, guys, let's have a look at where we are on our schedule tonight. Thank you to the healthcare professionals there for their amazing chat. Thank you to Beth and Partha and Amanda and Vicky. It's really, really insightful, and I hope that you a lot from it. There's loads and loads and loads and loads and loads of comments coming through, loads of discussions I can see in the chat, and I'm trying to like look through it while chatting away. I hope that you found that really, really helpful. So I just want to take you back to this slide. How to tune in. If you're just tuning in, you can see us on Twitter on the Diabetes Chat account or hashtag Diabetes Chat. There's so many messages coming through, and in a minute when the next chat comes up, I'm going to go check it out and see all the comments. You can also win some prizes. Woo! The fantastic Captain Atlantis have donated some books, so there's a book going out if you luckily win the draw. Mary has made, or is in the process of making, some mini pancreas toys, so you could win that. That is incredible. And our good friend James from the Overtones has kindly donated 4 VIP tickets to a Good Times tour, which is currently touring, and we'll put you in contact with the team. And you can look at available dates and see if it works out for you. Lots and lots of exciting things. All you have to do is go into YouTube chat and hashtag Diabetes Chat, and you can do it in the comment. You can just write it right now, hashtag Diabetes Chat. You're going to draw, and later on in the open forum, we'll do a little prize draw, and we'll see who wins. Okay, so let's have a look at our next speakers. Mary, I can see Michelle, so let's bring up Michelle and Edelle. Hello, hello, hello.
Hello.
How are you guys?
We're good, thank you. Great.
Good,
This is
good.
like a social event, Donna. This is brilliant. I have had a ball watching this. Well done to you all. It's brilliant.
Oh,
It's brilliant.
bless you.
So good. So
Thank you,
good.
guys.
Yeah, and I love that last session as well. Really good.
Really, really good, wasn't it? And we've seen,
It was brilliant.
and we've seen so many people tweet along, and I've seen some people actually watching tonight's Diabetes Chat World Diabetes Conference on like big TVs, and it's like my head's big enough. Never mind on a big TV. So
From what was it, Twitter Space last year to 24 hours. At least we've reduced it to 6
yeah,
hours.
I've reduced
and
it.
screens now. Yeah.
Yeah,
Like
exactly,
learn to
exactly.
learn to lesson doing 6 hours instead of 24. You know.
Absolutely, absolutely. Yeah. And last year we did audio, and this we're doing video, bringing it a different style. So I will jump off, and I will leave you with the lovely Mary. I do believe Maddie and Rob will be joining us soon, hopefully, from
They
PTB.
are. I can just see. I think they might be having issues getting on because they are texting me. They are coming through.
Okey-dokey.
They said, but yes. So hopefully, Mary, you should see them.
Okay, okay. As soon as they come in, I will jump them on, and I'll let Mary crack on. And
yeah, we can start.
Yeah. Between us,
See you
we can have a
guys.
conversation in the meantime.
Absolutely. See you later, guys.
All right, thanks, Tom. All right, so thanks a million, guys. So Maddie and Rob join. We'll circle back the questions to them too. So this is to talk about our side of it, really, like because we don't I don't normally talk about our side in things like this. It's not normally just the nuts and bolts of what happened, but like, so if you briefly just introduce yourselves first, right, and what your backgrounds are and what your connection to type 1 is, and start there. Michelle, if you can go first, maybe, or if are you messaging Maddie? Do you want to?
You mind if I just message?
Yeah, you go first, Edelle.
Thank you. So, yeah. I am Edelle Irwin. I am mother to a now 17-year-old as of last week. My God. He has type 1, and he's had type 1 diabetes since for 9 years now. 9 years. So 9 years we've had it in our life. I also, some of you might know me from JDRF as well. And I also run a group over here in lovely Northern Ireland called the T1 Club. So I'm probably quite heavily involved in type 1 diabetes, I suppose. But my main bit of love with type 1 is through my son, and trying to help him and support him as best I can, really.
Yeah. And what about you, Michelle, then? Like, what's your background and your connection?
Yeah, so yeah, that's it. I'm Michelle. Yeah, my daughter was diagnosed aged 22 months now. That was about 5 years ago. Had no idea about type 1 diabetes. I thought I knew about it. Didn't realise I knew nothing. So yeah, it was quite baptism of fire. Yeah, and I've been working with DigiBeat now for about the last 2 years. So type 1's brought me in a completely different direction in life in general as well.
Yeah, and there is Rob. I'll bring Rob. Oh, maybe
Fab.
Hey, Rob. Oh, I'm adding you, and Tom's taking. We're both clicking buttons.
It's late at night for all us, you know. It's late at night.
It is.
It really is,
isn't it? And oof.
It's like a social event here. This is. I feel like I'm out or something.
One of ours has just gone down, so.
Oh, sugar lumps. We were just talking, Rob, about like literally just started with who you are and what's your what you do and what's your connection to type 1 or to diabetes as a whole.
Right. Well, I'm a dad. I've got 2 great little unpredictable boys. 6, one's 9, and our 9-year-old has type 1 diabetes. I'm also a co-founder of DigiBeat alongside Maddie, who's just joined. And I kind of work alongside content creation, branding, and the media production side of the DigiBeat stuff.
Cool. Maddie, did you want to add anything to that? Like, so that was just like your connection to diabetes and what you do. So like, did you guys know anything about diabetes before?
Not a clue. It was just media, really. What you were fed by the media, I suppose.
Yeah. Okay.
So, Mary, sorry, was that me?
Yeah, that was just you. Just in case there was anything. No, it's all right. It's all right. No, because Rob did answer. If there was anything like that you knew about diabetes before.
No, not really. And I think that was what really struck us, you know, that kind of we were quite, you know, I felt like I worked actually in special needs beforehand and had a similar background to Tom actually. And so, you know, I knew quite a lot about epilepsy, I knew quite a lot about autism. I didn't really know much about type 1 diabetes.
Yeah. So I'm somebody who has type 1, but I'm also a parent of a teen with type 1. So Jonny is just turned 14, and he was diagnosed 7 years ago, almost 8. And there's loads of type 1 in my family and loads of type 2 in my family. And my first cousin was diagnosed when she was very small, and I have another cousin whose daughter has type 1 as well, and who was diagnosed actually the year after Jonny was the exact day, the year after Jonny was diagnosed, which was mad. But so there's the same anniversary, but just a year apart.
Yeah. So actually, I suppose, Mary, they did have some context, but it was in an older person. So it was my great aunt who had diabetes, and everyone used to say, you know, she was very high spirited, but I think she was probably just high and didn't have access to checking kit or anything at that time. And I look back and I just think she was a lovely, lovely lady. Actually, she was a very similar kind of quite entrepreneurial sort, and she was really cool. But yeah, she, you know, it was before checking test kits and stuff like this. This is when I was just a small child. Yeah,
that's really interesting. Like, just what would it be like? What would you be like? I know what I'm like and what you're like when you're higher and when you're lower, but like if you, that's only for tiny pockets of time.
Yeah.
So
yeah,
interesting. So I wanted to ask you guys about your child's diagnosis but your perspective of that diagnosis. So what was that time like for you and as parents? What was life in your family like, and then how did it change? Like,
Who would you like to pick that up first, Mary?
I know, I'm like, oh.
Because we don't talk about this.
No.
No.
I mean, like
If-
when I suppose I'll start him as well. I know that when Shane was diagnosed, it was such like we were not expecting anything to do with it. It was, we knew he was tired, he was thirsty, but he was doing judo. He was doing judo. He was 7. We thought somebody had told him to drink water and this would make him healthy. And it was we had sort of explained everything, do you know, that kind of way, until the day that he went over to hospital and the diagnosis happened and he was hooked up to machines. And it was just this fear. It was like, what is happening? My son, how do I fix this? Because you want to, as a parent, you want to fix it. You want to make it all better, and it's one of those things that you can't fix. You just have to figure out how to live with, and it as a diagnosis, it's a very lonely place, it's very it was just me and my husband, and we were the ones that understood it. We were the ones going through it. It was very much a family thing because nobody really understood when we were talking about carb counting and blood sugars and the impact on life. And nobody could get their head around that until we started meeting other people that had gone through the same. And then, it became a bit normal then to have the conversations. But that's the bit that I remember is just being lonely and afraid for your child. So.
Yeah.
Michelle, what about you then? Oh, sorry, Maddie. I want you guys to talk like a couple. I want a couple of perspective of you guys. Hang tight. Yeah.
Very similar to what Edelle was saying there as well. I mean, Florence, she was, as I say, about 22 months, so nappies, and it's really easy to sort of you see the signs and you go, it was a hot summer, she's drinking loads. Oh, I've got the wrong size nappy, this is why she keeps wetting, all these things, and you're like, and exactly like Edelle said, and then unfortunately she went in with DKA, so it was quite a huge shock to the system, and I think that time as well, having support from work, I was quite fortunate. I got a lot of support. My partner, it was not like, oh, okay, yeah, when you're coming back in, that kind of thing. I think that's where parents can feel very lonely as well. And when you go back to work, one of the things I really remember is that everyone goes, oh, so your child's better. And you go, well, yeah, she's out of hospital, but it's like, but it's just completely changed. And you go and you end up going, yeah. Well, just a few things have changed. You kind of just downplay it because you can see that you won't understand. Which you get. So it is lonely. And I remember thinking, are we ever going to laugh again? I do remember that was a real thing, but we do. I'd just like to say we do laugh again now.
Yeah. Then what about you guys then? So as a couple of parents, same house, and was it? What was the saying? Like, talk. You talked first, Rob. Actually,
it was a massive bombshell because neither of us really knew anything about type 1 at all. Otis, it's a very common thing. He was just wetting his nappy, filling it, continually. I think then Maddie, he had quite a series of infections, so Maddie took him to the doctors again and again. And one time took just a full nappy. They did a swab on it, and sure enough, it came back, with the lights gleaming. But unfortunately for us, that in this particular clinic, they didn't really respect privacy, so they ran through the clinic saying, "Oh, I think we've got another one," or something like that, wasn't it, Maddie? It was more a case of,
really
there was no privacy to it at all. So it was really quite shocking, and from journey DKA and working out what on earth all that meant and trying to decipher it all like a code, because I'm not very good with graphs and figures and things like this and counting in general. So when you're given a manual to kind of digest it, it's not the easiest to try and comprehend.
I think for me, there was all that. There was the getting the book. There was the kind of the 3 times to the GP over about 6 weeks, missed opportunity. I still find really hard to hear that the same things are happening still now, even despite all the work we do, despite all the, it's hard. But yeah, it's because, it may only get these GPs unfortunately, in their lifetime as diagnosis. And our GP was actually he brought us back in and he was really apologetic. And he said, I'm sorry, the second child we've diagnosed him. I've diagnosed him my whole life. So it is hard to sort of, they've got a lot on, haven't they? So I don't, there's no blame, but it's just, it does need more awareness. So there was that, but there was also, like Rob said, for us, getting the textbook. Now, Leeds is amazing place. If you're going to be diagnosed with diabetes, then you've got every aspect of multidisciplinary team. It's brilliant. But, Fiona Campbell would recognise as well, when we went to him, we said, we've got this book and we're trying to teach our family and we're trying to do, to sort of like basically take this textbook and say, this is Otis. There's like a mismatch. And that's really where Digibeat kind of came from, because we just felt like, if we can put things online and show people how the essentials work and what you learn in hospital, and then it kind of snowballed from there. But yeah, it was very lonely. And I think got to a stage where I had a big fallout with some family members because they weren't understanding and they kept saying that we were being over dramatic and whatever else. And you hear that a lot, and I think luckily now I think everybody's totally on board and they all get it, but it just took a while. And it is difficult. I think probably one thing I would say is that looking back and stepping back, I think we need to understand that, all these conditions are kind of quite challenging because they're rare and misunderstood. And I think it's that education. We've all got a responsibility to just... So I today was in Parliament actually, and there was a lady, one of the parliamentarians, I won't say who, was telling me that her friends, and she was sort of saying, they seem to be a bit overwhelmed by it. And I've told them it'll get better. And there are all these people who are like, Henry Slade and everybody else who, and we've got parliamentarians who've got type 1 and they're fine and all this kind of stuff. I sort of tried to say to her, look, I said, the thing is that child is 12 and they're being diagnosed and they're going to be treated like an adult in secondary school and they're going to find it really hard, And so it's that opportunity I think we can all take in the community, just when we hear these stories, just to try and say, please support your friend, or give them that extra bit of support and put your arm around them, because it is difficult.
Right. You're so right. Yeah. I've got another question, that because we're talking about all different types of diabetes, but there's types within types. So this is pediatrics, okay? And what does diabetes care look like for your child? Because there's even types within our children. We've different ages here. What does the frequency of clinics look like for you and your child? Like how do you order prescriptions as a what if we kind of go the other way around again? Maddie, if you start that one again, and maybe Rob, you don't even need to say this because it's the same, and then we'll go Michelle and Edelle.
Mary, I would say there's a in our family over what we do. So Rob's the really organised one, and he'll do things like prescriptions. I'll look at ratios.
Oh, nice.
Yeah, so we do a lot. We really, really care. I think that's hard, isn't it, Rob? Because I think a lot of people just assume it's the mums that do it all, but actually you are like massive part, in terms of the care, and you do a lot of the. I mean, I don't have a very organised brain. I'm quite happy to say that, like in a personal way. I mean, I'm like work wise, I can be totally switched on, but when it comes to organising my way out.
I'm so similar.
Yeah. So I think that's really important to say, because dads don't always get it. So I'm going to pass this one on to you, Rob, and you can kind of talk a little bit more about questions and stuff.
I actually there's not much you can take from type 1, but I actually get a kick out of actually getting it organised and making sure.
Tell us what you do. I'm excited.
It's like what I do. I don't know. Yeah. Just wait for things to run down, and then I'll
replenish,
and then eat liquid, make sure we've got enough insulin, all that kind of stuff. But I take it a bit personally though. Sometimes I end up kicking myself a bit when things are low. And I think it's actually hard to not do that for me. I think I need to be kinder to myself sometimes because, you know, we live in a very quite busy, chaotic life at the moment. We just moved house, so everything's all over the place. I know what the insulin stuff is and all the diabetes kit, but it's just trying to get everything organised, that side of things.
But you know, it's not all our fault either. Like, because sometimes the frequency of when it arrives in, like, is fine, and then if you left it to the same closeness, and then you order it, and then it's like weeks, and then you're really close to the nose.
The other thing, you know, I think one of the things that we need to recognise as well is kids are kids. They rip their sensors off. They take them off at night at the moment for some reason. You know, so it's like it's challenging, isn't it? And they have accidents and they swim and then it peels off and then, you know, and so they catch the sensors, the pumps, you know, and I think there's a lot of extra stress there really because you kind of it's not in your control. We've got to be so kind to them, haven't we? Because at the end of the day, no other child got things stuck to them all the time, and it's hard. But I think that's quite hard, isn't it, from the care point of view? Obviously, like that balance as well, and how we.
And as adults, you know, we will, if we run out of something, we'll revert back to pens and finger pricking so easily because, like, not so easily, but we can. But trying to change care in school, if you're just down to pens and your pump breaks or something like that, it's like, oh my gosh.
Kind of really reliant all the carers are on the tech as well. And if that fails for something, they're kind of left hanging, really. You've had the training, but okay, what do we do now? So you're in school for the day.
Yeah. So what about Michelle and Edelle? Like, what does care look like for your children then where you are? Edelle, if you go first.
I suppose care for me now is I'm at the other end where I have had to let go slightly and realize that my son is not a wee 10-year-old who carries his blood sugar stuff round in a bag around his shoulder, and you know he is a big 5'11", 17-year-old who sticks it in his pockets and sometimes drops an insulin pen and remembers on Friday at 6:30 in the evening when you can't act. You know, it's always on a Friday. If something goes wrong, it's on a Friday. I don't know what it is. Friday night. But it's just I'm at the stage now where, you know, this is has diabetes, and you know, at some stage you have to just let go and hope that you've taught them enough, you know, and that they know, and they know they can rely on you, you know. He knows he can rely on me. If something breaks or he's lost something, I will go and I will pull the house apart, lift beds, do the usual to try and make sure, you know. And I still do his prescriptions. I still do them. Colin runs and collects them, you know. But we want him to be independent, and we want him to know too that we always what we've tried to instill now is there was a time he thought we were on his back constantly, and what I've been trying to tell him and what he's figured out now is we have his back. That's what we have. We are there. We are his constant. If something happens, we're there to pick up the slack, you know. So that's been our point, and that's the bit that I've been trying to work with him. And we have an understanding. I'm not on his back, and if he thinks that I am, I'm trying not to be. I have his back. That's it, you know.
What about for Florence? Thanks so much, Edelle. What about for Florence, Michelle?
Yeah, so Florence, she's around 7 now. She's getting very independent. So she wants to do, obviously with supervision, she wants to do quite a lot of it herself now. When it comes to prescriptions and that, quite similar to everyone else. It's between Mark and myself, and we just do the down to the doctors down the road. It's quite everything's quite close, so we're quite lucky in that sense. But exactly like you say, though, some weeks where you go, I've gone too close to the wire, and it'll work out fine, and then other times you're like, oh, we've got to call round quick.
Can you do us a rush prescription?
Go to the Facebook group. Anyone got a sensor? You know, that kind of thing. Yeah. We've done that. But yeah, I mean, with with Florence now, for instance, she absolutely hates the stuff being put on, but we've done this agreement that and we've checked, that she's happy with this, that she likes to have her like sensors, and like as I'm talking to you now, Mark is actually doing a cannula change, because that's just something that she wants to do in her sleep. And at first I thought, well, this is a bit strange, but we checked with the psychologist, and it's quite a lot about her having that control, and having something that she can control. And it's like, okay, until she changes that, then we find that works at the moment. But like everything, as they grow up, they change, and we'll just adapt as we go along.
Yeah.
So we're getting very close to 10 o'clock, and I know, and we could just talk about this for another, not even a half an hour, but more than that. But wanted to finish really quickly on what we do for our children at their stages right now. Like even if you pick one thing that you still do for them, so like I would think like type 1 is like any type of diabetes is like an iceberg, and the bit above the water is the insulin, carbs counting, and all that stuff. What about the bit below the water that we carry as parents? What would you say is something that you do for your child, like that?
Keep asking them how they're feeling, really, like keep on top of that. I mean, like from our work as well, we see how important that is, just to check in with them.
Oh, I've goosebumps on my knees, Maddie. Like, that's so important.
Yeah, because I think they carry a lot, don't they? And I know we're short on time, but I would just definitely say, like, keep tabs on their emotional well-being, because that's something that unfortunately can go under the radar and you might not even realize. The rest of it is just logistics, isn't it?
Yeah, totally agree.
Yeah.
Anybody else want to add anything?
Yeah, and what I do is I just make sure, like, we have an agreement. Shane had a bad hypo a couple of months ago, about 4 or 5 months ago, a really bad overnight hypo. And what I do for him is now, even if I don't see his bloods during the day, even if he's managing everything, what I do is tell him to put his data on, and I will take control at night. And I look after that bit at night, just take it away, just until he feels like he can do it again. Do you know, that kind of way? That's our agreement, that I will just take that bit for him. So that's what we do, which leads to sometimes a wee odd sleepless night every so often. But I won't say anything about that. I've got good concealer. It's fine.
Can I borrow some of that, Edelle?
No problem. I'll send you it over.
Yeah, anything?
Yeah, and just with Michelle, much like what Maddie says, I mean, I'm noticing as Florence is getting older now, she's noticing she's different in class. She's quite a chatty type person. Her personality suits that she is happy to talk about it, so we're encouraging that as much as she wants. And I've always said to her, if you've had enough of talking about it and people ask you, just tell them, ask your mum. I can answer the questions for you. Like you say, take the burden off and just keep checking in with her. Yeah,
and Rob, last word.
Yeah, I guess we really help Otis navigate it all as well. We're there for him, and we can help, sail those choppy waters, even, on the good days and the not so good days. We're there to help through that. And we're constantly chatting to him about it and helping him through.
Thanks so much, guys. Like, that was lovely.
Thank you, Mary.
Thank you.
Thank you
Great seeing you all too.
Sorry.
Thanks, guys.
Late train, I'm afraid. I was really delayed. Sorry about that, but really lovely chatting.
No problem.
Well,
and it's
thanks for making it.
Yeah, and it's something that we'll have to do more of. I think tonight's Diabetes Chat has been so good, listening to different perspectives. You guys, healthcare professionals, we talked about type 2. We had the kids on, Shane before, Edelle. Like, oh my gosh, like these discussions will carry on, and it's so important to talk and share and learn and educate and raise awareness. And you guys are absolutely amazing for everything that you're doing for your warriors, but you guys are warriors, and you literally great stuff for everything you do. I know how supportive my mum was for me, like in my journey, and still is, bless her. But yeah, it's just great, and I think it's been great listening to this perspective. And we had so many lovely comments coming through, like you've seen popping up the last 10-15 minutes. But thank you so much, guys. It's been a pleasure, and we'll talk more for sure. Thank you so much.
Thanks, Dom. Bye.
Cheers, guys.
Bye.
Wow. Okay. Let's have a look, shall we? That was absolutely sensational. Our awareness, Maddie, Rob from Digibeat, Michelle, Edelle from the Type 1 Club, and the fabulous Mary. Mary. That was just incredible. Loved it. I loved it. So let's bring up the fantastic Jean. Hello, Jean.
Hello, how are we?
I'm good. Yeah, it's been
Good.
such an amazing evening tonight, and we've had so many fantastic guest speakers, like I said, talking about diabetes in different ways. We had Santiago, who is a DDoc voice, as you know, Santiago, and he shared his diabetes art. We've had so many amazing things, and now we are flying around the world. I'm going to hear you guys. I'm buzzing. I can't wait. And it's going to be great. Jean, thank you so much for hosting this section. I will sit in the background and just smile. Remember, guys, hashtag DiabetesChat, tweet on Twitter. And if you want to win some prizes, just send a hashtag DiabetesChat in the YouTube. And lots. I'm looking forward to this, to hear about diabetes around the world. And you guys are absolutely amazing. So I'll leave you and I'll come back later on.
Thank you so much, Tom. This is
See you
amazing.
guys.
Hey, everyone. This is such a great panel to be having. Oh, my God. So exciting. We've got Zimbabwe, India, Australia, and the Philippines shortly, I think, when Jaco joins us, which is really exciting. And we're talking about peer support. I have put my poster up behind me here of my peer support group's event this week that's happening on Thursday. So I was sharing earlier, I'm so excited to be in this chat with you guys because it's the 1 year anniversary of our peer support group in Edinburgh tonight. And back in Limerick, my OG peer support group has an amazing event happening as well, celebrating End Diabetes Stigma, which Renza and Jazz, I'm sure you'll speak more into in a little bit. And yeah, there's just loads of exciting things happening this week. And this is such a cool night to be kicking off the week that is of World Diabetes Day. And of course, we're in Diabetes Awareness Month. So I am just going to do a quick fire round, guys, if everyone can introduce themselves and just mention why peer support is important to you also. So Tino, you're next to there, so I might start with you.
Right. You can hear me? Okay, so it's Tino here. Peer support. I think this is the one topic that I fear mostly to talk about because I got out from my comfort zone later on in life after having been diagnosed. I started doing this, realizing the power of peer support when I got to one of these groups, amazing, powerful groups, like I think 9 years after my diagnosis. So it's something that I've seen because ever since I started, everybody been thinking, wow, it seems like you have much experience, things that you've learned about advocacy, but it's only been 3 years since I got to be doing this. I learned so much. There's no comparison, there's no judgment whatsoever. Whatever that is you get is encouragement and how people have been doing it all the years. So yeah, it's so encouraging and it's so important. No matter how good you manage your diabetes, peer support is important. It's critical. So yeah, I'll leave it up. Thank you.
Love that. Thank you so much, Tino. That was a great start. Renzo, I'll jump to you next.
Hi, everybody. Happy World Diabetes Day. It's already World Diabetes Day here in Australia. So happy World Diabetes Day to everybody. So excited to be here. And thanks to the DiabetesChat team for inviting me along. Peer support, gosh, community is everything to me. And peer support, I always say, is just as important as all the other aspects of my diabetes management. The only reason, I guess, that I feel that I'm able to manage diabetes the way that I do is because I am constantly surrounded by truly remarkable people doing truly remarkable things. And I've got 3 other people on this screen that I'm looking at that I've lent on at one time or another to learn from and to just recognize how amazing the work that you're all doing is as well. So it's lovely to be here, Jean.
Thank you, Renza. Oh, that was absolutely beautiful. Jazz, we'll jump to you next.
Namaste, everyone, and a very good morning. It's 3:30 in the morning here in India. So happy World Diabetes Day to everyone. And thank you, Tom, and the entire team for the invite. So I think peer support is so beautiful just because of, what we're doing right now. We are 4 people sitting in, different parts of the world and talking about this one shared mission, goal, whatever you want to call it. And I think over the years of being in this space, I've truly seen what peer support can do, not only for a mental health kind of a perspective or to feel less alone, but I've seen what it can do to end stigma. I've seen what it can do to improve outcomes. So it's not just what people say that, oh, you can feel less alone. I've seen it truly change people's lives, not only medically, physically, mentally, emotionally. And I think that just holds a lot of worth. So that's from me.
Oh, thank you, Jazz. And that absolutely, you're so right. Like everything the 3 of you have said there, just collectively, like the fact that we're all here together this evening, the way in which it impacts people overall. Tina, I know you just mentioned there as well, how you came to peer support a bit later, as did I in my diagnosis. I was 15 years into my diagnosis when I found peer support. And the impact that it had on me, the way you're talking about that, Jazz, the impact it has on your diabetes management and your mental health and everything as well. It's so, so true. And that actually leads me on to my next question, which is, for you guys, did you engage with peer support from day dot, or was it a bit later on into your diagnoses, or how did it come about for you, if you want to just explore that? So, Jazz, I might start with you on that, actually.
So, actually, I was diagnosed when I was 13 years old, and it was 10 years later that I ever met my first other person with type 1 diabetes. Just because I think in India, back in the day, in 2009, there was no concept of peer support, or if there was, none of us were really aware of it. So I think because I had no access to any peer support, there was none in my city, in my state, anywhere in India for that matter. So I actually began the first peer support that I could think of, because it did not exist. So it was a much later, just like Tino said, it was 10 years later for me actually. And that's when I started it in 2018. I started my foundation because there was no peer support. And I used to see online, the Western part of the world had this concept of peer support. So it got me inspired. It got me excited to do something in India as well. So it was 10 years later for me, a whole decade.
Wow, amazing. And it's amazing that you took the initiative to start something that didn't exist, and that you took those steps to make something happen that wasn't being provided, and that's so essential for our care. There's so much research now into the benefits of peer support and how it impacts people's not only mental health, but their actual diabetes management and their engagement with their management as well. And I think that is so important, because I know for me it had a huge impact. I was really late to it as well, like I said, and it just it felt more normal to engage with my diabetes because I was around other people engaging with their diabetes. It wasn't about I was like pressured into it or shamed into it. It was just that it was more normalized to engage with it. Whereas I found when I was not around people with diabetes ever, my norm was not engaging with my diabetes because I was mirroring what the people around me were doing. So being around different people living with diabetes has been so eye-opening for me, and the benefits are just endless in my opinion. So yeah, absolutely. And Renzo, what about yourself?
Oh gosh, so I was diagnosed as a young adult, and the last thing I wanted to do was be in a room full of other. Oh my goodness, the room that I'm in is about to go. The lights are all turning out. I'm speaking to you from a university because I'm here to do an event today, and it's very high tech. Anyway, no, there was no peer support because I wasn't interested. The last thing I thought that I wanted to do was hang around with people with diabetes. What were we going to do? Sit there and talk about diabetes? Really? Why would we do that? And I then ended up starting to do some volunteering with a young adult group, and then that's how I got a job working in diabetes. And from there, I met a lot of people with diabetes, and now peer support is obviously a very, very big part of my life, and I can't imagine not having people around me. And we don't usually talk diabetes. I might just also add, like, it's very rare that we sit there and talk about diabetes. So those things that I was really fearful of or I thought would be horribly boring don't actually happen. But other people, talking to and hearing from other people and learning from other people with diabetes makes sense of my own diabetes. So that's really very helpful. I'm going to go turn on some lights. Excuse me, just for a sec. I'll go over there.
No, it's funny that Renza says that actually, because I was the exact same where I wasn't engaged with it. Like there were support groups around, but I had no interest. I thought what people did with diabetes was sit around and just talk about diabetes and nothing else. And it was quite funny. I was at a party during the weekend, and there were 6 of us there, and 4 of us had type 1 because we'd met through the support group here in Edinburgh. And the 2 who didn't have type 1, they were friends of the girl hosting, and they were like, so I'm assuming you all know each other through some kind of diabetes network. You know, they all of a sudden were the minority. And they were asking what we all talk about for this, and they were saying, like, is it just diabetes? And it's exactly what you said. It's more that you're around people where what you're doing is just the norm, and you talk about other stuff, but also just freely get to engage with your diabetes without explaining it to anyone, which there's such freedom in. So it's interesting that we have 2 different stories, where one, there was not the peer support actually made available, and then that not wanting to engage as well, and like myself, which was the same for me. So Tina, what about yourself? What was it that made you not want to engage initially with peer support?
Well, thank you for that important question. And I think maybe I share a very similar scenario like with Shares, because I believe there was no peer support whatsoever in my community. And since I said 9 years later, that's when I wanted to get involved in diabetes community. But I think it was really for selfish reasons. I just wanted to stay on top of my game. I wanted to know so much, maybe better than my doctor knew, because they were general practitioners. I wanted to sort of like, when I reached out to the international community, I wanted to improve my skills, what I knew about diabetes. So it was from the first group that I met that introduced me to say, hey, there's what we call DDoc in 2020. So when I got involved with that, that's when I started to network with other people. And I think that's how I got exposed to do the peer support and see, okay, fine, this thing is important, and trying to read from it, and also trying to take it back, paying it forward, teaching people from my community to say, hey, there's this thing. We may not share medical advices, but just sharing our experiences will be okay. But right now, I think I still have to go back in these group chats, telling people, hey, don't exchange the medical advices. It's just peer support, share experiences and what's working for you and what's not working. And if you find it not to be good enough, maybe go tell your doctor. So peer support, that's where we get all these insights, all these new ideas, what's working for this person and what's not, so that we can probably change what's not working for us for our better. So yeah, thank you for that question.
And speaking on insights and on wanting to have all these expertise that your HCPs didn't previously have, you have your amazing podcast, which is the Diabetic Mogul, which is being rebranded tomorrow to Global Diabetes Insights, which is amazing. So I'm assuming, I don't want to put words in your mouth, but that was the inspiration. So behind getting it onto this unified platform that shares all of these insights and does pay it forward in that way. How did that start? And like, talk us through the process and how the thinking behind it. It's absolutely incredible.
Right. Thank you so much. So when I say when I reached out to the international community, it was really for selfish reasons. I needed to up my game. I needed to know so much about diabetes. So when I got involved with ISPAD, there was so much information that they would share on their platforms, like these guidelines that my people in my community, even doctors, did not have. So when I started as a solo, I would never describe anything or say anything like I would always say we, as if there was a team. There was just me. So when I started as a solo, and also considering that this is the name that I use on my social medias. So, and then other people like Connor, when she reached out to me to say, hey, Tina, maybe we can do something together. I didn't want to change my name immediately because I didn't know if she was going to stay, because I knew it was difficult. So you wouldn't know what was going to go on. So then we thought, okay, fine. If this would continue maybe for a year, we might have to change the name. So knowing how we cover the global perspective, not just bringing people living with diabetes, healthcare professionals, researchers, amazing, and great healthcare professionals who will also come to this, we said, okay, fine. I think maybe changing the name or rebranding would be good. It could be positive because we might get new perspective, but also thinking about this ending stigma. I thought maybe the name, we thought maybe the name might have to change as well, because diabetic, the word, it's something that we are trying to shun away from. So we thought maybe changing the name would be good, but also we reached out to the community, to our listeners, the people that have been supporting to say, hey, just a few, to say, okay, what would you think if we do change the name? So people liked it. So that's why we did it. So yeah, it's just how it went on and how it's going. So yeah, thank you for asking the question.
Well, huge congratulations, and I hope you're celebrating tomorrow with the rebranding. And it's amazing to see that that stemmed all from the diabetes online community and peer support, and that you wanted to pay it forward in that way and engage with the community in that way, because it's a different type of peer support when it's podcast format, I think, as well, which is really nice for people who maybe don't want to, you know, socialize directly, but they want to take in the information still and benefit from that information that we do get from peer support. I think it does it so beautifully and so well, and we've all had the privilege of being on it. So yeah, just huge congratulations. So going from online events to offline events, Renza, I know you are having an End Diabetes Stigma event there today in Australia that you're at. So that is so exciting. Can you talk more about it and tell us all about it? And it's obviously happening online too, before we sign the pledge, but what is happening there?
Well, firstly, I just need to give a shout out to Jazz, because she is up at 3:30, and then she is also doing this event this afternoon or this evening, my time. And I'm not sure if you're, because then I'm doing Doc Day as well. I'm not sure if you're doing that as well, but it's World Diabetes Day is a lie. It's World Diabetes Day 42 hours, I think. But this evening so it's 6 p.m. Australian Eastern Daylight Saving Time, which I think is like 7 a.m. UK time, is the launch of the consensus statement to end diabetes stigma. And, you know, I think that this is one of those moments that we will look to sort of see that this is another opportunity of where that community has really come together. And you know, the consensus statement has got a committee of 51 people, and Jazz is one of those people from, I think it's 21 countries around the world, and addressing the issue of diabetes stigma. And you know, it's got evidence to show why, you know, we really, really need to do this, because stigma is just so harmful. So we have a lovely event in the centre of Melbourne tonight. We've got some international people here, which is wonderful. They happen to be here. There was no budget to bring anyone, unfortunately, but they happen to be in Melbourne. So we sort of grabbed them and brought them on. But we're also then having an international panel discussion that Jazz will be on. And you know, we've got pretty much, they're all DDoc voices, actually, because, you know, the DDoc community, if we're talking about peer support, is another wonderfully global community that, you know, is open to everybody, you know, impacted by diabetes around the world. So that's pretty exciting. But, you know, I think that talking about diabetes stigma, we know that this is an issue that is very close to the hearts of very many people in the diabetes community. It's impacted so many people. We hear stories every single day about how stigma really, really affects us, you know, whether it be from, you know, making people feel really reluctant to go to see healthcare professionals because they're really concerned about what the reception will be when that happens, to, you know, even telling people, they won't even tell family members, they won't tell friends. They're embarrassed to talk about it in the workplace, whatever it is, you know, it is harmful. And so this consensus statement, is always wonderful to have something you can point to that's evidence-based, so that when people say this is rubbish and this is just political correctness, you can say, well, actually, no, we've got something to back that up. So so that's happening this evening. And so everybody can join us virtually. If you go to enddiabetesstigma.org, there's a thing about, go to the menu, find events, and come along. And we'll be sharing the link all over socials as well throughout today. So we're hoping to see lots of people online, as well as the people who will be in the room.
Well, I'm so excited for it, because I'm actually registered and I will be getting up at that time for it. So kudos to you guys, because it's normally you getting up at all hours for the events for UK time. So it's nice to return the favour and be getting up at the early hours, not the same level of early as you've committed to previously.
Poor Jazz, poor Jazz right now. I just want to know, it's very glam look at 3:30 a.m. We'll talk about that, my love.
Oh. So on in-person peer support then, Jazz, can you speak more into Diabesties and what that does for people in India? Because it's absolutely amazing, and I'm just always in awe. And also huge congrats to just yourself and Renza and everyone involved with the End Diabetes Stigma, before we move on from that again, because it's amazing and it's so needed. So yes,
Yeah, no, absolutely. So, firstly, a huge congrats to Renza and everyone who's been a part of this because it's such an important topic to talk about. And I think that's the power of peer support as well when we rally together to talk about more than just diabetes in the medical sense, when we're talking about things that are actually personal and important to us, which is stigma. So, I'm extremely honored and excited to be a part of that panel tomorrow just to talk about how stigma also looks different in different parts of the world. Um, but at Diabetes, the funny thing is that we're not doing anything on person on World Diabetes Day because it's so close to Diwali. So I don't know if any of you guys know, we just celebrated Diwali 2 days ago, which is a huge festival in India. So everyone's out for holidays. It's a vacay mode in India right now. But what we are planning, which is something I'm extremely excited about, is that on the 26th of November, we are launching the first ever Diabetes Center in India. That's our first actual physical space, which is going to be run by people living with diabetes, for people living with this. So it's called NEEV, which means basically foundation and roots in Hindi. So we're calling it NEEV, the Diabetes Center for Education and Empowerment, which becomes a really safe space for people with diabetes, all types, to come in judgment free, stigma free, to learn about their condition, to celebrate their condition. And I'm very excited to share. It's gonna look very non-clinical in just terms of aesthetics. So will be teal and yellow and lots of fancy colors. But the idea is to have a safe space where people can come in, be themselves, learn about their condition from people who look like them and from people who also live like them. So that's what we're doing for Diabetes Awareness Month.
Wow, that's incredible. Huge congratulations. And I also saw the amazing Decoded as well by Diabetes,
Yes.
which is a fantastic resource for people and absolutely beautifully written, and just it's such a lovely interface to access and to read through. And yeah, tell me about that. That was absolutely amazing to see go live. Congrats.
Thank you. No, Decoded actually, that's right. I forgot we did Decoded. I think it's my 3 a.m. brain right now, not working too well. But I think the idea of Decoded, and Renza is, of course, on our lived experience panel for Decoded. And she can probably share a little bit more about that. But the idea was always to simplify diabetes, and I know a lot of people are doing it all over the world, and it's amazing. We need more of it, But the thing is, I personally, while growing up, was very interested in diabetes research, but I always was terrible at biology and science and chemistry in school. But I'm not a medical background, so I'm not a nurse or a doctor. So sometimes reading even abstracts, I'm also a very visual learner. So for me, the 12-point font with like black and white graphics was very intimidating, non-appealing. So we said that people with diabetes should have access to understanding diabetes research. So the idea was born out of that how can we decode diabetes research, make it digestible, make it, colorful. I'm a big color person, clearly. So make it colorful, make it easy to understand so that people can use that research for their management. And Renza, I don't know, what are your thoughts about that as well, since you're on the as well?
Well, I mean, amazing work, Jazz, for getting this happening, because I think you're exactly right. Research has to be accessible to people, from all levels, whether it's being a participant, being involved in actually being part of research groups and being on, community advisory panels for different research projects, but then also being able to have access to and understand the research that's being done. One of the things that I frequently hear from people is the loop never gets closed, right? We might participate or we might hear about something, but then we don't actually get to see what the outcome was. So to have it presented in a way that is so visual, is so accessible, gives you all of those sort of headline but doesn't dumb it down equally, but then also gives you an idea of where you can go to if you want to delve a little bit deeper. And it's one of those by the community for the community thing, so it hits the mark. It makes you want to learn more in such a simple way. And so, and Jazz, block your ears for a minute because you get embarrassed, but this is one of those things that Jazz does so beautifully well, is you know, she makes everything look great, but, you know, that ridiculous idea of, you know, because we do see this, all style, no substance, that's absolutely not what you get with Jazz. You get both. And so, you know, it is truly a brilliant, brilliant tool for people. And I think for people at all ends of the diabetes spectrum, whether you're newly diagnosed or whether you've had diabetes for some time and you're wanting to keep up with research, it's such a great, great resource to have and to be able to access whenever you need to. I'd really encourage researchers to have a look at it as well, because I think that that's something, you know, have a look at it and connect, because you want your research to be featured on here so that more and more people get excited about it. Research is hope.
What Renza said is so important. What she said, that it doesn't dumb it down to the point. So I think we're very clear that we want to keep the scientific integrity of that paper alive. So what Decoded does a little differently, I would say, than other sort of blogs would be that we get each of those decoded articles verified by an expert researcher. So you know that that decoded article is not compromising the scientific integrity. So even our advisory panel, we have a lived experience advisory panel to get that person-centered approach. We've got an advisory panel of very expert senior researchers on there as well, basically because we want it to be, as Renza said, a collaborative effort. And we want people from the community to reach out. If you guys want to be a part of it, we always want more people to sort of get this and use it. I think the biggest thing, you know, I'll give you a recent example. We launched with the concept study, which talks about how CGM in pregnancy is it improves outcomes. I just got an email that somebody read that paper and they're going and asking their doctor for a CGM because they're going to plan their pregnancy. So, I mean, that is when you know that, okay, it works.
Yeah. That's amazing. Absolute kudos. That's incredible. And the thought put into it and like you're saying, the substance in it and everything, it's just incredible. And I love that you have the dictionary then on the side for people as well, with the vocab for people to, if they're not familiar with the terminology, you've thought of absolutely everything. So a huge congrats. Guys, I have 100 more questions, but we're nearly out of time. So I just want to say thank you so much, because this has been an amazing conversation. I love that we've gotten to talk about the Diabetic Mogul podcast rebranding into the Global Diabetes Solutions, about the End Diabetes Stigma event happening in Australia, and all of the exciting things happening there, that Decoded, and the Diabetes Centre opening up. I'm tripping over my words with excitement here. So there's just so many great things happening. And I think that's why this panel was so great to have, to see that we're from all different parts of the world, and peer support has this impact where we've all gotten into peer support one way or another and been inspired and been driven to provide different resources in all these different formats as well, and all these different ways of spreading diabetes information and knowledge to people that they wouldn't maybe have access to otherwise, if their HCPs maybe aren't as engaged or aren't getting that up-to-date information that we actively do engage with, and that we really want to make sure that other people have access to. And it's making such an impact in people's lives in such different ways. So yeah, I just want to thank you so much. Tom, I think we're out of time, are we? You might tell me if you're there. I don't know if any questions have come through in the chat as well that maybe we want to quickly go through if we do have more time. Oh, you're on mute, Tom. It has to happen.
Hasn't happened.
I think after 4 hours, I'm a bit tired now. But wow. It was amazing. And I think there's so many comments coming through. You've seen them flying in while you guys have been talking. I think there's so many themes coming through, and I think ultimately talking about the importance of peer support and community and talking, and you guys have raised a lot of awareness tonight. Everything that you're doing on your social medias is great, and all the things offline as well. And thank you for just being part of this tonight. It's absolutely amazing. Look, we're getting more messages coming through. What a chat, clapping hands, amazing. Love it. I love it. So thank you for your time tonight. And Jazz, I can't believe it's 3:30 in the morning. So what time is it everywhere? Tino, what time is it with you?
It's 12:32. Yeah.
Oh, bless. Oh my goodness. And then Jazz,
9:30
4
here.
o'clock? 9:30 for you, Renza.
It's a nice time. Usually I'm the one who's
Yeah, she's always the
For
one
the first time.
in the middle of the night. I'm happy to take that once because it's always red, like 3 in the morning up. So
Oh,
That's
bless
all
you,
right.
bless you.
It's all right.
But thank you honestly for coming on. And like last time we spoke when we did the Twitter Spaces audio, but this time just bringing it to life with seeing people's faces. I was just texting Mary offline, and we said, "Oh, it's a bit chilly." I said, "Oh, I'm not putting my dressing gown on while I'm on camera."
I have a hot water bottle for the whole thing. It is so chilly here as well. That storm is going.
I love it. I love it. But so thankful for your time today, guys. Keep up the amazing stuff, and we'll catch up, I'm sure, next year. But yeah, thank you so much.
Thank you,
Happy
Tom,
World
for an amazing
Diabetes
event.
Day.
See you guys. Pleasure.
Bye.
Bye. Bye. Bye. Bye.
Thank you.
Alrighty. Let's have a look. Where are we? Oh, there we are. So what time is it? It is 10:30. And you're listening to the Diabetes Chat, or watching the Diabetes Chat for our World Diabetes Day virtual conference 2023. And it's just been amazing. And if you want to win some prizes, we're giving prizes out. All you have to do in the YouTube chat is type the message #DiabetesChat. You can just do it just like that, or you might do it as a comment or a question or whatever, but you will go into the draw and you could win a Captain Lance's book, a mini pancreas toy, or 4 VIPs to the Overtones Good Times Tour. 3 fantastic presents, and I can see Mary's putting a scarf on in the behind the scenes. Love it. And there you go. So all you have to do is #DiabetesChat, just like this, just like Leah there. And some fantastic comments coming through there. Love it, absolutely love it. Superb. And tonight has been really, really special, and the show must go on. And here we are. Let's bring up Tony. Hello, Tony.
Hello. How are you?
Hello. How are you? Are you okay?
I'm really not used. I'm used to standing at the back, looking moody, and so being a bass player asked to do stuff isn't a thing that happens at all.
So
I'm not a
Tony is here
guitar
tonight. Tony, you are now, after all the amazing stuff that we've had tonight, we have
I
had
know.
kids,
Yeah.
we've had diabetes art, looking at Santiago's art, how he represents diabetes. We had a type 2 chat with Claire, a person with
No
type
pressure,
2.
Tom.
I'm just giving it an overview. And then we had the tech chart and the healthcare professional chart, the parent chart, and just the amazing global chat. And what I wanted to do to conclude the next hour and a half of this conference is having a bit of fun now and having Tony on. I'm not sure if Alex can join us tonight. I'm not too sure.
Fun for me.
And we're just kind of a bit of fun and raising awareness about diabetes. And Tony's got a few songs that he's going to do. And if you're watching along, which we can see people, look, Tony, you got some fans. Woo, Tony! There we go.
Oh my God. Yeah. So
Diabetes. Go on, Tony.
Because obviously we talked over the weekend, and
yep.
And it's really weird. As I said, it's really weird. I'm standing at the back playing the bass, and it's all the proper musicians generally do stuff. But I thought what I'd do is I'd play some bass lines of songs related to type 1 or diabetes or anything.
Yeah.
And they're all bands that contain. So you've all got.
So we have to guess, right? We have to guess. Do you have to guess the name of the band or the name of the song?
Both.
What are we going for?
Doesn't matter. There's no prizes.
And how many have you got?
Yeah, just as soon as you guess it, throw it. There's some.
Put it in the chat. Put it in the chat, guys.
Yeah,
or if you're on Twitter.
There's some really obscure. Mary's got her Guinness 0.
I'm gonna bring Claire up to the panel as well. And Mary, thumbs up. Do you want to come up to the panel as well? Brilliant. Let's there we go. Mary as well. And we're gonna have some live entertainment, and we're gonna guess the tune. A bit of fun now for the next 20 minutes before we have our open forum. You have to name the tune, what the band is called,
I'm rubbish at this. I am rubbish at this.
Okay, so
if you know the band or you know the song, jot it in the box, and they are diabetes related. I'm going to mute my mic and over to you, Tony.
Just adjusting my T-Sim. Okay, so. So, anybody?
Ooh, I didn't hear it quite clearly. I don't know if that was just me. I hope not.
Right, do it. Can you do it again? Do it again, because
Do
it
it again.
doesn't sound familiar.
Yes, no?
Ooh.
80s, 90s dance thing?
I'm not sure,
I'm not
Tony.
getting it. Anybody?
No.
Anybody in the comments? Let's see.
No, I don't
Mark.
think people are...
Shall I play it? Let's.
Yeah, play it on.
I hate-
I don't know if it's because the connection, I didn't quite get it. I don't know if it was me.
But I'm rubbish.
Yeah.
So
Oh,
Leah's saying I have no idea. Shaun is saying it sounds really familiar. It does sound really familiar to me too. I'm going to be going on. Oh.
As soon as you tell us, give us a hint.
Give us a hint. Give us a hint.
It's Candy by Cameo. Candy.
There we go.
You're not R&B guys. I can see.
Wrong audience. Go on, Tony. Give us another one. Oh, someone said face green smiling.
Laughing.
Oh.
Yes. Yes.
I am so bad at this game.
I can't even
Head's like,
think.
ooh.
Anybody?
Guys, are you guys that are listening?
So what do we get on our CGMs and stuff?
What do we get on our CGMs?
Like numbers?
Okay, it is Basement Jack's Red Alert.
Ah, there we go. It's themed. It's all diabetes for themed.
Oh, Tony, I'm sorry. I'm so
Go on, do
rubbish.
it.
So this
Go
is
on,
what it
John.
sounds like. Yeah.
I didn't hear that one.
No, we're not hearing that actually.
No, not hearing it for some reason. Is it? I'm not sure.
Let me find-
Maybe it could.
Let
John
me
got it though.
just-
Look,
Yeah, John
there's
got. Yeah, John got it.
Point
Oh,
for
good.
John.
Well done, John. At least I'm not playing to an empty room.
John.
Right, John, we're relying on you. John, we're
Come on,
relying
John.
on you.
Come on, John.
I'm shouting here and the kids are asleep.
That sounded absolutely class. I have no idea what it is, but it sounded absolutely incredible. Go on, John. Give us the answer.
Sugar.
Sugar. Oh, come on. Let's do it again. Come on, do it again, and we'll sing along to this one. Sugar. I don't even know the words. I'm not bad at this game.
Sugar.
I'm actually gonna Google the lyrics. Can you do that one again?
Oh, yeah.
We'll all
Yeah.
sing it. Come on.
Oh, here's
So-
here's Diabetes Chat karaoke.
Tell us when to start singing. So I'm bad at this. I think I've lost the place to start. I think it's class. Well done, buddy. Well done. I'm just so musically untalented. I have no idea.
Everybody got it. Come on, folks. Yeah, yeah. It's actually called "My Boy Lollipop," but I'll give you that. I'll give you that, Victoria.
You give me that. A point for Victoria. Oh, there's Mark, Candy Girl, Sugar for the last one. Smiley faces from Kez. Yay! Brilliant stuff. Oh, we've lost Mary. Did she jump off on purpose then, Mary? Yes, I think she did. I was bringing her back on. Go on, Matt. Go on, Tony. Give us another. I know this one. No, come on, do it again, Tony. I think I know this one. It's in there. It's in there. I just don't know it. I just don't know how to take it. Sounds Radioheadish, John says. No. Go again, John.
What's the Libra?
Sensor.
What do we call it?
Oh, here's Kez. I think she's come to join the fun here.
What do we call it?
What do we call a Libra?
Flash.
We're so bad at this.
You are really bad. not quite as bad as karaoke, but
controversial.
Let's try this one.
Go on. Kez has joined it, and she's going to come up with the answers. I can tell.
No? Any guesses?
I am like the worst quiz player in the history of.
Deflecting type thing, maybe.
Oh man!
Shall I tell everybody?
Go on.
Yeah.
Pour some sugar on me, Def Leppard.
There we go. Yeah, even John didn't get that one.
Yeah, John.
Come on, John. So Tony, before we crack on, you're gonna do a song, I believe. Tell us a little bit about you, then, your connection to diabetes. And you didn't expect me; I was going to tell you this, wasn't you? Who are you? What's your connection to diabetes? How long have you been living with diabetes?
I was diagnosed when I was 10, and that was a while ago, 1978. So I've been type 1 for 45 years. So not half as in the figures as Martin and Peter, but there you go. And I've always had type 1. I kind of don't have a lot of kind of memories beforehand. It's always been, kind of started on glass syringes and then pork insulin and stuff, and then went through the whole pens and then ended up past 5 or 6 years on Libras, and I kind of DIY'd a bit. So I think that was part of the reason why my clinic then gave me funding, because they didn't like me DIYing. So and that's where I am. So T Slim and Dex.
Yeah.
T Slim's been brilliant, just
Yeah.
life changing.
So do you find, because obviously you go around and you perform, and you said you're normally in the back, but you were amazing tonight. But do you, when you're going on gigs and stuff, do you find how's your diabetes and stuff like? Do you find hooray for the 70s kids? Yeah, Linda. Do you how do you find your sugars? Like tonight, I'm looking at my blood glucose now. Let's have a look. It's 12.6, and it literally has been 12.6 most of the evening. I've been probably trying to stack. Well, it's probably stacking the insulin, but the adrenaline for me when I go on like these things, or like on Saturday when I was at the Diabetes UK, it kind of peaked up a bit. Like, how do you find your levels, and how do you manage it? And do you get adrenaline and stuff like that with?
Yeah, I do. I mean, very often particularly because we tend to kind of gig hour and a half, 2 hour max. I mean, it's never up and down the country, but particularly what tends to happen is that I mean, we're a weddings and functions band, and so we'll kind of turn up at 6 o'clock and do an hour or so set up, and then kind of and then it's just sitting around. But it's also, we tend to get catered for, so eating's not good because you never know what you're going to get, and there is the adrenaline stuff, and so I tend to kind of, if I'm going to have something, I'm going to spike, and it's I'm going to spike, and then I tend to kind of drop a little bit on the way home. It's always having to try and keep that in check. And of course, if I'm getting home at 1:30 in the morning and then unpacking the stuff, and then I can't. Adrenaline keeps me awake, and very often I'll be kind of awake until 2, 2:30, kind of, because it's, and that causes issues the following day. I mean, I'm 55 years of age now. I'm not 17 and kind of can have 3 minutes sleep and then wake up. Sundays or Saturdays and Sundays do tend to be does tend to be difficult. It's unpredictable mostly, but you develop. The first couple of gigs with the tandem were a little bit strange because you kind of, it was trying to trust,
the technology,
technology.
And how do you find then, obviously, when you're gigging, then, like, do you have any hypos? What do you do if you do have a hypo while you're on? Like, is the technology good so that you can kind of track it, see the trends?
Yeah, I do. I particularly with the T Slim now, and previously when I was open looping, on my Apple Watch, I tend to kind of have it facing that way, so I can kind of keep an eye on. But I've always got stuff on stage. I've always got Coke and stuff, and the guys in the band, and particularly Jo, Funk Mum, we call her Funk Mum. She's really good and stuff, and we tend to, it is full on 2 1 hour sets, and we don't tend to break between tunes and stuff, but she always knows if I need to kind, they can fill out, they can do something and stuff. So it's it's manageable. It's not easy, but it's manageable.
Yeah, you got some amazing comments coming through, Tony, thanking you. Thanks for playing. Thanks, Tony. Like I said, hooray for the 70s kids. And we're talking about them sleepless nights are killers for control. Absolutely. Was there a question from you, Mary or Kez, for Tony in terms of diabetes and his guitar stuff?
Yeah, I was going to ask about going home, and like you were talking about, like, you would tend to go low. Like, I know you've only been looping like a few years, not that long, but you've been gigging for probably a long time. How did you manage getting home? Like, and like, get car stuff to stuff?
I think it's always been, it's always been kind of, I don't know if I've managed. There has been, there have been times when, I'm on stage, and it's kind of like you start to dip, and you're starting to dip, and it's whether or not you're going to reach the end of the set. So you tend to then count the numbers down. And particularly, I do have issues nowadays that I tend to get kind of crampy hands, particularly if I've not done the usual stuff of drinking enough. And so, yeah, it's just, it happens, you know, like everybody who does performance and stuff, you just find a way of getting through it. You know, the show must go on. It's just, yeah. So it's just, it is what it is. It's,
you kind of work out, you have it, like you have your backups and you just throw the situation. Yeah.
Yeah, there's always a glass of Coke on stage. And so, yeah, and if we can get to the end of the set and then I can do something about it. But generally it's okay. As I said, I'm surrounded by really, you know, great friends and bandmates second. It's really good.
Have you ever not made a gig?
I've come close. Yeah,
I
mean,
totally, like you drag your legs to go.
Yeah, I mean, literally, you know, there has been a couple of times over the years when, yeah, I've just ended up kind of playing complete rubbish and stuff, and you know, luckily, people have kind of realised that I'm going. I mean, that's the relationship thing. Like in a band, you've always got people with your back and stuff. And I've always, like work, I've always made people aware of my condition because it's just in everybody's best interest.
Yeah.
I've never had an issue with opening myself up for, you know, that I had this thing and if this happens, you know, sort it, you know, this is how you sort it. Balloon.
I think it's time that we get our balloons. If Claire and Kez, if Kez has one. Kez, do you have a balloon?
I can give you one.
Here you go.
Are you on mute?
I can't believe I've just done that. So I was saying, I think we should get some balloons now. And if you haven't got a balloon, you can wave, Kez and Claire, if you haven't got a balloon. And I think Tony should perform
play some balloon music.
Have you got balloon music? That is silly. You know, it's harder to bounce a balloon in small space, in a tiny space.
It is, because you're trying to get it in the camera view.
You know, this is me trying to keep time and range here.
Yeah.
I couldn't do it in here. It's just chaotic. It's yeah, my little man cave. It's I'd damage stuff.
Oh, imagine if you fell over trying to bounce a balloon, catch a balloon, and then you pull something off the wall.
If anyone's watching on Twitter, maybe take a screenshot of us doing this, because I can't actually do that right now. But Tony, I think you should see us out this section with a song. It's been absolutely amazing having you on tonight to give us some live entertainment, some fun, and I think you should see us out, my friend, and then we will start open forum chat.
I'm going to invent something on the fly. I mean, literally.
Go on. Are you going to sing it as well?
That's to my Irish friends.
Yay! Amazing. Absolutely great. Oh, Tony, you've got so much lovely. Oh, there's a message in response to the balloons. A lovely message from for Joe. Joe, Tony helped me out massively when he was diagnosed in February. Love you, Tony.
Yeah, so Joe's the son of my wife's one of her team, and he was diagnosed
Wow.
Yeah, he was diagnosed at the start of the year and stuff, and it was me who put his first Libra on.
Wow, that is
Because he
great.
didn't have the guts. I'm shopping you, Joe.
I remember my first sensor I put on. I actually, for some reason, it didn't work. So, but thank you so much, Jonny, for coming on. It's been amazing. We are going to now, guys. I'm going to send a link in the chat. If you want to come join myself, Mary, Tony's here, Claire and Kez. This is the open forum now where you can come say hi.
Not for long.
Not for long. But basically, if you want to come say hi, this is your time to come do that. Let's just let's get that slide up. So it is the open forum chat. It is your opportunity. And on Diabetes Chat, the reason Diabetes Chat started was from an idea I had where I wanted to talk to people and connect with people and not feel alone. And Diabetes Chat has really, really grown, and it's so amazing to hear so many stories and people's voices, and it's just been sensational connect with people all over the world. So if you want to come say hi, you are more than welcome to come join this last element of this sensational night. And I'm going to just point you in the direction of this as well. The live draw. If you want to be in the prize giveaway, hashtag Diabetes Chat in the YouTube chat box, and you could win a Captain Atlantis book, a mini pancreas toy, or 4 VIP tickets to the Overtones tour, Good Times tour that is currently in tour, and we will connect you up with the team there, and absolutely will be amazing. So let's have a look. I see Shaun's there. If you want to come say hi, this is your chance to do so. You are more than welcome. So that is up to you. Let's have a look. Let's see who's there. And Shaun has joined us. Hello, Shaun.
Hello.
How are you? I feel like I need a drink.
I think
Any drink.
Oh, Mary's already gone for it.
Mary's on it. Mary's on it. What a fantastic night tonight, hasn't it been? It's been just great fun and lots of awareness. Yeah, it's been really good. What have you enjoyed tonight, Shaun?
I love the bit just from around the world.
Yeah.
I just think the power of that is amazing, and that kind of sums up where we are at the moment, isn't it? I think peer support groups coming together, and as you said earlier, together we're stronger.
Yeah, absolutely.
Really seems to be happening. It's great when you can get people from around the world on the same forum. Amazing.
Absolutely.
You're on mute, Mary.
I thought it was, and what Tina was saying was like to share the stuff, not just the support for tech things, like the how to get your tech working, but like what you're finding about the experience of whatever your type of diabetes is. Like that's the bit we have in common, whatever the type is.
Yeah.
It's the trying to get your appointments, trying to get to your appointments, trying to get to all your appointments, like trying to get time off work to go. Like, do you take that last minute appointment that you offered? Because those kind of things, like they're all the same, aren't they?
Yeah. So many practical bits, aren't there?
Yeah. And asking for what you need, and asking for what you need and being told no. And then trying to I think your chat was Emma and Tim were really helpful in how they talked about the things. It was empowering, actually, what Emma was saying, like that. Know what you go out there, don't waste your 10 minutes, 10-15 minutes with me, me telling you all the stuff. You can find out this stuff.
Yeah.
No, try and find out yourself what's out there, and I'll help you then work out what's best for you.
I thought it was important to ask that question because clearly they're going to have a heck of a job. So, just if people can just know a little bit about it and take a little bit of work out of it for them.
Yeah.
The stats are incredible, aren't they? I think that we've had 45,000 people on pumps in 15 years. So that's 3,000 a year, and now we're expecting to somehow get 60,000 people onto looping in 5 years, which is
150. Yeah, and like isn't it 150, 160,000? Yeah.
There is in total, yeah, but it's just not doable. So anything we can do to help is going to be massive.
Yeah. All right, there's Mark. Was Emma saying like that there in Derby they can put 50 people on board a year, or that's historically what
that's what she said in pumps, didn't she? We've actually put 50 people on pumps in the last year. So, and this is a completely sort of different thing. And
that's 4 people. Is that 4 people? 12, that's 4 people a month.
Yeah, that's it.
Oh man.
So they've set out.
And that's Derby. And that's Derby.
I know.
Man.
But Derby have lost 5 DSN to industry over the last 6 months.
Joking.
5 real good quality DSNs, one of whom was type 1 as well, because Emma, of course, is type 1. So yeah, we've lost 5 recently to industry, just because of conditions in the NHS and what they're being offered in industry. And yeah, so 5 in Derby alone.
Oh, my mouth hit the floor. That's like it's one thing not having enough, but it's another thing losing what you've got.
And that's in a service that Emma is, with her reputation, and you would imagine that people want to work with Emma.
I know, man.
One of them's gone from ours.
Is that right, Mark?
From Ruster's Hall. Yeah, one of our DSNs, one of the pump nurses, has left Ruster's Hall. The one who got me on a pump after 10 years of fighting to get on it. Yeah, she's gone to, I think it's QE.
There's a comment there that Linda's put up, and I think that was one of the questions we kind of asked Partha tonight. That came from Jimmy on Twitter that said, can people living with diabetes support the healthcare professionals to try and roll out the pumps and hypochlorous loop and these sort of things? And I think Partha was quite open to the idea of looking into things, wasn't he, Mary? And I think we'll hopefully see that. I think that could hopefully help.
Yeah.
So yeah, I think watch
he
this
was
space.
talking about like having it's creating trust for the consultants and for the healthcare professionals, trust that we would be able to help somebody. So like it's getting qualification, and so they have to go. They're up. He said he's up for it.
I suppose they were saying though, the people who do the pump training, they're not healthcare professionals.
No.
Yes, they said that too. Yeah.
So it's just thinking creatively, isn't it? Really.
There's a lot of talk about regional hubs and perhaps fairly major regional events, and I think if those happen, I think there'll be people with lived experience will be very much a part of that, because it's one thing having the theory, isn't it? But then these are the practical problems that you're going to get asked about in clinic with people on this, and there's so many different facets of it but I think regional hubs will be an attempt to get as many people educated in one go as they possibly can. They're just looking for any way of doing that quickly.
And so in Northern Ireland, right? So we are behind in some ways, and I'm on the network over here too. So as an adult with type 1, and what Diabetes UK are doing over here is they have wellness hubs. kind of like what Louise talked about there, about like having somewhere to drop in. So there are drop-in sessions that are like dotted around the province, and they are where bits of education will come from, and they'll get to talk to each other. It's for all types of diabetes. It's one part, but the structure over here is so we have a regional pump hub now that buys centrally in Northern Ireland, and it's gearing up, and so all the trusts, there's 5 trusts in Northern Ireland, and each of the trusts they all put forward people for pumps to the pump hub, and then the pump hub order the pumps centrally and have them sent out to the person's house, and then the person, this is for upgrades too, and then the person who does the pump, the person then has online training in a central group. So it could be like with 2 or 3 other people, but from all over Northern Ireland, not just the area, and with one DSN on the call, who's normally got the cameras turned off and is just literally there, like just to be there to answer any question if somebody has an issue. And that means that they can offer all the pumps. And so there's equitable access to the types. And so that has started in the last number of months, and Jonny was upgraded on through the hub too, because all pediatric patients that already are on pumps get upgraded through the regional hub. But all pediatric kids who are starting on pumps, they are basically handheld, with in-person training. The upgrades are only done online. But I can see the benefit of it.
But that said, I remember when I started on my T-Slim, when it came first time to change my cannula and my reservoir, what I ended up doing was following a YouTube video. I mean, I was shown in the hospital, but you know, three days down the line, I couldn't remember it, so I had to watch a YouTube video, and that's why I said in chat earlier when we were talking about pumps, go watch videos. So I was watching a lot of Diabetic and She's Diabetic and Type 1 Talks and people like that, and that's how I learned. Pick the T-Slim, because there were things with Omnipod, as people know, I've got the insulin resistance of concrete, so I have to have a lot of insulin, which is one thing I don't think that pumps really think about.
I saw somebody share the Medtrum Nano today. Was it today?
Yesterday.
Yesterday.
Oh,
and it holds 3 mils of insulin as opposed to.
Yeah, I saw that one at when Claire, Tom, and Rich and I were down at the Birmingham City Ground. I just couldn't remember the name of the company. They look quite interesting, but unfortunately, their CGMS is not on the standard.
It's teeny tiny. It goes on the top of your finger. It's so teeny tiny. But there's
they showed it. They showed, because at Birmingham they were only just prototyping the 300 unit one, but then
it's
again,
really flat, isn't it? Like compared to like other ones, I thought, oh wow, that's really flat. Like for 300 units.
There was one previously that came in all different colors. Was it Kaleido? No, is that what you called it? Do you know what I'm talking about?
Wasn't it? It was Kaleido, wasn't it?
Was it Kaleido?
Yeah, I think it was.
It had all different colors. I'm just thinking, I haven't thought about it for a while, and it was on what was that? Johnsel. Is it Jonsel's video? He was wearing one in his hypo video. I'm just looking it up here just to see if it was it. Yeah, Kaleido.
So I know Tandem are working on a patch pump as well, from what I remember. I think it's called the Mobi. Sorry.
Oh, Mobi. Yeah. That's like a little sports pump, I think. And that's going to be a brilliant pump, actually, because the Medtrim Nano and the pods, like they're pods, and there's one type of set because it's attached to the pod and then it's all stuck in your body. But the Modi, it has a tiny cannula, so you can. Well, I'm thinking that they'll do those tiny little cannulas with all the different sets, like you get steel sets and like different types of ones, Teflon ones, and so it makes it more accessible to people who can't use those Teflon sets or use pods because the set isn't, because it goes in at 45 degrees from an Omnipod, and so it doesn't go in that far, but it goes in at an angle, and maybe you just need to get it to get deeper into the layer of the skin, underneath the skin. So I think that's going to be a great pump for choice for people. That Mobi one. They're getting smaller.
I think it is. I mean, I remember.
Victoria's saying Lodo too.
I mean, I remember a friend of mine who was sort of like into medical tech saying there was an idea once to actually get the pump and put it in your buttock, so it would be eventually just built into the. But he was somebody who was really into medical tech. But how would you charge it? What would happen if it was wrong? It would be kind of like a pacemaker. And could you imagine that at the airports and stuff like that? Not unless you're going to operate on me, you know, with them and their scanners.
Oh, here, actually, Louise put a comment up.
Oh, go on.
Oh, I was just going to say, Louise put a comment that, like with online training, it's better because you can go back to it and rerun it. So
yeah, definitely. So what education on training have you guys had then in your years of living with diabetes? Maybe tell us how many years you've been living with diabetes and what education training have you had, and maybe when you had it roughly. Who wants to kick off?
Well, I'll start. So 25 years and 26 shortly, and I got my first training, first carb counting was Bertie, and it was within 5 years. But I wasn't allowed out from to attend it from my work, so I actually had to change my job to do it. And then that was while I was working in engineering. So that was the first carb counting, but then I couldn't get my pump. So I was diagnosed in 97. I got my pump in 2014. So what are those sums? 97. It was 20. No, I can't do those sums. That's too late. So I had to do a Daphne refresher before I could get my pump. And then that was the last carb counting course I did. Of course, Jonny had choices when he was diagnosed too. So lots of carb counting, and I'm still rubbish at it, really. Kind of still slides.
Do you eat the same sort of food, Mary, or do you have a lot of different stuff?
No, lots of similar food, but lots of variations of similar food. If that makes sense. So kind of a fair
like
amount
a rice dish, but it's going to have different flavors or different meats in it or whatever.
I eat the same amount of the rice, but I might make a biryani, or I might make just like a Thai green curry, or so you're just kind of doing the same rice amount and going whether it has a sweet sauce or what kind of a sauce it has. And then do you do similar, or
can you put a biryani in the air fryer?
Yeah. Oh no, we make it. I make it in. I have a Ninja Foodie, and I'll make it in the Ninja Foodie class.
There you go. I think we kind of just have the same sort of things, and I think we're in a particular stage the last couple of months and stuff that it's just quick, easygoing food, kids food, it's just easy and convenient, and but we do try
maybe bolognese.
You can do boiled eggs in the air fryer.
Can you?
Oh, I've seen them. Yeah, I haven't tried it.
I'd need to speak to the chef, but
in like a bowl of hot water.
No, you just literally put them in. And, yeah. I'll get the recipe.
I get the
like,
recipe.
Real big. Do you know the
Bacon.
part?
Get yourself
Bacon
a
is
double. Get yourself a double ninja, and then you can sync the stuff.
Their
Double
ninjas are
ninja.
amazing. Ninjas are amazing.
Yeah.
They're like they're like the microwaves for the 2020s, aren't they?
Yeah. Oh,
just remember that first thing where you had a microwave and it was just like food.
It's like you're cooking everything in the microwave.
Yeah, literally.
Yeah, no, that's so true, actually. Yeah.
So what about you? What about you then, Kez? What sort of education have you had in your diabetes journey so far?
I think my issue I was only diagnosed in 2019, but then COVID hit, so there wasn't anything. And what I did do, I kind of just found myself, or through like Diabetes 101 or whatever. So, I did things like Daphne, I did Bertie, I self-funded Libra, because even though I was type 1, they wouldn't give it to me on a prescription. And before I could get that on a prescription, I had to do the Libra Academy, which was crazy. And you get a little certificate at the end, which is nice.
I had to do that with Dexcom, so they got a little certificate.
Yeah,
we all like a sticker.
I'd have printed
it off. I'd have been disappointed if there wasn't one, to be fair. But I didn't do well. Ironically, I did the "Are you ready for a pump" training before I'd even done my structured education. So I went to my structured education on a pump, which no one else in my structured education was on, which was great, because then they were talking about things that had absolutely no relevance to me whatsoever, because I was the only one on a pump. So yeah, it's tricky. I think the course they do locally, Katie, is really good, and I still got a lot out of it. I think I was still using Libra at the time as well, which helped because a lot of them were using Libra as well. But yeah, all of my pump startup was all done online. Yeah, most of what I've learned is from the community, really, on where to find things. And I just think my worry going forwards is, if we're getting cancellations in appointments now for a pump clinic, and I started, it'll be 15 months since I had my last consultant's appointment by the time, if they don't cancel it, by the time I get round to that. And that's my first year on a pump and closed looping, and nobody's spoken to me. What's that going to look like when more people are following that pathway?
It was interesting, that they mentioned living in a bubble, and I think to a certain extent, it is a very Twittery kind of thing. I know loads and loads and loads of people who are on pumps, because that's what we talk about. But the reality is that there's loads of people out there who aren't. It's just it's difficult to see the consistency in how we're all kind of like given the same opportunities, and that's the thing. It's almost like a noisiest wheel gets the grease thing. For a lot of clinics, it's just.
Tim mentioned the percentage that, or was it between Emma and Tim? They were talking about when they took a snapshot before the HDL, and I think it was something like 20 something percent, 20, no, 12%.
12%. I was going to say 12.
Yeah, I 12%, and it started in 2008, and yeah, there's Louise said 12 there as well, and it's shocking. And that's not even like, that's 12% of what, like 8-9% of the diabetes community that have access to like a pump, and there are those with type 2 that would benefit from being on a pump, and they wouldn't have access at the minute. But there's also those who are misdiagnosed out there that have diabetes and that are seen in primary care.
Well, that was me. I was back in the 90s. I went to university, couldn't make my pump appointments, my clinic appointments, got discharged, and my professor said, "Oh, perhaps you should be retired now for when when you actually, because you've got so many appointments." So I stopped going, and because I was so used to the old 90s ones where it was yelling at you. And as I said in chat earlier, I still mentally prepare myself to be yelled at when I go for diabetic appointments because of what it was like back then.
Yeah.
And I don't know how many of those. I mean, my training, I was diagnosed in 89, so not quite as long as Tony, but getting there. Apart from getting the training you got in the hospital, that was it. And occasionally, if they said, "Oh, here's a new actual meter, this is how you use that," I was left on human mixed-ard from 89 till about 2010 when I got retinopathy. They realised how bad my control was, and they then moved me on to MDI. And from there, it took about 5 years to get on the carb counting course, and my work was terrible. It was like, you're going to have to work this time back. We can't let you have an afternoon for so many weeks. And I think that it would be good if it wasn't the postcode lottery. So there was one sort of like carb counting course for England, and there were online courses you could go on in the evening and what have you. But that may not never happen. And that was the last training I got from the doctors and from the hospital until I had my pump training.
There's Louise.
10 years later.
Yeah, she's saying her son just got told no for a pump with no proper explanation. It's quite depressing when you feel you can see a solution to avoiding the complications other families.
So no. I mean, I never really.
Surely it's going to change really soon, isn't it? The nice guidance that surely no child is going to be told no at that point. Sure.
And Louise's son is 23, isn't that right, Louise? So he was only diagnosed like a year or so ago.
23.
Louise.
Yeah.
Louise, as I said in the chat earlier, I put a link into the WhatsApp group that Tony and I are part of for the Midlands. Join that, and we'll see. What do you reckon, Tony? We can talk in a better way because the Midlands diabetes groups are awesome. Sorry, but I think it's good, and there's been a few people in the chat tonight, and I just keep on posting it to get people to join, and the more the merrier. I might post it again.
I'm reading Louise's reply. I'm going to put it up. Oh, that's sobering. So yeah, like definitely join that group, Louise, and if anything, your voice will become a bit more confident to push to ask. I remember when I was diagnosed, I was 18, and I didn't know I could ask for anything even, and I didn't know for a long time. Like I wouldn't have had the confidence to speak over a doctor, like, or to say, no, this is what I need. Because they don't have the resources to give it to everybody, so they don't really offer it.
Yeah, and very often you ask for something, even when you have the courage to ask for it, you, like Louise has just said, you don't get it, which is
keep asking. Keep asking.
Yeah, yeah. I mean,
I'm going to say, like, so,
it's part of
sorry,
the it's part of the psychology, though, isn't it? It's a part of the, I think, the emotional stuff, particularly.
Yeah.
You know, us of people of a certain kind of age, of that thing where it was literally turn up at a clinic and feel, you know, extraordinarily guilty and never feeling good enough, and you know, and having your books looked at and you know, told you got to do better, you know, and all of those things. It's impossible to leave for me emotionally. It's impossible to leave that feeling every time I walk into clinic, and my clinic are just, you know, my consultant and DSNs are just the most amazing people. But even still, despite the head saying you're doing fantastic, the heart always, when you walk into clinic, is always, I've never done good enough, and it's just, you know, for people, I think the whole language matters thing has been, for me, the best part of our journey. You know, it's taking that 10-year-old boy, you know, that 10-year-old boy, and telling, you know, those whole questions about if you could tell your 10-year-old self something, you know, it's just that, you know, I'm glad we are where we are now, and with some great HCPs and great peer leaders. It's great. Anyway,
I was going to say, and add to that, like Tony, that because that's building up our confidence, and like we don't have any confidence in ourselves to even pretend we've got more confidence than what would be normal. But when I'm just thinking about what Louise could do, and what we talk about in JDRF and Flipper, you talk about this. Probably the best is about building your case study, or not your case study, but building your case.
Just regulations, having a look at the nice guidance or TA, well, it would be TA now sort of thing on that, just seeing where it applies to you, or if it doesn't. JDRF website, brilliant, because it has a bit from ABCD, which is another professional body that isn't in the nice TA, but they're things that you can build a case around, that you know you might be able to get something on. And have a look where it applies to you. So that if a clinician comes back to you and just, if you just go in and say, I want this, and they say, oh, why? And you say, oh, because my friend's got it. I'm not saying that's what's happening to this lady at all, but that. But if you come back and say, well, the nice guidance says if my HbA1c is this, and I've tried this, and this, and I have done that, and it's still at that, or I know my HbA1c is there, but to do that, I have to do A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, and build a case. And then maybe it'll open up more of a discussion. If you actually are, the TA does cover you, then actually, if they say no, then you've got a right to sort of go back, not in a nasty way, and just say, I'm not quite understanding why you're saying no, because my understanding is I fulfill that one criteria and I only need to fulfill one. And then if again they say no, another thing is after the appointment, email and just say, still not quite clear. Could you put it in writing, please, so I can have a look at it in my own time? And if
it's almost certainly not an emotional decision that's been made by consultant. You know, they need to have that list of stuff to say, yes, this patient, check. And you know, it's not as if your consultant or DSNs are holding this, you know, pot of money and they don't want to spend. Very often it's about check, bang, and it's in its process. And so very often, like you say, it's just about knowing the criteria, and if you fulfill the criteria, job done. And there's a there,
criteria and they say no, Tony. That's what I'm saying. Mostly, if you fulfill the criteria, they know you know, sort of you've said, look, this is why I think I should, and also why I think it will help. Because there's lives where even if you fulfill a criteria, if you actually know, well, actually when I'm exercising, I'm doing this, or where, you know, I look after children and I need to be able to do, you know, there's 110 things. But if they still say no, at that point, I would try and get something in writing, and then I would contact JDRF, because they are brilliant with their advice on getting tech. I'm sure Mary and the others all agree. And if you've got something in writing from your hospital, it's not, oh, well, I thought you said, or she thought you said. It's in writing then. And they may have a very good reason, even though you fulfill the criteria. There might be something in your history or whatever. There might be a misunderstanding, in which case you can clear that up yourself, sort of thing. But it could be which is quite valid, but, you know, just worth it.
They did write, and did they give you in writing back? Everything was saying was in the letter. How did they write it back to you then?
So I had when I did mine, because when I changed consultants, they're all still part of the same trust, but I just changed consultant. So I came out of my appointment and I was like, I don't know what I'm going to do. Like, this is ridiculous. I can't do 12 plus injections a day and they're not listening to me. And I spoke with someone at JDRF, and they wrote out something for me, like with the conversation that we'd had, which was solely based on the ABCD criteria. And they can't not respond to that, because if they don't respond to that, there's time frames for responding to things like that. And if they don't do that, so like here, it would be a PALS complaint because you've not had a response. And then you're kind of forcing their hand in terms of a response. And people don't like putting things in writing because it's harder to argue back again.
Yeah.
But if there's a genuine reason and there's a genuine need and you can make a genuine case, surely that's going to lessen the burden on the consultants, the DSNs, etc. That's just my thought on it.
And there's also my thoughts, like you're saying, some people are under like the ABCD things that aren't necessarily in the tech appraisal. So you haven't got well, when I say a right, it doesn't mean that you can just go in and demand it. But anyway, but if they do say no, if you've told them, like you're saying, Kez, that you were doing so many injections, that's why you could get the results and you just couldn't maintain that, then just pose a question of them, not aggressively also. It's like, well, okay, then what can I do? What can you offer me to help? Because I can't do this. I think this will help me, but you're saying I can't have it. What's the alternative? You know, what alternatives are there? What other approaches can we try? And just
I think that was the difficulty, because where do you go? You know, if you've tried a basal that's got the longest acting profile and that's still not doing anything, where do you go from there?
But I'm saying, if you're asking them, saying, look, this is working, you think that I think maybe will, but you're saying won't, you're saying no. So, okay, what are your alternative solutions? Because if they've got none and you can't carry on how you are, do you know what I mean? Then that said, well, can't I, you know, why don't we, is there a possibility of trying the pump and seeing if it does help or what? Do you know what I mean? It
does sound like Louise is really doing all the things. So she wrote on Wednesday, like after the TA was published, and hopefully they come back to you now in writing on that.
Yeah. And I think at the moment the TA, even though it's literally just out, isn't it? Less than a week. Services are going to take time to read it, consider it, see how they're going to approach it. So, you know, either they've got your letter somewhere but they're waiting to respond, because if they respond at the moment, they know they can't respond fully. But
yeah, and I think they are slow about onboarding people onto insulin pumps anyway. Like, it's not.
It's a lot of work.
I think I was approved in the December. I'm trying to work it out now. November of 2021, and didn't start until March 2022. So
And then you were diagnosed in 2019.
yeah. So the reality is I didn't wait that long, but that's because I was talking to people and having the conversations about, this isn't sustainable. What do I do? Who can I talk to? What next?
I mean, I remember when I got onto my T-Slim, the new consultant said, well, let's try it. Because I was saying, look, I get these hypos in the night. It's annoying. Well, let's try it. I'll schedule you with the pump nurse, see what she thinks. They approved it. That was December 21, and it took till May 22 for me to get my T-Slim. So I was surprised how long it took. But it does take a while. It's a shame. It's not just like they have you know, I don't know if your clinics are the same. They have an Aladdin's cave of all no pens and all the meters and what have you. That doesn't include pumps. They have to be specially ordered in.
I'm just saying
the healthcare professionals' time as well, because they can't just put somebody on a pump and assume they're going to know potential. And I know this is being dramatic, but it's the truth. If you're not taught properly, somebody could do real harm to themselves. So they've got I think most of us, when you first went on, there is a learning process. You know, with my second and third, I set it up myself. I really didn't need the education, but that first time I did, and it takes time getting your basals right and all your different bits and pieces.
Yeah.
So I can appreciate, you know, that there is a wait.
Tony or Mark?
Yeah, Josie, come out, or Joyce. Let's see. Sorry, you're saying, Claire?
I was just asking Tony or Mark to repost the link to the WhatsApp group because it's gone off the end of the.
Oh, let's see. Can I get that?
Yeah, bear in mind it's a Midlands one, so a lot of the stuff we have kind of Birmingham and West Midlands based. So Mary, I don't think.
No, that's not it. But no, Joyce is wanting to. Is she wanting to join? Is she wanting to join your chat or this one? No.
I've sent the link in the chat,
Okay.
Mary. So, guys, we're about 20 minutes till midnight till World Diabetes Day 2023. Hope everyone is all right. It feels like it's New Year's Eve. We should get. Oh my gosh, we should do a diabetes chat New Year's Eve party. No. Happy New Year's Eve. I've just sent a message out in the group. Please let us know how you have found this evening. Have you enjoyed? I've actually turned the lights off now. In relaxing mode.
It was great, apart from the bonehead playing bass guitar.
Yeah, who's that guy? It's really good, really good, Tony. And we had so much love for you, my friend. Everyone was literally loving it, and I'm so sorry, and I apologize for my lack of musical talent.
I'm gonna have to go solo now. I'm gonna drop the band and go solo.
Yes, Tony. Yes, Tony. We'll be.
Well, you got 3 singers, Tony.
You what? Sorry.
You've got 3 singers.
Me, Claire, and Richard could join the band. Yeah, come on, Tony.
Tony doesn't rate these very highly.
What did I say the other day? Couldn't carry a tune in a bucket.
Yeah, that was class. I'd never heard that phrase before, but I laughed.
Well, we wanted to know which 2 of the 3 of us you were talking about.
Yeah, it was just the boys, wasn't it?
Yesterday we met Jay James and the Overtones, and we went backstage and we were talking to the guys. It was fantastic, and And then Richard goes, bless him, and goes, oh, we went to karaoke yesterday. And then Richard turns to me and says, oh, Tom's right, good he is. And then Joe's like, well, you never know, we could be after a fifth band member coming one day. I was like, just laughing my head off, like, nah.
There's Joe.
This is what it's about. Diabetes Chat, bringing people together. Hey, Joe, how are you? All the way from the Philippines. Hello.
Yeah. Good morning. Good evening there. It's morning here, 7:42 a.m. Yeah. I'm thankful for your team to organize this, and I just wonder if I can ask something like a more serious question, like what were the turning points in your diabetes journey? I'm just pretty curious about it, like how it changed you, these turning points, and yeah.
Oh, can I go first? Because I can think of some.
Go on, Philippa. Great question, Joe.
Right. I was diagnosed as an adult and got very little support, really. So I became a bit disengaged. And then my practice nurse at my GP surgery need to go for an appointment because I sort of stopped going and got lost in the system. And I didn't want to go, so I kept cancelling the appointment. She rang me and said, oh, you need to... It's really difficult with work. So she says, oh, don't worry, I can come in early. How about 8 o'clock on Wednesday or something? So then I was a bit cornered, so I thought, oh, I'll go in, but, that'll be it. And I went into that appointment very disengaged, not doing great. And she was so lovely. I love that woman. And when I was saying, oh, I'm not doing that well, she said, no, you are. You're doing fantastically. It's difficult and this, that, and the other. And she was the first healthcare professional that was sympathetic and celebrated what you were doing and ignored what you weren't. And then through her, that was the start of me engaging. And after a while, she was the one who got me on the Daphne course. And it was from the Daphne course that I got on a pump. It was because of the pump that I joined social media, sort of like Twitter and that. So really, she was my turning point. That was me.
Thanks.
Mine was about 2007, 2006. So we just when we realized like that we were going to settle down and think about having kids, and I knew I needed to do something as opposed to just kind of moving along doing the same thing. And it was before then. It was at that time then that I asked for a pump for the first time. So I was waiting for a pump for 5 years. And we've had 2 kids, and it's funny, I laugh when I see the CGM criteria when it came out there recently, and then now the HCL one, where the priority is for those who are planning pregnancies and pregnant. And I wasn't allowed to get an insulin pump because I wanted to get pregnant. And I remember I nearly killed us driving home. I was heavily pregnant, and I could feel hypo. Like I didn't know what it was. Actually, I never had a hypo like it, and I probably only had one since where I could feel the whole half of my head going. Oh, there's Martin going numb and I'm getting a numb jaw, and I'm driving the big truck going beside me. I thought, that's not right, something's not right. And I pulled in and I did a finger prick, and I was 2 point something. I'd never seen 2 point something on a finger prick, or felt that in, like numbness in my jaw. And I just sat. I think I sat by the side of the road for about an hour, terrified. And it was 2007, probably 2006, where I put my name down, and then it was 2014 when I actually got one in my hands. That was my turning point.
I think mine was probably the opposite way round to Flipper's, actually. I didn't really talk to anyone, didn't really know much other than what I'd experienced from having a type 1 in my class at school when I was in primary school. And I was diagnosed as an adult. And I was asking for information, but didn't really know where to get it. So I came to social media, and then it all went from there. And it's actually a year since I've been involved with you guys, so that's great. That's how I met you last year.
I forced you into it, didn't I, Kez?
Yeah.
Sorry.
And now look at us.
Yeah.
But I think I just became my own best advocate, probably is the best way to describe it.
Yeah, there's Martin joined. How are you doing, Martin?
I'm fine. Can you hear me?
Yeah, we can hear you grand.
Oh,
Yeah.
great. I'm ready for bed. I got my gym jams on.
I'm cold. I've got a scarf on.
That's why I was hesitant to come on.
Nobody can see that you got your jammies on.
It's been a great evening.
Joe asked a question about what was the turning point in your diabetes, and I know she's dropped off the call and she's kind of half in, but it's not connected properly. But Kez has answered, Clipper's answered, I've answered. And then he's coughed.
For me, pumping was what changed my life with diabetes, really. 2016, I was offered a pump. 2018, I got the Libre. Then through social media, because I didn't do social media before then, I found diabetes community and found out about looping, and in 2020 I started DIY looping, which I've been doing since then, and it's changed everything. My timing range is between 80 and 90%. I actually had 99% briefly today. But I'm due for a new pump beginning of next year. I've just started Dexcom 1 with an Anubis, so it's working like a G6, and I've found it more accurate than Libre already.
What do you think you'll go with if you had a choice of any of the systems, including the commercial closed loop? What do you think you'd go for?
I would go for CAM APS
with
Dexcom G6 and a Dana eye pump.
Oh, Dana. Ypsomed.
Yeah, I'm on a Dana RS. I'm used to Dana pumps.
Okay, sorry, I didn't know you were on.
I've looked at the other one, and there's certain insulins that they don't supply for. I forget the.
You can get cartridges and fill them yourself for the Ypsomed.
Yeah, that's true. But I've heard because they're glass cartridges in the pump, that there have been some cases where they've actually broken. And the pumps have been damaged, but how often that's happened, I don't know. But I have read reports of that. But I'm used to the Dana eye. I know they're a bit. Dana pumps are a bit fiddly with the cartridges, changing them, and the insert screw and everything. And but it doesn't take long to get used to it, and I am now. So that's what I go for, I think.
So it was technology. It was starting on a pump for you, Martin, that changed. What?
Yeah. 2016, I started on a Medtronic 640G.
Yeah.
Which
did you catch? I'm just thinking, like, because Joe's just joined us back, and so she's writing the things down.
Yeah, 2016, the Medtronic pump, 2018 Libre, that encouraged me to go on social media and try and find out about other pumps. And then I found about looping So I plan to get a Dana RS pump because you can loop with them without too much hassle, which I did in 2020 with a Meow Meow and the Libre 1.
Yeah, that's phenomenal. And what about then?
But,
who's going to go next?
Yeah, I was just going to say, who's next? Shaun. That's Shaun there, or am I imagining it?
I'm here. No, I'm here.
That's I'm on my phone screen and it's like that big on it, and I'm like,
I'm only that big anyway, Flip.
that big. Not that big. I'm that.
For mine was my changing moment was when I got a pump as well, because at the time I've been on 12 maybe 16 years now. At the time, the way that they did it in Derby was you literally got invited along to somebody who already had a pumps meeting. So not only was it the first time I had a pump, it was actually the first time I'd spoken to another diabetic out in the wild as well. So it kind of started my sort of peer support journey off, because I had a pump and I had a buddy for the first time. So we started talking about it, and then so that was massive for me, the fact that I had somebody to talk to. And it was stupid things like, you know, what do I do when I go swimming? You know, well, I give myself a unit and then disconnect my pump and I go swimming. So, and it was daft things like that, you know, that you just like, wow, I didn't think of that. So it was stuff like that that really sort of changed things for me. And then we're lucky in Derby to have Emma, and we've also got a couple of really technical guys, you know, Alistair D Flipper as well, you know, who's big on DIY looping. So that my next stage was DIY looping, which I've been doing now for about 6 years, I think. And same as what Martin said, really, that's just transformative. You have a choice. You can put the same effort in as you did before and get miles better numbers, or you can put less effort in and get the same numbers. So whichever suits you best, you can do. You know, and like Martin, I'm kind of up there in the 80s and 90s. A bit like Tom, I've been high all night tonight. I think it's just an adrenaline thing. But, you know, I mean, my last 7 days in range are 85, 84, 91, 97, 92, 92, 97.
That's
in
phenomenal.
terms of time in range, which, I mean, I'm the sweetest tooth diabetic on the planet. I can't finish a meal without a pudding. So, you know, for me to get those sort of numbers was just unheard of. And
pudding for breakfast, Shaun?
Yeah, that's right. Pudding for breakfast, yeah. You can get nutty bars or you can get chocolate nutty bars. Guess which one I go for?
Love it.
Stories so far.
So yeah, they were the two big things for me. I think the first time I spoke to somebody, and then the loop.
But this,
I say, what you like. That's what insulin's for.
Yeah,
exactly.
Yeah. What did you say, Flipper?
I was saying it's interesting that all the stories so far, most of them, there is an element of peer support and part of a community at the same time, be it the DIY community or just generally meeting people. Like Shaun was saying, meeting somebody in his appointment.
Just one person there as a buddy, you know, made such a huge difference.
Yeah.
And the old Animas pump, you know, and it's just amazing.
Yeah.
So many tips, so many life tips from the two of us. We're still friends now. He's still in the Derby group now, and he's looping now. I've been able to return the favour a bit because I was looping before him, so I've been able to give him a bit of help back. But yeah, mate, that was huge for me.
I think the community is also a healing in some way or another. It's not just a form of encouragement, but also a form of empowerment. And I myself have been helped by others so many times, and I used to think that I was failing. in some ways, and it's through others that have pulled me up and have encouraged me and even believe that I'm better than what I think I am. So I'm very thankful for that support from others. And I'm really glad to learn how Shaun and Martine benefited from technology, and also a good or an encouraging HCP team has been helpful for Flipper, and also advocating oneself for Mary. Yeah, so really amazing.
Amazing guys. I think before we wrap up for tonight's amazing conference, let's try and do this this prize draw. I've never done this on StreamYard, so let's hope it works. Bear with me.
I feel it's out.
Can you see? Oh, where are we?
No. Wait to present. No.
Oh, it's doing something.
Oh, we've all gone.
There we go.
Can you see that?
Yeah.
Yeah.
Can you see that?
Can you see it?
So
Can you see it in the chat, please?
I'm hoping that this will work.
Yes, I can see it on YouTube.
So we have 3 prizes up for grabs. I hope this will
and here.
work. Otherwise,
Don't read out
work.
because there's a delay. There's a delay on YouTube, right? So like nobody shout until like give it a tiny bit. I can tell you when it's on YouTube if you want. Be quiet.
Okie dokie. So we said earlier on today, we have some prizes up for grabs, prize giveaways, Captain Atlantis book that I will post out to you. Mary has kindly, after I said, "Hey Mary, would you make a mini pancreas?" She goes, "Of course I will." So thank you, Mary. And J. James from the Overtones has kindly donated 4 VIP tickets to the Good Times tour. And we'll get you in contact with the My Diabetes Stories team, and they will basically hook you up with some tickets, subject to availability and just on depending if the venue and stuff, but you can talk that through with them. So let's have a look. I'm hoping this will work.
Louise is saying just to do it, like not to delay.
Okay. I hope this will work, and hopefully it will allow me to do 3 draws. If not, I will have to do something magical in the background. So let's go for our first prize. Should we go for the Overtones tickets? Let's go for that first. So hopefully you press the draw button. Can you still see the screen?
Yeah. Go.
Here we go. Ooh.
You're only pressing it now on YouTube, so
here we go. Flip coup. So well done to you. We will, Mary, would you write these down so we can get in contact with these people, hopefully?
Yeah.
Or if you can send the DiabetesChat account on Twitter a message, and we can go from there. Hopefully we'll get in contact with these people. So well done. You've just won the tickets to the Overtones.
Is that Flipper?
Yes.
Is that you, Philip?
Quiet in case it seemed like a face.
Oh my goodness! Well,
do we have to do it again? We have to do it again.
That was completely random. So yeah, are you happy? Like, yeah, do we carry on?
Cheat codes.
I was just going to say, I'm going to wait and see who.
I did not know that.
Who wins the pancreas? Because I'm like,
right. Let's have a look. Or did you want the pancreas one, and we draw the next one again?
No. Do it fairly. Do it fairly.
Okay. Yeah. All I'm doing is press and draw again, and it draws. So Philippa, well done. You got the tickets. Let's go for the Captain Atlantis book. Let's go for it. Oh, here we go.
Lochlan's
Legacy. There we go.
Oh, how nice.
There you go, Captain Atlantis book. I thought that was going to be Philippa again. Now we'd have to redraw. And last one, Mary's mini pancreas that she will make for you over the next couple of weeks, months, and she'll get it out to you as soon as possible because she's so busy. Here we go. It's quite a cool feature, this, isn't it? Ooh. Oh no, we did. As if.
I was wondering if that had happened.
Oh, Tom, I'll make you one.
We'll draw again. Here we go. We'll be here now for the next hour just redrawing. Here we go. Who's it gonna be? Jimmy! There we
Louise,
go. So Jimmy.
Louise, will you message in and I'll make you a pancreas too?
There we go.
You stayed to the end.
Oh, bless. So let's unshare that screen and let's bring all the amazing people back. Bit of fun, eh? So there you go. Flipper, you won the VIP tickets. That was not a fix. That you saw me press that button.
I'm really bad about it.
Lochlan have won the book, which I have right here somewhere. Lost it. It's here. There it is. I will be sending them that.
Is there a contact us on the website?
If you email,
oh, there is.
let me...
There is. I'm going to just put that link into the chat.
Yeah.
See if Louise will message.
Or email. And then obviously Jimmy won the mini pancreas. That's amazing. So there you go, guys. Hashtag cheat codes. I hope you enjoyed that little mini draw. And once you get your prizes, you'll have to tweet out and let us know.
And you can share the WhatsApp group. And I'm just thinking that if Louise emails you, you can share the WhatsApp group with her from Tony and Mark. Is that right? That'd work, wouldn't it?
Yeah, if you email that, because for some reason it won't. Yeah, we can do that. We can sort that out. For some reason, it won't do it through this this thing. What a night, guys! It's been absolutely fantastic, hasn't it? I think we've raised lots and lots of awareness for diabetes, all types of diabetes. We've spoken to people from all over the world, from different perspectives, parents to children. How great were the four guys? They were amazing. And we've had healthcare professionals. We had the tech chat. We had the diabetes art when Santiago and Kez went through some amazing art. We had a celeb chat with Jonny, arrived a bit late, and me and Mary improvising, and he got on. And we had a great,
very quiet chat. Though. It was
I know. I'm not sure why. Apologies again. And then we had the parent chart, which fantastic. I love the guys, and we've been doing things the last couple of years working with them guys, and I just think they're just great superheroes for their warriors. And then we had the global chat. Jean absolutely sensationally hosting that section with Renza and Tino and Jazz, who was up at 3:30 in the morning. And Joe's joined us now. It was really cool, wasn't it? Fantastic. And yeah, it's been really cool. And then Tony did some live performing.
We were rubbish.
Yeah, we weren't that good. John was great. Yeah, good John and the Safeguard Bacon there, didn't he? And our amazing friend right at the end there, Shaun, for doing the Type 1 Derby chat group. I think we've got to know Shaun in the last couple of weeks, a month or so, and I just think they're a fabulous.
Probably longer than that now, actually.
Yeah, and they're a fabulous community supporting people like we are. And I can't wait. I know we spoke briefly, Shaun, and I know we'll continue to work together to help each other out and help everyone out. And it was an honor to have you guys here tonight to lead that session and talking with Emma. And
so brilliant.
It's really good.
Yeah. Can I just say as well, Tom, is it 3 weeks since you and I had that chat and you said, I've got an idea?
I know, yeah.
Wow, you've managed to get this together in 3 weeks.
Have you seen these bags? No, it's been sensational, and a thank you, mate, and a big thank you to Mary, who's literally my right hand wing woman, who's always by my side helping me
I'm
out.
really bad at this actually. Like I'm too clicky at the bottom, like sharing things.
Too happy clicky. Yeah, well, doesn't matter. But I think because you press it and I press it, and then they kind of
remove ad.
But honestly, it's been I wanted to do something for this, and it's been a mad year with everything going on at home and stuff. But I wanted to do something, and I come up with a mad idea, and the team, Philippa, Kez, Gary, Mary, Claire, Tony, have been so supportive. Have I missed anyone? I feel like I have.
What about Richard
and then people like Richard, who is such a fantastic person for the community. So many people, but the team were really supportive in helping put this together. And just kind of, when I said, I put in the group, said, I've got a mad idea. And I thought, oh my God, they're just all kind of like, what now? Like, but they were super supportive, and it's been really good fun. It's been really busy sorting everything out the last couple of weeks. But
and you know, it's been so lovely seeing Kez and Claire and like kind of in such a short time, like, cause like just getting.
I want to type 2 chat.
The type 2 chat, yes.
Yeah, absolutely. And also a big thank you to everyone that's listening. There's still people I can see in our screen now. There's still people tuned in via YouTube or Twitter, I guess, at 8 minutes past midnight UK time. This is the longest one we've ever done. Like our normal Monday nights, we're normally done by 10:30 now. So tonight it's been special. We've done 6 hours. I think we've raised lots of awareness.
Guys, it's World Diabetes Day in the UK now.
Yeah.
Yay!
Happy World Diabetes Day.
Happy World Diabetes.
Happy Diabetes Day.
Tom, you're not going to want me to have to get Gary in to tell you to slow the screen down.
I am going to go to bed in a minute because I am absolutely cream cracking, mate. I'm so tired, and I was listening in the last in this chat, this segment, and I've been going off camera a few times because I've been a bit tired, and I thought to myself, I'm so glad this isn't a 24-hour one because 6 hours in, I'm struggling. Yeah, thank you so much. Thank you for everyone that's tuned in.
Are we finishing with BG Bingo?
Go for it. If you want to share, if you're on a YouTube channel, you can you can send your number should you wish to. There's no obligation and no judgment or anything. If you want to share it, you can. If you're on Twitter, you can hashtag DiabetesChat and post it. Anyone want to kick off?
6.4 for me.
Brilliant. Oh look, I'm loving that everyone's getting their phones. They're going to do the same. There you go.
Larry. I'm a 6, but you can't see it.
8.4.
Oh
wow.
0.2.
Oh, that's good.
Great. Love it.
Oh no, it's gone off.
Screen's gone. Oh, there. No.
There you go.
Flipper. You were low there, Flipper. I was low on high. Oh,
I was
Mark,
low and
well
now
done.
I'm going high, so I think I need to give myself a bit of insulin.
8.7.
Alyssa says 5.3. Hello.
Donny's listening in too, I think, or what? Oh, she's
hello,
still there.
Donny. The lovely Donny. I had a lovely message from her before, and Nikki, bless. Both of them sent me lovely messages saying what a fantastic night. Louise there saying she's on 5 and her son's 8.5. Shaun 10.6. And there we go.
Alyssa 5.3.
5.3. Brilliant. Thank you so much for everyone that's joined in tonight. It's been really cool. Thank you for raising awareness for diabetes, all types of diabetes, and it's been really good fun. Yeah, thank you so much. And next week is an open forum chat back on Twitter Spaces, hopefully. And we'll see you then. But happy World Diabetes Day, and whatever you do, just keep being you and keep being awesome, and do what you can do and raise awareness in ways that only you can decide to raise awareness in whatever ways. There's no pressure, but you raise it in the ways that you want to.
Jonny's 4.0. I just want to say that.
And Jonny's 4.0. There we go. Thank you guys. Hope you have a lovely evening. And if you tune in on Twitter and stuff for tomorrow, send some messages of how you thought the event went, and we'll see you soon.
Bye. See you soon.
Bye. Good
Bye,
night.
guys.
Bye. Take care.
Bye.
Bye.